Ahead and start. It's 8:30. We'll let the other folks trickle in that are going to be here. I know there was some conflicts on traveling to a conference, so I'm not sure who will be here today for sure. But nevertheless, we are here and you are here, so we appreciate that. I want to talk to the conferees. We've got a really busy schedule today. I want to hear, and I think the committee wants to hear what you have to say, but if you could keep it as brief as possible and still get your message across and what you want us to know, that would be great. And committee, I certainly want you to ask all the questions that you need to be comfortable with these subjects. But again, we want to try to keep things as brief as possible too. But again, I want you to be comfortable in asking these questions. That's how we learn, is asking questions. So with that, we're going to start the meeting. Responses to the second quarter, these are written only. Okay, so now we're down to Haley. Oh, Steve. Yep, Steve. Stephen Anderson, no stranger to this committee.
Good morning, Chair Carpenter,
Welcome.
members of the committee. Thank you for inviting me here. I am Steve Anderson, Inspector General. I want to just cover some things right quick with you from my written testimony. I want to point out the number of complaints of fraud, waste, and abuse and illegal acts concerning the Kansas Medicaid program continue to increase each year. We've already received 758 complaints this year with 95, that's 95 complaints higher than last year at the same point. Just by reference, in calendar year 2024, we processed 1,454 complaints. So, and most of those involve eligibility fraud. Our operating budget for this fiscal year was adjusted via a budget enhancement that allowed us to add 3 additional staff members to do Medicaid-related work. We also requested important changes to our statute, which is KSA 757427. That expanded the authority of the OIG to conduct audits and investigations involving the cash and food assistance programs. I appreciate the support of members of this committee in those requests. On May 28th, or May 23rd, 2025, we gave a recommendation to KDHE, this is a shout out to them, not a bad thing, to create a separate web page or centralized location for historical and current summary of change documents for their policies and things. The SOG or SOC identifies changes made to the 2 very important Medicaid policy manuals, the Medical Kansas Economic Employment Services Manual and the Kansas Family Medical Assistance Manual. KDHE prioritized that request. They made some changes for all their SOCs through 2000 through 2025 and put it under the policy and eligibility web page on KanCare's website. It was organized very carefully and is very easy to use, and I really appreciate KDHE taking our request under doing that and putting it out, so it was really good. Our office is finalizing the performance audit of the managed care organization's prior authorization process in Kansas for Medicaid recipients. The audit covers the period of January 1st through 2021 through December 31st, 2023. The exit conference was completed on July the 10th, 2025, and the final report will be published this quarter. We're still going through edits on the report and discussions with KDHE about findings in the audit report. The objectives of the audit were, are there delays in the peer-to-peer review process under each MCO? Are Medicaid beneficiaries being placed in observation status when they should be classified as an inpatient? And is there consistency in how each MCO determines the level of care for post-acute care for Medicaid recipients? We also recently published a new product called an issue brief. It was dated May 27, 2025. Everybody on this committee should have received a copy of that document. It was entitled, Do Kansas Medicaid Recipients Receive Explanation of Benefit Notifications? An EOB notification to insurance beneficiaries allow them to be aware of services their provider claimed to have provided to them. This also serves an important way for beneficiaries to be more involved in the care they receive and to report possible discrepancies. 2 of the Kansas managed care organizations, United Healthcare and Sunflower, do not currently provide EOBs for Medicaid recipients. The 3rd MCO, Healthy Blue, does provide EOBs to beneficiaries enrolled in their plan. At this time, there's no contractual obligation or requirement from CMS that MCOs must issue EOBs to Medicaid recipients. EOBs received by private insurance holders are a major source of fraud referrals to insurance companies. These referrals frequently identify false billings by providers and medical identity theft. Issuing clear directives to Kansas MCOs about providing consistent EOB statements to Medicaid recipients could help uncover fraudulent claims. Some beneficiaries may face challenges accessing care if a fraudulent claim interferes with their current or needed care. When providers submit fraudulently inflated or unauthorized claims to Medicaid, it can lead to increased rates and potentially deny services to Kansas citizens who need medical coverage. By educating recipients on how to locate and understand their EOBs, we can empower them to take control not only of their health, but also their privacy. While one of the MCOs does have this information available on their portal, recipients may not be aware of it or how to access the information. A beneficiary would not know to check the portal if their Medicaid ID was being used for fraudulent purposes. We recommended the following steps: provide clear and precise instructions during enrollment, annually, or during change of MCO for the Medicaid beneficiary to use the MCO's portal and access their EOBs. Update the contract or Kansas statute to require MCOs to provide electronic EOB notification on a per claim or monthly basis. The contents of the EOB should consist of a list of services provided and billed to the health plan, the name of the provider furnishing the service, the date of which the service was furnished, clear contact for recipient services, and instructions reporting suspected fraud. I had also previously briefed this committee about a Medicaid beneficiary who had submitted fraudulent applications for Medicaid and food assistance by claiming to be pregnant. She was deemed eligible for poverty-level pregnant women coverage beginning on March 1st, 2022, due to her claim of pregnancy. Investigation determined that, in fact, she was not pregnant and had supplied a forged letter from a doctor to support her claim of pregnancy and a fake pregnancy test. On April the 30th, Isabel Sanchez entered a guilty plea to one count of making a false claim to the Medicaid program and one count of making false information, which is basically the forged letter. On June 30th, 2025, Sanchez was sentenced to 18 months probation and ordered to pay $5,042.10 in restitution to the Medicaid program. Appreciate your time. Be happy to stand for any questions.
Very good, Steve. Thank you. Committee questions? Representative Sutton.
Thank you, Mr. Chair. I just wanted to clarify, we expanded the three investigators for your office. Did the funding flow through that as well? It seemed to me like there might have been a little bit of a hitch in that process.
Yes, sir, there was. The funding for HB 2217, which expanded our authority, the fiscal note called for 9 FTEs and also $955,000 in funding, and the funding did not happen.
Right.
So we currently do not have funding for those FTEs.
Gotcha. Now, if I could continue, are you able to hire those people with existing funds, or is that something that's going to have to be on the back burner until we can get the money to you?
We cannot hire we do not have room within our budget to hire those people as we currently stand.
Okay. All right. Thank you.
Yes, sir.
Thank you, Mr. Chair.
Any further questions? Senator Peck.
Thank you, Mr. Chairman. So even though CMS does not require the MCOs to provide Medicaid recipients the EOB, you're confident we can statutorily?
It would appear that we could go above that. You know, CMS rules set what the base is. The state can change their contract to make it more, require more of the MCO, but not less. So in other words, if CMS said they had to do it, we couldn't come along and say, oh, no, you don't have to do that, no matter what CMS says. But CMS just sets what the base is, and if the state wanted the MCOs to do it, they could require them to do it by their contract.
And if we did pass that, if I'm reading what you said correctly, or hearing what you said correctly, it would make your job a little easier to find fraud?
It would certainly make our job easier. It would also result in a lot more referrals and allow us, and it also identify potentially fraudulent providers out there. Friends of mine and colleagues that work in the private industry, that they said this is their largest source of fraud referrals is from EOBs. And I know from my own personal experience, we go through our EOBs very carefully that we receive from Blue Cross, and we frequently find errors and problems and call it out. And it's as simple as being billed for an x-ray or that sort of thing that you don't know about. You know, if you're being billed, you see it on your EOB, but Medicaid recipients get nothing like that. So if I'm a corrupt provider, I can be billing Medicaid for an x-ray for you and be paid for it, and you would have no idea about that because you never receive a bill of any type.
Okay, well, Mr. Chairman, that might be one of our recommendations. We'll talk about that another time, that introduce legislation to
I think that's a great idea.
any of it. All right, thank you, Mr. Chairman.
Very good. Representative Bueller.
Thank you, Mr. Chair. So I want to dig in a little more to the question that Representative Sutton had asked. So past 2217 had additional staffing and funding. So can you tell us why or what the reason is that you haven't received or what the process is to stop that funding from flowing to you?
Sure. The fiscal notes were going to be handled under a separate process under the State Finance Council. There were some other fiscal notes that also didn't get funded, and ours was one of them. So we did not receive the funding for that, and consequently, we're not able to hire the staff that we had intended to hire to do that work.
Okay. Thank you, Mr. Chair.
Committee further questions? Seeing none, Steve, thank you very much for being here. Okay, next we have Haley. Welcome to committee, no stranger to committee either. Very good.
Make sure we're all set up and good to go here. All right, you should have my presentation. First off, good morning, Representative Carpenter, members of the committee. My name is Haley Ordoin, and I am here as the State Long-Term Care Ombudsman. Every single time you see me up here, I am going to reiterate exactly what that means and what we do, because most people either forget or don't know. Ombudsman is a Swedish word for advocate. So we are advocates for anyone who resides in an adult care home setting. I specify adult care home because that can include long-term care, home plus, assisted living. The only environment we don't go in is independent living. They're independent enough they can advocate for their own needs. But we come in and we provide assistance, referral assistance, resource assistance, for anyone who has a complaint for abuse, neglect, exploitation, or anything that kind of falls in that realm. We do routine access visits to these homes so that we can ensure that we are readily available for individuals who maybe, have difficulty reaching out to resources. We are not surveyors. I will talk about surveyors here in a minute because it's kind of a hot topic for me right now, and you'll understand why. But we are not surveyors. We're not authorized by CMS or anything like that. So we do not go in and cite deficiencies or anything like that. We do find deficient practices that impose on a resident right, or all residents, and we do coordinate with the state surveyors. So we do have a working relationship there. We also coordinate with Steve's office if there's something inappropriate going on, Attorney General's office. We provide a lot of referral assistance for additional resources of what we do not provide. But I did want to bring a few things to your attention, and just because I have a half an hour does not mean I'm going to utilize it, so you will appreciate that fact today. All right, so moving through our slides. Okay. I skipped 2 there, that's okay. I listed a bunch of the care issues because I wanted you to have some context for what a normal day is in our life and in our environment. We have common resident right complaints, resident care complaints. The third page here shows environmental and non-facility complaints. These are just a few examples. I touch on some of these to give you context. Let's see. Very frequently, just try and put yourself in someone's shoes, okay? Break a hip, okay? Nobody wakes up every day and says, I want to go to a nursing home. I understand the reality of that. I was a previous provider, and in my 15 years, I had one lady call me and say, you know what, today's the day. Can you come to my house and talk to me about this? One in 15 years, okay? It's not common, I understand that. And why? These list of care issues, it's why. So yeah, one day you wake up, you break a hip, you end up having to go into a skilled nursing facility for rehabs. Not everybody has the luxuries of being able to get that care in home. And you run into an issue to say, maybe your kids who you raised, clothed, fed, took to all their activities, decide that this is the opportunity that we know what's best for mom. We know what's best for dad. Okay, and they start making the demands, and they start taking over the control of what your day is going to look like, what care you are going to get, where you're going to go, what you're going to do. That's where our office comes in and says, this is a resident right. They have the right to choose. They don't like this provider, they can fire them. They don't like this therapy company, they can bring in a different one. Maybe someone's trying to take over assets and say, you know what, mom's incompetent. Mom's just been diagnosed with dementia. Well, for anyone who knows much about that, there's lots of levels and stages to dementia, and that doesn't mean that the person goes from, being okay to instantaneously incapacitated. So review the care issues, because I think it gives a lot of insight into what we do daily. But I want to bring your attention a little further down into my presentation. What I want to focus on primarily, if you go past systemic issues, past recommendations, down to this page right here that shows 4. Okay, in my years of advocacy, I've learned not to bring too many issues at once because it kind of waters down the messaging. I like to stick to a rule of 3, but I'm breaking my own rule here and giving you 4, okay? 4 things I really want to focus on, okay? The first being the expansion of discharge reporting requirements. Now, what this means is, in our state, a federally licensed, so like a skilled nursing home that receives Medicare dollars, they are required to notify our office anytime there is a discharge, whether that is facility initiated, or, like to the emergency room. Those emergency reports are sent to us monthly, which is okay. But oftentimes, I would say multiple times a week, we get contacted because a facility is discharging a resident. And there's rules and regulations, state and federal, for what those need to be. However, what we do not have in our state is the assisted livings, the home pluses. They're not required to notify us of a discharge, okay? Many other states do. And in fact, I have a list in case anyone wants to know of what states do and what states don't. Many of our surrounding states do. Why this is important is because oftentimes our office is able to get those notifications and say, this is not an appropriate reason to discharge someone, or there's something bigger going on that the home doesn't either have the time, have the resources, or take the time and resources to investigate, or sometimes it can be wrongdoing on their part too. But we're able to come in, we're able to resolve, we're able to avoid that transfer trauma, or we're able to refer to, say, APS and Adult Protective Service finds that maybe a family member is misusing their funds and that's why the nursing home's not getting paid. We come in and we can actually do the investigation and work to resolve the problem so that in the end, it's what the resident is wanting is able to happen. So if they're wanting to stay, that's what we do. That is not available in assisted living, okay? All we would need for that is language and statutory language changes on the state side to make it that those are sent to our office, okay? I know I'm asking for more work. Yes, that is precisely what our office is asking, seeking to resolve that, okay? So that's number 1. Number 2, something I want to bring to your attention right below that, pharmacy provider choice and fees. I don't know if people are well aware, but in this state, if you are at a nursing home or at a home and you say want to use your local hometown pharmacy, okay? You know what? Tom down the road's always been my pharmacist. He's filled my prescription for 20 years. I want to keep giving him the business. If the home that you're in contracts with, say, a larger scale pharmacy, okay, they're great, nothing disservice to them. If you choose to use the provider of your choice, we have homes that are charging residents $200 to $300 a month for an administrative setup fee for that, because it's not through their primary pharmacy that they contract with. And they're saying, you know, that it takes additional time, additional resources to set that up. So really, it's not a provider of your choice. It's a provider of whether you can afford based on your socioeconomic status. Okay, so it's really limiting that. I have contacted the AG's office. I have contacted Consumer Protection. There's no law, there's no statute that says that they can't. Because trust me, I tried to find one. So bringing that to your attention. The third is the personal needs allowance. That is that $62 a month that anyone that's on Medicaid in an adult care home gets to keep. Put that in perspective. How many of us can live on $62 a month for just extras, clothing, haircuts, you know, anything that's really not covered? Yes, you might have your basic needs covered, but anything beyond that, cable, you know, for someone who's maybe paralyzed, that's their only reach to the world, internet, you know, computer, any sort of upkeeping, $62 a month. So we ask that you consider raising that. The last thing I'm going to focus on, and I saved the biggest for the last, is the increase of KADS surveyor staff. And here's why that's important. I believe last recently reported was that our state, and this is a question for KADS as a follow-up, I believe that we have a 50% occupancy rate, like empty, right? Like I think we're half-staffed on our state surveyors for nursing homes. Okay, why that is important to us. We come in and we resolve as long as both parties are willing to come to the table and resolve. I'm not sitting here saying nursing homes are terrible, all are bad. Some of you that have known me long enough know better than that's the message I'm portraying. I'm not. But we do have some. There's good and bad in everything, okay? There's good and bad in providers too. There's good and bad in employees. There's good and bad in the entire world. What we face is when we get to the point where we try to resolve things or there is obvious wrongdoing, abuse, neglect, exploitation, okay? That home is no longer playing by the rules. They're no longer playing to reach compromise, to reach resolution, and we've had some flat out tell us that. That is where we call the state surveyors, or we report to their hotline and say, listen, this home is doing this deficient practice. We've observed this. We've tried to resolve this. Excuse me. It is beyond our capacity now. This is where you need to come step in. If they're not at full capacity to be able to do so, it can take way longer than absolutely necessary for them to come in and investigate. And for something that I think is an important issue, they have their own triage system, and that is, you know, from CMS, they have their triage of how soon they're supposed to come in and resolve something. But I can tell you right now, it's the little things that add up. It's something that's maybe not big right now, but left unattended to, it gets bigger, it gets bigger, it gets bigger. And this is where you'll see in the front page of the news, you know, nursing home residents are left to die and the state never showed up, okay? It's not always the big cases, it's the little things that turn into big cases. It's the little things that we observe daily that we feel and we can see where it's going to turn to. So we would absolutely love to work together and provide any sort of feedback of what we can, of what we're seeing when it comes to that side. Whether the resolution be increased funding, I know some of that has happened. Different expansion of surveyor types, I believe, I reserve the right to be wrong, but in our state, you have to be an RN. I think we may have expanded that to LPNs in the past, but I do know other states have been able to make this work, and they've expanded it to include audiologists, therapists, licensed nursing home administrators. They have a multi-diversified team for their surveyors to expand the population of which they can hire from. Maybe that's something that we look at and consider. Bottom line, we need to hire more state surveyors to come in and hold these homes accountable. You know, I have a dear friend that told me boundaries aren't set, you know, to limit things. It's to protect what you love. And those regulations are the boundaries. But if we don't have anyone there enforcing those regulations, what incentive does anybody have to follow those rules? What incentive does anybody have to do the right thing when there's no consequences? Okay, and that's what I feel like what we are seeing and what we are experiencing. So I wanted to bring those 4 things primarily to your attention. I did also, towards the end of my slides, last time I went through the wonderful effort of providing you my beautiful team and putting faces and names to areas. However, I didn't attach the map and the description of who was in what areas. So you now have that for reference, so you can see who is your ombudsman and in what area. And I attached this also because our team is very dedicated to who we serve, and a lot of those people are your same constituents too. So we happily invite you and welcome you that if at any time you would like to come along with us for a day in our life to experience and see what we see, the good, the bad, the ugly, I leave that invitation wide open. My contact information is on there along with our team in your region. And with that, I am happy to stand for questions.
Very good. Committee questions? Senator Petty.
Thank you, Mr. Chairman. So, Haley, thanks for being here today. I'm looking at your team. So in Region 2, you have an open position. Is that correct? You just have
Yes.
Stephanie?
Yeah, the dark green of Region 2, yes.
You, on your recommendations, when you were talking about the KADS, I kind of got stuck on the very beginning. You said something, I wasn't sure whether you were referring to them having a shortage of positions filled, because you said something about 50% of positions unfilled. So are you talking about unfilled positions? Are you talking, or is it dual in that unfilled positions, but also you think your recommendation includes an expansion? I would say there's a shortage of audiologists, so I'm not so sure that would be an area.
No, what I am stating is that it is my understanding within KADS, their state surveyors is currently, they have a 50% vacancy. So if they have 100 positions is what has been deemed to be the capacity that they need to, you know, come in and handle those complaint surveys, to do the annual inspections that should be occurring, that they only have 50 in that reference that is actually filled. So they have now double the workload for the individuals that they do have hired, which brings concern to their capacity.
Right, so that becomes a, you know, I mean, we have other government areas where we have a shortage of employees due to a variety of reasons. It could be salary, but, so I just wanted to clarify that. So it's 50% you're saying 50% of the positions are unfilled. So if those positions were filled, then that would be, would help to cover those
Possibly, yes.
surveyor positions. Thank you.
Thank you.
Committee, there's a reason I hesitate here a lot of times before I look at you. I've worked with all of you as representatives and senators and everything else, and I try to make sure that I call you by the right name. But so instead of calling Senator Petty, Representative Petty, I think about it first. So Representative Buehler.
Thank you, Mr. Chair. I have 2 questions. So of the 4 recommendations that you had, or I guess challenged us maybe to work on going forward in the future, is there one of those that is top of that list of the 4? And the second question is back to Senate Bill 88. I'm curious about the long-term the training for dementia and Alzheimer's that we talked about, because you did say, or you recommend that to be expanded to all medical service provider types. I'm kind of interested in what that recommendation looks
Absolutely.
like. Two
yeah.
questions.
No, I love it. Thank you so much for asking. For the first part, absolutely. I saved the biggest one for the last. That's my top one. We really need those surveyors expanded. We need to find a way to develop that workforce, because the reason I'm advocating for that so much is like I said, we come in, we do what we can as long as people are willing to work with us. It's holding those accountable who aren't. So that's number one. We need to find a way to expand that team and that group. And I'm not coming in saying that it's negligence on KDAD's behalf. I don't think you don't have incompetent people running that, and it's not a lack of leadership or anything. I think it's resources, capacity that needs to be brought to that. The second part, yes, Senate Bill 88 with us just starting here in July, that is on our agenda here for our quarterly training for our staff, for our team. So we have reached out to a couple different resources. I am a certified dementia practitioner, so I am technically, I have the criteria to be able to teach that to my own team, but I'd like to bring in some additional resources for that training, for expansion. But yes, one of those recommendations is to expand that to multidisciplinary services. Another thing that we tend to see is homes, and that's another bill that you have. I don't have the number with, it's listed on my recommendations too, for criteria for certification of those memory care homes. People use memory care as great marketing and then don't deliver the services. They don't understand the different stages of the dementia, things that go along with it. And what we get called for often is there is actually state language that says, you should do an assessment to make sure that you can meet the needs of this person prior to admitting them. With dementia precisely, we get calls all the time where someone was admitted with a dementia diagnosis. That's why they got admitted. And now they're turning around getting discharged because the dementia has progressed. So that's where we say, your EMTs, primarily the caregivers too, we think that should be expanded to them for the criteria that they know, because they are the ones actually providing that care on the day-to-day basis. We can come in and we can advocate, we understand the communication, but as I've said before, we cannot push a wheelchair, we cannot give direct care. So it's really, in our opinion, the people that are giving the care on the day-to-day basis that really need to be understanding the disease and understanding the variances of how that should change person to person.
That's helpful. Thank you, Mr. Chair. Thank you, Haley.
Thank you.
Any further questions? Representative Ballard.
Thank you, Mr. Chair. I appreciate it very much. You mentioned the scenario in terms of who decides it's time for mom or dad to go to a nursing home. Okay. Who is actually registered with the nursing home as the payer?
Okay, so it gets a little hairy, and it gets a little it gets muddled, because technically it should be, unless there is court documentation that states otherwise, it should be that resident. It should be that individual. So if you have, a durable power of attorney, each one is very individualized. Some of them take place the minute they're signed, others not until this person has been deemed incompetent in a court system, not by one doctor, two doctor, but through the court system. Those are the documents that should be honored. Part of the Universal Guardianship Act that was just passed this last legislative session, we're excited about that because that gives more levels of individuality. But it should be with that resident, and oftentimes it's not. Oftentimes it's someone else signing in this resident, admitting them against their will. We run into that a lot.
The reason I asked that question is because 2 years ago, I was working with a person who actually did not want to be there. And mom decided she was going to get her own attorney to do it. And they proved, number one, that she did not need to go, that she could stay in her home. What she needed was home care, some services to come in. But why then, if that's acceptable, does a nursing home continue to allow a family member to do that without having proper documentation?
I would love to know the answer to that too, because that is something that we experience daily. I have assumptions, and I'm not going to openly state them, but we run into that a lot, to where we have said, and we've helped people precisely like that, to where we say this, like almost we deal with illegal discharges or invalid discharges. We have invalid admissions where people are admitted against their will, where they have been duped and tricked. I don't like bringing all the terrible scenarios, but welcome to my daily life. We've had individuals where, hey, farmer, let's go check your crops. And they've met a Homes van out in the middle of a field and admitted them from there. And guess what? Dad was now in a nursing home. I mean, these are real people. And then they get in, and some contract with attorney firms to do an immediate temporary guardianship. Another reason I'm so thankful for the guardianship law coming in. We still have a long several months until that comes into play, but we have people that come into a hospital with just a bad case scenario for health, delirium, UTI, things like that. And before we are even contacted, we've had attorney firms swoop in and they have temporary guardianship, temporary conservatorship. And before this all gets resolved, homes sold, assets are sold, bank accounts are drained, all sorts of things. So I understand I'm probably really starting your day on a terrible note, and that is not my intention, but this is why I'm really passionate about what we do, okay? Because I don't want that to happen to me, to somebody I love, and sometimes it's the people that they thought loved them the most that are doing this to them. So that is why I feel like our office is very vital for coming in and supporting these individuals and connecting them with the right resources, connecting them with attorneys, attorney firms, DRC, Disability Rights Center. I pray that they can keep their funding because they are a huge resource that we refer to for primarily situations just like that.
Thank you. I'm going to switch on you. Surveyors. Why is there a shortage of surveyors?
Again, great question. I don't know all of the answers. However, my understanding is that pay is a situation. I will say too, it's not exactly the easiest job, and they're traveling a lot. They are away from their families a lot. Yes, they are regional, but when they come in and they do a survey, oftentimes it's 3, 4, maybe more days to do the annual inspection, the annual survey, and they're staying local, they're at hotels for that. So there's that part of it too. And I believe also that part of that is that they are hourly staff and they can reach that capacity, you know, by Wednesday for their inspection teams. So, you know, if they're staying late to do their survey and get their time in, you know, 3 12-hour days, you know, they're pretty darn close by the time you factor in travel too. So I understand that that has been a reason for limitations also.
Thank you very much. In terms of what I asked, there's a pay problem, there's a time problem, there's an hourly problem, and they spend a lot of time travel. I have my answer. Thank you.
Thank you.
Excuse me, my colleagues, other than that, it's a great job.
Yeah.
Representative Sutton.
Thank you, Mr. Chair. I think you set us off on a perfect note, Haley. This is fantastic. I want to dig in a little bit more on this ask on the pharmacy provider choices. The setup fees of $200 or $300 a month, is this anecdotal or is this across, or do we have more information on where this is happening? And
I
love to get it.
I have information on where this is happening. Yes, I very much do. And I'd be happy to work together to coordinate that with you. But I can say it is statewide. It's not one versus another. It's not nonprofit versus privately owned. It's expansive across the board.
Right, and that $200 to $300 fee or setup fee, is that being charged to Medicaid, or is that out of the pocket of the patient?
Yep. It's out of pocket of the consumer. So legally they cannot with Medicaid. But
That's why I was
I
asking.
can tell you right now, it does. They do it for people with the VA. We've had homes that if they choose to get their medications through the VA, they still apply to that $200 to $300 charge.
Interesting.
We think so
Love to
too.
get a little bit more information on that one.
Love to provide that to you.
Beautiful.
Thank you.
Thank you, Mr. Chair.
Very good. Thank you, committee. Further questions? So, and I appreciate these recommendations here. And what I hope is that in this next legislative session, you will also be part of the solutions.
Absolutely.
I always hate it when people dump a bunch of problems on us that they don't have solutions for. And I'm more than willing, and I think this committee is too, more than willing to work with you on these solutions. I have dealt with several of those, one being the pharmacy deal. The excuse that they used for me was that the local pharmacy has to be open 24 hours. And that's a huge excuse that they used to not deal with the local pharmacy. So I'm very familiar with the situation that.
One word, well, two words, e-kits, emergency kits.
Right.
I survived in our rural area utilizing them with our pharmacy that wasn't open 24/7. So there's solutions.
are.
I'm happy to work with you to find them.
Very good. And as far as the surveyor staff, we're going to have a interim committee here a couple of days here later on this year. I'm not sure which time frame it's going to be, but I would hope that you would participate in that. And this interim deal is not a, gotcha type of deal. It's looking for solutions to our surveys. Our surveys, we've been understaffed in that for a long period of time. And it may need exactly what you said. We may need to lower, they may not need to be an RN or a LPN or what, we just don't know. But everything should be on the table to get our surveyors. And one of the things that I think is critical about that is lack of training and one of the things that has brought this to my attention was our use of IJs, immediate jeopardy versus, corrective actions and stuff like that. And I believe some of that is caused because they just don't have the training to know what an IJ and to be, I look at it when the nursing surveyors go in there, how can we help you versus how mean can we be and what can we find? We all need to be on the same team working for a common goal. And so that's kind of the deal that I hope you'll participate in this. And I think KADS will probably talk about your vacancy rates when they get there and some of the issues too. But it's on the radar screen. So any further questions? Very good. Thank you, Haley.
Thank you, everyone, for your time and attention.
Okay, next we have KDHE updates and quarterly reports. Derek, virtual. Derek, are you there?
Yeah, can you hear me okay? Can you hear me okay?
We can.
Okay, thank you. I'll let Allie get our slides posted there. Thank you. Good morning. Dr. Derek Totten, Chief Medical Officer with KDHE, coming to you remotely from Colby, where I maintain my clinical practice this morning. I'm going to present to you this morning on our measles outbreak that we're experiencing in Kansas, and then we'll turn things over to Deputy Secretary Osterlund. Next slide, please. So looking at the measles cases in the United States over time, the preliminary number for 2024 had the U.S. at 285 cases. Excuse me. At the time, that was the most reported since 2019. As of July 1, when this deck was submitted, the CDC was reporting 1,267 measles cases nationwide. Since that time, CDC is now reporting 1,288 cases, which surpasses the 2019 numbers, officially making 2025 the most cases reported in the era of measles elimination since 2000, which is also the most cases we've seen in the United States since 1992. Next slide, please. Here, the cases have been identified in 38 different jurisdictions, with the most cases occurring in Texas, New Mexico, and then here in Kansas at number 3 right now. There have been 27 outbreaks. An outbreak is defined as 3 or more related cases, and those are reported all in 2025. 88% of the confirmed cases are outbreak associated. And for comparison, 16 outbreaks were reported in 2024, and 69% of the cases are outbreak associated. And what that means is that the vast majority of the cases we are seeing in 2025 are associated with these large outbreaks. Next slide, please. Looking more specifically at the case makeup, most cases are among school-age children, accounting for 37% of the cases. Adults have the next highest proportion, but keep in mind that accounts for a wide range of ages here. So the significance of the less than 5-year-old group should not be discounted by any means. 92% of the cases have been unvaccinated or unknown vaccine status. And this happens with the unknown vaccination status if there's a lack of records or if an individual is lost to follow-up at times. Of the cases, 155, at the time of the submission of the slide deck, 155 had been hospitalized, and most hospitalizations are occurring in that less than 5-year-old age group. Unfortunately, there have been 3 confirmed deaths associated with this measles year. Next slide, please. Now, for Kansas data, this data has also changed since the slide deck submission. As of yesterday, we are seeing 89 total cases in Kansas, 86 associated with the outbreak, and still at 11 affected counties. But keep in mind, these numbers are preliminary data, and we could see changes after final review of the cases takes place between KDHE and CDC. Next slide, please. Looking at the demographics of our cases reported so far, most are among white non-Hispanic individuals. The highest number of cases reside in Gray County, followed by Haskell County. Most of the cases are in that 0 to 4 age group, but if you condense the school age children age groups as CDC does, you'll see that percentage-wise, we have many cases in that 5 to 17-year-old category as well. So we are seeing that roughly 80% of our Kansas population who's affected by measles are children. Next slide, please. And then last slide for me, most of the time, local health departments and KDHE investigators are able to figure out where a person with measles was while they were infectious to others. If it happens to be a location where there are records of everyone who was there, a doctor's office, for example, investigators will work with the facilities to identify people who were potentially exposed and notify those people of their exposure. If the infectious person went somewhere public and identifying everyone who was there isn't possible, then these locations require a public notification. Currently, we have 1 public exposure location listed here, which is also available on our measles dashboard, but that means that we haven't been able to identify and notify all the contacts exposed directly. And with that, that includes my portion of our presentation today, and I'm happy to virtually take any questions for you.
Very good. Committee questions. Senator Petty.
Thank you for that presentation about the measles outbreak. Could you tell, I know you mentioned that we've had 1 death in Kansas. Is that correct?
No, ma'am. That's between Texas and New Mexico. They've seen those 3 deaths.
Okay. And we still have an outbreak going on in Kansas. What do you have any information on what this is costing the communities and the state to deal with the outbreak?
Yeah, I do have some information here that I can share from our team. So when they previously reviewed outbreaks in the United States between 2001 and 2018, the average cost, the median cost was $152,000 per outbreak, and the median cost per case was $32,805. For a contact, not a case, it's $223. So applying those estimates to our current Kansas counts, that actually would put us through the middle of June, that'd put us at about 2.6 million.
And when we talk, thank you, when you talk about that cost at 2.6 million, that's cost total, is that total cost like loss of work time and the impact for the communities dealing with the measles outbreak?
Typically, yes. I don't have that much of detail sitting for me right now, but I'm happy to take that as a follow-up to get that level of detail for you.
And I forgot, but do you know how much money is, how much funding is actually available to assist communities when they have a measles outbreak?
Yeah, so the notes I have from our team indicate that there's no dedicated federal or state funding for a measles response. A federal cooperative agreement, the Epidemiology and Laboratory Capacity Cooperative Agreement, provides funding for vaccine preventable disease outbreaks response for $330,000. And that includes some salary for epidemiology, part-time microbiology, some limited travel and supplies. But if there's more information you're wanting there, I'm happy to take that as a follow-up as well.
I thought we had in our state budget some funding for communicable diseases.
That I am not able to speak more on directly with you. I'd need to follow up with our epidemiologist and deputy secretary, but I'm happy to take that as a follow-up as well.
I'll ask that question when that time's available. Thank you.
Any further questions? Representative Bryce.
Thank you, Mr. Chair. Thank you, Dr. Trotter. I had a quick question, Dr. Totten, I'm sorry. Had a quick question. Do you have any epidemiology data on the undocumented migrants, maybe across the southern border, the rate of vaccination or lack of vaccination, how that might relate to spikes in some of the measles cases, and whether there's any relation to, I just don't know. I would assume the undocumented migrants might be unvaccinated for the most part. Does that playing any part in the spikes in cases? Thank you.
Yeah, thanks for the question. And that's honestly, that's difficult to answer because of there's so many unknowns with that information. Yeah, what I would tell you is historically when an individual travels outside of the United States, we do recommend immunizations at earlier ages because of the increased rates of measles at those types of locations. But that is still a question that CDC is looking at, in addition to the genetics and how the transmission is taking place with this current outbreak. I'm sorry, I wish I had more information for you on that question.
Okay, thank you very much.
Representative Ballard.
Thank you, Mr. Chairman. If we go through the middle 90s through the middle of 2000, the state did a big push on immunizations, and it was a campaign, and I think that helped a little bit. But what we found out is that there were so many individuals, American citizens, that actually were not getting their children vaccinated as they had been previously. And that contributed a lot. But when we were talking a little bit about the funding, the House did funding social services budget itself, $1.5 million. And part of that was due to the tuberculosis outbreak, which continues to be one. And then shortly after, we heard about measles. But the Senate did not approve an amount, and we settled on $250,000. During the negotiations of both chambers, that money was removed so that we did not have an additional money to deal with this crisis. And yet both of them are continuing to increase. And I would simply say, part of why we put it there is because we were aware in social services from the testimony we got that it was a problem and that it would increase. And it has indeed done just that. Thank you, Mr. Chair.
Any further questions? Senator Petty.
Thank you, Mr. Chairman. And this is just a follow-up to the earlier question from Representative Bryce. So in those communities where we have the highest measles outbreak, do you have, I know we have this information by counties of the immunization rate. Do you have the immunization rate for those counties?
Oh, I'm sorry. That's I could easily get that for you, and it's not something I've committed to memory. But yeah, it's broken down by school districts in those counties. But that's something I don't have committed to memory, but is easy to get you that information.
And I think this just goes along with what was mentioned by Representative Ballard, is that particularly I mean, we're seeing that our immunization rate is not improving, it's going down. And this measles outbreak is just an example of that. But I know in some of our communities in Kansas, sadly, our immunization rate is really at a dangerous levels when it comes to the safety of children and families. So I would agree. I think we need to be looking at everything we can do to assist with that educational piece.
Agree completely. Thank you.
Committee, further questions? I just have a question very quickly. I just find it hard to believe that, I think, didn't you say that each measles case was $230,000?
I agree. The number was shocking to me as well. And that is data that was handed down from, like I said, I think it was, I have the dates here. They took a look at 11 different outbreaks over about 17 years. And that was the numbers they extrapolated from that information. And of course, like for us, that's an estimate because each case is different. And there's a variety of factors that go into that, but yeah, that's simply data that basically epidemiological data that was looked at over about a 17-year period since the United States had declared measles eliminated.
That just seems pretty high. When I was a kid and had measles, it was 2 weeks out of school, and yeah, and that was fun. So anyway, thank you very much for being here, Derek.
Thank you.
All right. Next, we have Christine, and no stranger to this committee whatsoever.
Good morning, Chairman and members of the committee. Christine Osterlund, Deputy Secretary for Agency Integration and the State Medicaid Director. We need to go to slide 9. I think this is on 26. Yeah, it should be the same slide deck that we were just in. Oh. Okay. All right. So the first thing I'll cover, and if it's okay with you, Chairman, after I finish each topic, I'll pause to see if there's questions. Okay. So this is a continuation from, I know, a conversation that was happening prior to last session and during last session is some of the challenges around sedation dentistry services. I do want to acknowledge that the legislature last year passed an increase for a code G0330. This is a code that was for facilities where sedation dentistry and dental procedures would be performed under anesthesia, like in an ambulatory surgical center or a hospital. So this was a really pretty nice increase for those facilities that were offering their space for these services to be provided. The legislature also just increased reimbursement in general for dentistry service, which will touch a little bit on some of these more complex procedures, and we worked with Oral Health Kansas and the Kansas Dental Association to implement that rate increase. Where the challenge still lies, and it's something we're still working on, is in Kansas, there are a group of folks that do the anesthesia for sedation dentistry, but they're mobile. The way the code structure is set up, and this isn't particular to Medicaid, this is just the reimbursement codes, they really haven't caught up with this concept of mobile sedation dentistry. So the anesthesia codes that they use would take into account that this is just I'm in anesthesia, I work and practice in this space, and I'm not traveling around the state, I'm not bringing my own equipment, I'm not doing all those extras that come with mobile anesthesia. So we've been working with these anesthesia providers to try to find codes that would potentially give them some type of a rate increase. We have found, it's up to 2 codes now that we think we have found that these anesthesia providers bill for, but what we're trying to extrapolate from that, if we do a rate increase, what other anesthesia providers also use these codes. And again, not that I'm ever opposed to a rate increase, but want the legislature to know, because right now there's really not a code that is specific to just mobile sedation dentistry providers, and that's really the challenge. We're also looking at, we've identified, I believe it's in Montana, they're using a modifier on a code that tries to kind of get at maybe some of the additional expense that these provider types encounter. So we are trying to understand better that modifier, what could potentially be the rate with that modifier to see if it will work. But more to come, but our commitment is that we'll have, recommendation that we can share with these providers prior to next session. So hopefully we can address kind of this just nuanced service, which is a great and innovative service that we do want to continue in Kansas, because I think it does deal with would create a shortage if it had to go away due to cost. So I will pause there.
Very good. Committee questions on sedation dentistry. So I have just a real quick question. So in this adjustment to this code and the cost, how would you adjust that in your budget? It would be part of the state plan?
Yes, it would be a modification to the state plan. I mean, obviously, if you allocated the increase, then yes, we would do a state plan amendment to make that happen.
And the only reason that I bring that up, committee, is because we passed that bill last year that talks about all these modifications throughout the year that will be approved by a committee from the LCC. So these are the kind of things that we're talking about when we talked about that bill and how we do this. We will meet, if they come to some kind of agreement, the committee will meet and go over these increases to the state plan. So anyway, yeah. Representative Sutton.
Thank you, Mr. Chair. That was 2440, right?
2240.
2240. Okay. I've slept since then.
Yes.
All right. Thank you.
Committee, further questions? Seeing none, on to the next one.
Okay. The next couple slides are going to be around some of the follow-up on the CHIP discussion that briefly happened in the last Bethell committee. So one of the things that we were asked for is to look at the number of CHIP children compared to just the overall Kansas child population. Did want to point out that these numbers for the Kansas population are not KDHE numbers. We don't track total number of kids in the state, but roughly looking at calendar year 2024, if you did 19 and under, there's just under 800,000 children in Kansas. 84,000 approximately are on CHIP. Of course, Medicaid and CHIP enrollment each month fluctuates a little bit, which is about just under 11% of the Kansas population is on CHIP. Did want to point out, we didn't include this in the slide, but if you combine Medicaid and CHIP together, that does represent roughly around 300,000 children. So at that point, we would be a little bit less than half of the child population in Kansas would be either on Medicaid or CHIP. Next slide, we were asked some questions around what do we do to promote or outreach on the program. In kind of the most passive side of it, we do have a fact sheet and some charts on the KanCare website. But probably the biggest push is we do have staff from the Kansas KDHE that are outreach staff. They are located out in various communities. They help members, very specialized members around some eligibility, but they will go to a lot of community events to answer questions about Medicaid and CHIP, promote the programs. Our managed care organizations also support that effort and do a lot of outreach at the local levels to try to, again, educate and inform folks about both programs, Medicaid and CHIP. And then we also work with a variety of community organizations, provider associations, interested stakeholders to spread the information in the communities. I will say that as we went into the unwinding, and folks, as you remember, hadn't done re-enrollments for 3 years. I think the coordination between KDHE and some of these local community stakeholder groups was really formalized, and I think an excellent working relationship was developed that continues today, and so we still kind of use that network of organizations and stakeholders to help get information out to the public and inform them about Medicaid and CHIP. And with that, that is the end of the CHIP side of it.
Committee questions on CHIPS. Senator Petty.
On the CHIP and Medicaid, I know that your testimony says that, and I actually just went to the website, that there's a table. Is that table, or will it be updated concerning any impacts from the federal level?
Oh, yes, with the reconciliation bill or the OBA bill that was just signed. Yes, yeah, as we finish our analysis of that bill, yes, we will be putting information out on our website as that is finalized.
And just to reiterate, so when you mentioned that we have about 11% of our Kansas children are on CHIP, and then when you take CHIP and Medicaid together, that's almost half of our.
It would be probably in the low 40% would be, I'm not a mathematician, I cannot do it in my head, but looking at the numbers, probably in the low 40s. Again, probably some months a little higher.
Thank you. Or on CHIP or Medicaid, thank you.
So just to clarify that, that means their parents are on Medicaid.
No, not necessarily.
Okay, so
yeah.
then how are they on, why aren't they on CHIPS and they're on Medicaid?
So CHIP is for children only, so parents cannot be on CHIP. When a child, they apply on behalf of their child, it's very common that the parent will also apply for themselves, but there's different income thresholds for the two programs. For an adult, we call them caretaker medical adults. So an adult with a child, to be eligible for Medicaid, they have to be at 39% of the federal poverty level or below. So a family of 4, that's about $23,000 a year. If the family makes more than that, the parents are not eligible. The threshold for the child is significantly higher. It's 100% of the federal poverty level. So in many cases, you have a child on Medicaid and there's not a parent or a caretaker that's also on Medicaid, which is why there's such a differential. Right now, our caretaker medical, we run about 38,000 enrolled, and our number of children enrolled in Medicaid and CHIP is around 300,000. So that really shows you the differential between those populations. Now, again, caveats would be if the parent is disabled, they could be in the disabled population if the parent was on an HCBS waiver, so there could be exceptions to that. But if you just kind of say everybody in the household is healthy, that's kind of the differential between those numbers.
Why wouldn't they be on CHIPS and Medicaid? What would be the difference? The child, the difference between CHIP and Medicaid is the income level. So CHIP picks up right past the Medicaid threshold. So we'll screen them for Medicaid first. If they don't meet that 100% threshold, they'll be screened for CHIP eligibility, and if they qualify, then they would be automatically put in CHIP, either at the 0 premium or I think they're 20 and 30, I think, are the premium levels. That's kind of confusing to me. I always thought that when I looked at the CHIPS enrollment, which is around 50,000 kids or something like that, that was, so you're saying that number is not accurate when I see it on the sheet?
It fluctuates, so you'll see through the course of the year, there might be months when our CHIP enrollment might be running around 80,000. And then again, there's nuances when you look at the eligibility categories online, because you have CHIP and you have M-CHIP. And so if you add those numbers together, typically that level will fluctuate between 60-some thousand up to about 83,000 in any given month. It's somewhere in there, but there's 2 line items in that report that are around CHIP. Because I think this most recent month, it was 58 regular CHIP, and I want to say 16 or 17,000 M-CHIP.
M-CHIP means Medicaid CHIP.
Yes.
But you were saying 300,000.
If you do then just the Medicaid children. If you take the children enrolled in Medicaid and children enrolled in CHIP or M-CHIP, and you add those together, that total ends up being around 300,000 roughly a month.
Okay, very good. Thank you. Committee further questions? Okay, on to the next one.
Okay. I want to point out a change in the next one. This is standard data that we present. It's our application status over 45 days. For Medicaid, the states have an over 45-day standard, which means you want to get your applications processed in 45 days. There are exceptions to that. If someone requests an extension to get information into us, or other types of circumstances. But one thing I wanted to point out is, again, I think I've mentioned to this committee, we think it is an improvement to the Medicaid program is we created a Medicaid data bureau that is specifically staffed with folks, and the legislature supported us in creating this to data and data analytics. And one of the things that we identified historically when we've been reporting our over 45 number, we've been reporting applications that are what's called presumptive disability. And that is a category where an individual is applying for Social Security. If you know anything about the Social Security disability process, it can take years. So there's in Medicaid a presumptive disability process that they can do. Again, all the same medical documentation is submitted, but it's a more streamlined process. If you appear to meet the Social Security level of disability, you can receive Medicaid while you wait for that final Social Security determination. Those applications actually have a 90-day threshold, not 45. So we were reporting them under the over 45 number, even though they may not have been outside of any compliance. So you will see going forward, we will break those out. So right now we have 634 of those applications. That's the single biggest category. And we'll do a better job of displaying it. But I did want to point out that that's a change. Really, otherwise, our true over 45 number is about 900 in some applications, which is a little bit lower than we've been running. But again, historically, we run around 1,000 to 1,100 over 45 days. And right now we have 8,270 applications in-house. Any questions on the eligibility numbers?
Any questions? So just to break down on these charts here, you've got family medical registration. The top two are our application folks, right? We do that in-house.
Yes, elderly and
others are
disabled
done-
and long-term care is done by KDHE staff, and family medical is done by Conduent, a vendor.
Okay, just so we're clear,
Yep,
our
that's a,
200 folks
good-
that we
yeah.
have working for us do the top two.
yes, correct.
Okay, very good. Thank you. Committee, further questions? Very good, thank you. On to the next one.
I won't spend a lot of time here. Obviously, the call center continues to perform extremely well. Again, really outside of, for those of you that were on the committee as we started the unwinding, the first month of the unwinding, we had a surge that we did not expect. But really, in the last 12 months is what we're reporting here. You can see our average speed to answer. Besides the month of January when we had all the snow days, the funeral for President Carter, there were 6 days that we were shut down unexpectedly and 2 holidays in the month of January, which is why you see the 5 minute and 28 seconds, because of course that created a pent-up demand when your call center is closed unexpectedly. But outside of that anomaly, you can just see that the call center continues to perform exceptionally well, which really what that means is our members and their family or facilitators that need to ask questions around eligibility are able to talk to someone very quickly without having to hold and wait for someone to answer the phone. Any questions on that?
Any questions? Seeing none.
Okay, this is getting into complex wheelchairs, and obviously there was some discussion and some proviso language around prior authorization around complex wheelchairs. So this is the KDHE portion of this presentation. The MCOs will have their presentation this afternoon. First slide, I won't really cover this. This is just, I think most people are aware of what a prior authorization is, but we have the definition here from both the Kansas administrative regulations as well as CMS. The next slide, why is prior authorization important? Really, in a nutshell, it's to ensure beneficiaries are receiving necessary services. It's also a way to hopefully be cost-effective and eliminate or reduce fraud, waste, and abuse. Again, one thing I want to point out here as we talk through prior authorizations, and you're going to hear in this presentation that the agency does not agree with the language that is in the proviso about no prior authorization on complex wheelchair repairs. We're going to get into that a little bit. But one thing I wanted to point out, and when I say this, a majority of the Medicaid providers do the right thing. So I want you to hear that. I'm not making this out to be, you know, everybody's a bad egg, if you will. But historically, in the Medicaid program, the two areas with the highest level of fraud, waste, and abuse are durable medical equipment and home health. And so prior authorization in those areas, while you're going to see in this presentation, I think there were some adjustments that the agency was working on in that space, were necessary. I think going to a complete, having no prior authorization in this space does put the state at risk for increase in fraud, waste, and abuse, because again, historically, this area has been, and CMS has put in a lot of requirements in this area, again, because of that. So our current process was, as we entered session, that all repairs, accessories, all of that did require prior authorization. As you were meeting in session, actually KDHE was working on an update to that policy that would have removed prior authorizations for any repair or maintenance under $500. So again, batteries, the things that you heard about that didn't seem to make a lot of common sense that there would be prior auth, we were already in the process of making that update. Of course, the bill passed before we could, so now we are prohibited, so there will be no prior authorizations. One thing I do want to point out is there is some requirements around wheelchair seating assessments. This is part of the whole complex wheelchairs. The first step in that is doing the seating assessment. So while prior authorization is not required, there is some requirements around a physician order. There must be a face-to-face encounter, because obviously to do a seating assessment effectively. And then we also have a multidisciplinary team that is involved in those seating assessments, because again, these individuals are very, very complex, and so we'll have a provider involved, a physical therapist involved. It's a multidisciplinary team. So again, while we don't do prior authorization, it is a multidisciplinary team, and there is a process to get those approved. Some changes that are coming at the federal level, which I think the state is really interested in, and hope this will move not only Medicaid forward, but all insurance companies. For those of you may have been aware, Dr. Oz and Secretary Kennedy Jr. Have been speaking about prior authorizations. They've been talking about a standardized electronic program or system to provide streamlined processes in prior authorization to speed it up, to make that time from submission of the request to approval much more streamlined, have streamlined processes between different types of insurance, which from a provider perspective would be really appreciated. So again, we're really looking forward to seeing what comes out from the federal level. We're really hoping that Medicaid will be able to take advantage of those improvements. But even outside of that, one of the things that we are undertaking in KanCare, and again, it's part of our reorganization that we did where we have allowed and moved our clinical team. So we've got nurses and physicians to move them away from a lot of the in-depth policy work and CMS compliance work. We have another team that does that, freeing them up to do a lot more clinical type work. One of them being is they're going to be going through all of our policies where we require prior authorization and doing that analysis to say, does this make sense? If you're approving 95% of your prior authorizations, does it make sense to continue to have that prior authorization? Or maybe like we were looking at doing in the wheelchair repair, you start to set thresholds and say, well, if the cost is below this threshold, we're going to eliminate prior authorization. We're going to keep it at a higher level. So we have started that process and will continue, but I think that will be a positive for our providers. So we're going to be doing some work outside of what's happening at the federal level, but I'm really hopeful that we'll be able to take advantage of a lot of the work that they're doing, and they'll make those systems and processes available to the states to utilize as well. Some other recent changes that we made around this whole issue of the complex wheelchairs is prior to about 8 months ago, the process was you had to go to a seating clinic. We have some very good seating clinics in Kansas, but some of them end up with wait list. They might be 6 months or more. So obviously if you have someone that has to wait 6 months to have a seating assessment, that is probably not a good patient care. We also have, especially children that are extremely complex. They might be on ventilators. So to have to travel to a seating clinic, especially if you live in Western Kansas, that could just be a risk to the patient themselves. That I have to be loaded up and transported 2 or 3 hours, spend a day or two at the seating clinic. So what we've allowed is for certain individuals, we allow those seating assessments now to be done in the home environment. Again, the same physician, physical therapist, occupational therapist, the same providers involved. It doesn't eliminate that requirement, so they're getting the same level. It's just doing it in probably a safer environment for the member, and again, as also a way to avoid the wait time. And this is when, again, I won't talk a whole lot about this other than to say we were able to, and I think this is a very positive thing. I think many of you are aware that we have certain DME rates that we have to increase every year based on Medicare. And so last year, or in 2024, when Medicare redid their rates, they actually reduced some rates that freed up some money. So for us, at no cost to the state, we were able to take other rates where they were significantly below Medicare and take them up to 80% of Medicare. So that was actually a very positive outcome for the state, and I hope our providers will recognize that. But again, that doesn't happen all the time every year, but sometimes when CMS will lower their rates, it will allow us in a budget neutral way to bring some other rates up to a much better threshold to Medicare. The other thing that we're working on is wheelchair growth kits. As we know, children, this becomes a very complex space because obviously they're growing and needs change. So I want you to know that we've done some policy clarifications there and guidance. We're continuing to review that just to make sure that what we have and what we're allowing makes sense clinically for these children. Again, like I said, children can be very complex in this area just due to growth and just the normal process of happens of aging. The last one is I'll just talk about some of our concerns. Again, with having no prior authorization that we can do. Again, we are concerned about an increase and maybe not so much fraud, though, it could venture into fraud, but waste and abuse. We could be without the ability to do prior authorizations. You could have enough requests for repairs submitted that it would exceed the cost of the actual wheelchair. There's that point in time where it becomes more effective to replace the wheelchair than it does to continue to do repair and maintenance. So again, we will be providing some data, to this committee as we go forward. Of course, the fiscal year just started, so a little bit too soon, but we've been working with the MCOs on identifying some data points that we'll be monitoring and providing, but we would respectfully ask that next year that language not continue and that we be able to go forward with our policy to remove prior authorizations for anything costing less than $500, but any repair that is $500 or over, that the KDHE be allowed to re-implement a prior authorization process. All right, and with that, that is the end of the wheelchair.
Very good. Thank you for that. Committee questions. Representative Bueller.
Thank you, Mr. Chair. Thank you, Christine. I know this is at a point where the agency doesn't agree with what the proviso is. And I do appreciate the work that you're doing to recognize that the problem, the issue, and the fact that it's real. I think the reason we got to the proviso in the first place is the horror stories we heard of prior authorizations and slow walking repairs for complex wheelchairs and for the Kansans who are sitting and living in them.
Yep.
So that's the stark difference between what is supposed to happen and the action I think we took for these folks. I would say that the work with seating clinics, continuing to look at data, whether it's 500 above or below, allowing us to look at data to see whether or not the proviso language is actually necessary again next year. Because at this point, I am open to hearing any and all data that comes, but I'm also, I was also very personally frustrated with the application of prior authorizations and the denial of care for those individuals. So I'll look at both sides of it. And again, I very much appreciate all, this is great, the stuff that you're bringing today. But I still have a frame of reference that goes back to last session. So anyway, just in all candor, thank you so much. This is great. Looking forward to the data in the future. Thank you.
Thank you.
Representative Sutton.
Thank you, Mr. Chair. Christine, there have been a lot of stories come out in the news over the last few months, settlements, judgments, big dollar amounts. Does this proviso really open up the door to that sort of thing happening in Kansas?
Yes, it does. In all honesty, it does. But again, agree with Representative Bueller that I think our policy was way too restrictive, which in cases delayed care, absolutely agree with that, which is why we've made some of the internal changes we have to allow our clinical team. But yes, it does, because again, if I want to be a dishonest provider and I could bill for a battery or a repair that I never did on a wheelchair. And again, I always want to reiterate, the vast majority of our providers do the right thing. But I think Mr. Anderson would agree with me, in every basket there's a few bad eggs, and a zero prior authorization would allow them to take advantage of the system, which is part of the data that we'll be monitoring. And again, hopefully it doesn't come to pass, but we will be watching and providing that information to you because we do have concerns.
Excellent. Now, I agree that there's got to be a better way to solve this problem. I'm a little skeptical on drawing a line at any number $500, because I think we'll find that every repair is now $499. You know, and so whether it's done or not, because it won't be scrutinized, you know. So I'm cynical. I've done this for too long.
Well, and you know, but I think that's an excellent point, which is part of the reason that we created the Data Bureau, because the reverse is true as well. So when we look at the data and say, okay, all the repairs $500 or less, we're approving them, or the MCOs are approving them at, I'm just throwing numbers out here, 95%. So this doesn't make sense. But you're absolutely right. Once you remove the prior authorization, or lessen it in this case, you've got to have the data analysis ready to go to then monitor of, does it create a reverse problem? And I think, that's kind of that holistic view of, again, trying to do the right thing by our patients and our providers, because we get prior authorizations create administrative burden in the system. But yes, you've got to watch for, I think what you'll probably find is it would probably be limited to a subset of providers. But again, it's a way for us to uncover those and then obviously get them over to the OIG for the work that they need to do if someone, like you said, wants to take advantage of what they now see to be a loophole.
And I'm excited to see that communication taking place. That's kind of the way it was supposed to work when it was set up. So I'm glad to see that communication. I'd like to see more with the MCOs as well, communicating with the Inspector General, but that's just me. I can wish. Thank you, Mr. Chair.
Senator Petty, I knew I was going to do that.
Yep, I'm still in that position. So I appreciate you bringing up, I mean, we have heard so much about fraud and how much we don't, and of doing things to mitigate fraud. And then we pass a proviso that actually doesn't do that. I mean, it could reinforce the whole thing of fraud. So I appreciate you bringing up that. And I think it just brings home for us to the whole problem sometimes with provisos, that they do come in at the end without, even though this medical, with this prior authorization issue has been something that's been out there for a while. It's not brand new. But I appreciate that the department is looking at providing a solution that really addresses that, but at the same time, considering that we don't want to increase the opportunity for fraud. So I look forward to addressing that in a different way than we did this past session.
Representative Ballard.
Thank you, Mr. Chairman. I would hope, even though with pre-authorization, I'm thinking from the university point of view when we do it, even though they don't have to have prior, when they submit the bills, we question why that was, or this is the range of what the cost is. Why was your cost higher? So just because it's not pre-authorized doesn't mean that you automatically get that, because you have to justify it if we question it as well, right?
Yeah,
So
there's
I
some
hope
things,
you
yeah,
do
that where it will be on the back end versus the front end. Yes, there's, and like around the seating assessment is one of those where it's done more on the back end than on the front end, where there might be some question if, for instance, they're ordering the most expensive, or they want the very most expensive wheelchair that's out there, but on medical review at the MCO, they might think that, you know, we could do a little bit less expensive one, or if the dollar range is way out of whack. So there's some things, again, to try to do that on the back end. But again, I think the multidisciplinary team for the seating assessments really, I think, limits that, because it's a combination of providers, coming together. But yes, it does happen.
Okay, I just wanted to comment again on SB 125, the prior authorization. One of the other things we heard that I think played right into it was an individual that had actually outgrown the wheelchair, and they were still in a wheelchair. They had had over 10 years. Well, the body changes, your needs change, the support you need because of either being heavier or your bones are weakened or whatever. And yet they had, I think, over 4 times gone through trying to get this done. And that just seemed that it was totally out of whack for them to deny that, when we all know that that's a long time, and wheelchairs are expensive, but yet you're going to still have somebody in the chair they can't function properly, or even as much as they can do with that disability.
Yeah, and that's some of the policy work we've been doing to identify those gaps and make sure that, especially for our children, but it can happen for an adult too. There can be, weight gain or weight loss or other things that happen, but obviously children is where it's most predominant. But we've been working on, reviewing and making sure our policies are aligned with best clinical guidance and updated to ensure that as a child grows, that whatever technology they're using, that it's growing with them, if you will. Because you're right, it with a child, it can be every, 3 years, maybe 5 years, could be less, just depending on the child's situation.
Well, I'm glad that we're kind of on the same page on that one because the consumer was the one that was really on getting
Exactly.
the short end of the stick.
Yep.
Thank you very much.
Thank you. And while we're on that subject, I would like for the MCOs to report at each KanCare meeting, the initial prior authorization denial rate, and also the average and median time it takes for final approval for wheelchairs. I find it hard to believe, first of all, I don't even think in this fraud realm, which is very naive of me, you know. So, but I am concerned about the consumers, and obviously there was a problem. It didn't even enter into my mind that people would take advantage of that kind of situation. So, but I find it hard to believe that we can't monitor this in a level that will be transparent and not affect anybody. If our expenditures go up, you know, on a certain, I mean, we're not talking about that many folks. And I find it hard to believe that we can't control any fraud or any abuse or anything like that. It just mind boggles me.
And that's something too that the agency can report on. We're going to get into it a little bit here in the next slides about some of our utilization management and new oversight approach in KanCare 3.0 that I think will address some of where your concerns are.
Very good, thank you. Committee, further questions? Representative Ruiz.
Sorry for my lateness, but I was listening in, and this is one of the areas that I was really excited about that we were talking about. I think it'd be helpful also that when we talk about prior authorizations for wheelchairs or any kind of assistive technology, that we actually have pictures of what that looks like. Because I think in our mind's eye, we see, you know, the more traditional kind of, you know, wheelchair that we see when you walk into an ER at a hospital and they're available, you know, to be able to use. But we're talking about technology-loaded assisted devices. And when you talk about the device being able to grow with the child, all of our children are growing up with all kinds of technology, and that's all they know. And it does not matter if they have a disability or not. So yeah, it's, you know, is it going to be expensive? Yes. I'm glad to hear all the oversight that's going to be put in place for this. Thank you.
All right.
Committee, further questions?
Okay.
Very good.
So on to what we refer to as One Kansas Hub. So I think I've shared with the committee previously that under KanCare 2.0, kind of the oversight and monitoring of the MCOs was a much more of a passive process, for lack of a better word. There wasn't a lot of real proactive and active oversight on the part of Kansas. So part of getting to where we want to be in this new contract and with our new approach to oversight is one of the first things that we had to do, as I think you're all aware, actually KanCare is divided between three agencies, DCF, KADS, and KDHE. And everything overlaps with each other. There is no, well, this is 100% KADS, because even though it's a waiver recipient, there are services that they're getting that are in my bucket. So there really is no, this is me, this is you. It's all of us. And so we created what we call the hub. And what that is a very focus group of people from every agency. This is where we talk about, you know, processes, we talk about policies, problems, you know, what are the stakeholder issues, but it's a way to get everybody on the same page and that we're all walking in the same direction, because you can imagine everybody's trying to do the right thing, but if we're not talking to each other, we may be actually going in separate directions. So we implemented that first quarter of 2025. Again, you'll see here some of the things that, you know, we try to deal with, you know, obviously any issues, areas of enforcement that we need to look at, interventions, you know, streamlining, vendor management. One of the things that we really identified in this effort is that a lot of our staff were not educated on what it means to do vendor management. So we've really engaged in a lot of activities to shore that up. Again, strengthening our data systems without a data bureau, which KDHE did not have until a year ago. Again, of what are all these data points that we need to be monitoring, so we can effectively oversee the MCOs. And part of that overseeing, and I don't always want to make it sound punitive, because it's not. It could be our policy, meaning a KDHE or KDADS policy, that's driving the inefficiency or driving the barrier to the patient. So it isn't always just looking at what the MCOs is doing. It's looking at our own policies and how are we creating those inefficiencies, looking of opportunities, again, around, fraud, waste, and abuse. So again, this was implemented first quarter. I would say that in the last couple months, this has really gotten to be a good process. Obviously, it was a little clunky at the beginning. Everybody's trying to get used to a new process. But again, I think really now it is really moving. A big portion of this, of the new oversight model and part of the hub, was utilization management. Again, historically, our clinical team was really the team that developed all the policies, did the fiscal analysis, or was involved in it with the policies. Well, that's really not clinical work. People that are SMEs and Medicaid can do that work. So we've transitioned that over to our policy team, and then our data team does a lot of the fiscal impacts, freeing our clinical team up to do, again, what we talked about before, the reviews of prior authorization and where do we need to tweak those or modify those. But another big element will be utilization management. The thing with utilization management is it a lot of times takes some on-the-ground effort, looking at files, looking at documentation that the MCO would have, maybe provider files, to really determine are the MCOs doing the right thing, but also is our policy accomplishing what we need it to accomplish? So we are starting this process right now with the MCOs. I will say that our 2 part-time medical directors and the MCOs, CMOs, along with our clinical team are meeting very frequently. Is it weekly or monthly? See, I always have to ask, phone a friend. Those conversations have been really engaging. The MCOs are very good partners with us in working through this. Again, the whole idea is that the member receives the care in the right setting at the correct time while also being cost effective. Again, lofty goals to achieve, but that's at the end what we're trying to do. So we're very excited about working with the MCOs to bring this to full fruition, but we think it will also give us a lot of insight into, what is actually happening at the member level and where we need to improve. All right, that is kind of the end of what we're doing on MCO oversight.
Thank you for that. Committee questions. Representative Sutton.
Thank you, Mr. Chair. Christine, first off, love this, all right? Love what you're doing with this part. But right when you started out on this section, you said something that scared the heck out of a budget guy. And that was that everything, that Medicaid is split up between KDADS, KDHE, and DCF. Where's the Medicaid budget line item? Where does that reside?
So the waivers will be in the KDADS budget. The CCBHCs and those are in the KDADS budget. So the budget is even split. Predominantly, a lot of it is in the KDHE budget, but there is portions in other agencies as well.
All right, so if another agency makes a tweak, makes a change, and that hits the Medicaid budget line, who takes the hit?
It would depend what the change was of who it may hit, but this is the whole reason for the hub, is to get us all aligned, make sure. I won't say we did a bad job before the hub, but I think there were just times that you get busy and there wasn't this focused, we do weekly meetings, this focused time to make sure we're all on the same page and, oh, you want to make that change? Well, hey, did you think about what that's going to do to my budget or what that's going to do to my policy? Making sure all of those conversations are happening. So while I don't think it was terrible before, I think there were definitely gaps before, and I think we would be, one agency or the other would be surprised. And I think this is the whole effort of this, is it's one Kansas, we're one team. So you won't see those differentials, that those conversations will happen, and we're all moving in the right direction.
Excellent. Well, I certainly like the sound of it
Yeah.
because I know how I feel about surprises. And I would imagine that it probably is a pretty universal feeling.
Yes, yes, it is. And I think the other part of it too is it's also good for our providers and stakeholders, because if I'm talking to a provider and I wasn't aware of something that DCF or KADS may have been doing, or vice versa, they weren't aware of something I was doing, I might be speaking out of what I believe to be factual information when in fact it's not, and then you probably would hear the frustration. But part of that is that we're speaking with one voice as well, because it's very important too that we're all saying the same message, all on the same page.
Excellent. Thank you. Thank you, Mr. Chair.
Senator Petty.
So I just want to reiterate that I think the One Kansas Hub is a great move, and I would agree, speaking with one voice, because having sat on this committee and sat on Ways and Means as well, that hasn't always been the case. So I appreciate this. I think that it will be beneficial for the budget process. It'll be beneficial for you, for KDHE and DCF and KADS to all be speaking with one voice, and also for MCO. So thank you. I look forward to that, seeing the fruition of this with the next session. Thank you.
Representative Bueller.
Thank you, Mr. Chair. Christine, I'll admit to being a little slow on the uptake here. I like the idea, but I'm just curious about tactically how this is working. So you've got the three agencies, who coordinates it? Just help me understand tactically how this is working.
And I can also submit to the committee too a presentation that we did for our own staff as we rolled this out, which will go into more detail. But generally, yes, we have one person that is assigned to be the hub coordinator. And so they're the ones that they do all the meetings, they organize the group, but we have a centralized like issues log. So again, instead of KADS has theirs, we have ours, DCF may have theirs. We're making sure that everything is centrally tracked. And again, that would be the hub coordinator. There's a lot of times subgroups that form off of the hub as we're working through an issue. Like we're working through some issues around our, what we call our electronic visit verification system. And so there's a subset of folks that are working on that, but then it always reports back up through the hub, so everybody is in the loop on the outcome, the resolution. Again, we may bring the MCOs in, at time as appropriate, but yeah, it has a whole coordination and reporting structure, centralized tracking. We're trying to create, I'm not sure if it's live yet, I'll find that out, a SharePoint site. So
if I may, one follow-up. So how is work prioritized? So how does something climb to the top of those three competing or overlapping agencies?
So, and I think that's really the great thing. I know I'm going to go do a two-part piece to that. So if there's something that needs to be worked and it's going to be a rather significant workload, which is a lot of things in the Medicaid space, the first line would be the hub would look at everything going on and all the outstanding items that we're dealing with. Let's say it's a contractual change that somebody wants. They would first prioritize it and say, we believe that this would be number 3. But then we have, above the hub, we have what we call our governance council, which is Secretary Howard, Secretary Stanek, and myself. The final decision, if there's a disagreement between the 3 agencies of they can't come to a resolution of where this should be prioritized, then it would come up to the governance council, and we would make that decision of where it gets prioritized. And one thing I want to say about prioritization in Medicaid, and I always try to be careful with our stakeholders and providers as well, that is never a statement of something being not important. It's really capacity. And so sometimes if there's, several competing priorities, you kind of do have to prioritize, but we're always sensitive to the fact that we're never trying to communicate something's not important.
Thank you, Christine. Representative Sutton, I think there's an opening on the Social Services Budget Committee at 3:30. And you could,
My plate is full.
and you could have some input on, as you saw yesterday when we got the caseloads, KADS has their caseloads, DCF is foster care. So they are separate. And just a bit of history, in 2015, the Brownback administration tried to condense all the Medicaid into one thing, and the federal government said, no, we could not do it. But that was in that budget process, which made a lot of sense, but nothing the federal government does makes any sense either. But it would have been really in one place. All the Medicaid expenditures would have been in one place. We tried to do that a budget year. CMS said, no, you can't do that. So the next year we separated it all back out. But anyway, and your question.
Thank you, Mr. Chair. Just your discussion with Representative Bueller triggered another question for me. What if the agencies don't necessarily agree? Does anyone have veto power? Is there any, the governance, is that the part that?
Yeah, the governance, it would come up to the two secretaries and myself. We would have it presented to us. We invite them to come and kind of they make their case, if you will, and then Governance Council would make the final decision.
Okay, all right, thank you. Thank you, Mr. Chair.
Very good, thank you. Committee, further questions? I think you might.
Real quickly, I think there's only 2 slides here. Just one thing I wanted, this kind of goes along with the whole idea of the hub and collaboration. This is some things that we've done since the session ended, which is external to just Medicaid. So Medicaid and DCF and the Office of the Inspector General, we met, I believe it was in May, and we were walking through all the data sharing between especially DCF and KDHE. Where were those things happening, automatically? Where might they be happening, but it's manual? And kind of talking through how we could improve or opportunities for improvement in sharing data. One idea that really came out of that meeting was currently in the SNAP program, because it's a federal program. A lot of times DCF will go in and update an address to out of state, because for SNAP, it doesn't matter where you live. And currently, it's a manual process that would get that over to the Medicaid side, which then means sometimes it happens, sometimes it doesn't happen. There can be gaps. And so we are looking and working with the eligibility system vendor on trying to determine cost if we automated that process to make that more automatic to reporting that on the Medicaid side. Just one caveat I want to put here is the managed care and access rule, which has a variety of implementation dates in the future, could potentially impact this. That managed care rule. Right now, if we get a referral from SNAP, it's considered a verified source, which means we essentially notify the member, we've made aware you live out of state, we're going to close your case. They get a time frame to tell us that that's not accurate and you can move to closure. That rule would move it to an unverified state, which means we cannot take immediate action, and then it becomes about a 90-day process to be able to move from notification to being able to close them for an out-of-state residency. So again, we're still going to move ahead with, getting cost and all of that, but we may have an impediment there if that doesn't change at the federal level. The other thing that we're working a lot on is automation opportunities, we believe. And we're getting some pricing from our vendor that in our keys, which is our eligibility system, that case registration could be done through bots, which is basically taking the information that comes in on an application and it's automatically put into the system. There's a lot of technology. We've been watching, especially Arizona. They've been kind of taking the lead on some of these items, and we're watching their outcomes, which right now look very positive. So I think there's room for efficiency that would cut down on FTEs. It would also increase accuracy if it's done correctly. So we'll be bringing those forward as we have confidence in solutions, but I think there's some real opportunities there to streamline our processes. There was a comment made about the Inspector General working with the MCOs. Well, I want to tell you there is a start of that happening. KDHE and the Inspector General met again. It was after session to discuss opportunities around fraud, waste, and abuse. Conversations will be ongoing, but the Inspector General shared with us some of their observations and things that they've learned, so we can make sure that we're aligning and looking at some of the same things. But an outcome of that meeting was the start of this will be the Office of Inspector General, the MCOs. The Office of the Inspector General is going to conduct a fraud training that the MCO staff and KDHE staff will all attend, so we're all kind of on the same page, so to speak. And the Inspector General offered to do that for free. Traveling over to Kansas City, our staff will travel as well, so we're in the process of scheduling that. The other thing that I want to point out is a couple efforts that KDHE has underway, and I know it's been a question of this committee on Inspector General audits and findings. We're going to be creating on our website some information that will outline how KDHE is responding to findings. We don't always agree with all findings, but we, by and large, probably do. But we'll be providing information on what we're doing to address that finding and to mitigate it. One thing I do want to point out as a part of the out-of-state or the members out-of-state audit that was done, we've just completed a free pilot project with a public consulting group where they actually use their data sources to try to find out-of-state members. That data has now been submitted to KDHE. We are validating that. I'm hoping to share it the next Bethel. If the preliminary information that was shared, we can validate, it would indicate that this may be a potential solution to better identify out-of-state residents. We'll just have to, again, see what the results and then what the cost would be. One thing I will point out around out-of-state as well is in the bill that the president just signed by 2029, CMS finally has been given the money to create a hub at the federal level. They have all the data. They know if someone's enrolled in multiple states, but that will actually start to become available to the states to access and use for verifying out-of-state members. So we might have a stopgap measure here, but I think we'll have a permanent solution coming in the next 3 years, which is exciting for the states. And with that, I am finally done.
Committee questions? Senator Petty.
I just have one. I was trying to, so when you talked about the SNAP, did I understand you that what has gone in place at the federal level is making it actually harder because of the out-of-state address to take someone off?
So on the Medicaid side, yes, the managed care and access rule, and I believe and I could provide the exact date, but I believe it's 2028. They are going to change SNAP address updates to an unverified source. Today in Medicaid, it's considered verified. So kind of talking about the federal government having the same challenges we do at the state level with the left arm isn't talking to the right arm. But we are hearing that may be addressed in an edit to the rule. But again, right now, it would move to unverified.
Thank you.
Any further questions? Just one, Christine. I haven't heard anything, and I don't know if there will be later on, but how are we doing on our care coordination for the MCOs? The care coordinator? Is that, I know it got kicked down the road.
Community care coordination, yeah. Andy's actually going to talk about that in his update, and then because that's really primarily led by KADS, but I'll be here as support. We're not the lead on it, KADS is. So Andy's going to cover it, but I'll be here to answer any questions if they, again, overlap into the KDHE space, which they may.
All right, very good, thank you. All right, thank you for being here. Next.
Thank you.
Secretary Howard. Welcome to committee.
Good morning. Thank you, Mr. Chairman. Members of the committee. Let's see. Not sure where the, oh, okay. All right. Just kind of waiting on the slides, but I can go ahead and get started. I just have a few opening comments before I turn this over to my team. You know, as usual, we had a busy legislative session with all of you. So we've been very busy implementing the fiscal year 26 budget items, the rate increases that you approved in a number of areas for adolescent substance use disorder services, some things around problems, sexual behavior, cognitive behavioral therapy, specialized medical care, BI waiver therapy, and some of the IDD waiver services. Those have been implemented. And we're actively engaged in making sure all of our contracts are updated. I asked our insider agency, how many actual contracts do we have at KADS? And I was told we have more than 750 that we need to do each year. So anyway, doing well on that. And then again, of course, we did have the 1.5% across the board cut, which for KADS was about $1 million. And I think we provided that information earlier, but we spread that across 8 programs, focusing primarily on kind of some haircuts to some new and one-time additions. We didn't eliminate any programs. We also had some changes coming out of the session in some of the reporting provisos, some of which have kind of been talked about here already in the last couple days. The legislation would no longer require us to provide information on the supplemental healthcare agencies. That was kind of a one-year thing related to the registration and report of wages. I know you were talking about that issue yesterday. I think at your next meeting, we'll have kind of the final report on that. But certainly the last quarter report to the chair's comments yesterday certainly reinforced the point that the charges paid by the state compared to the wages paid to the workers have significant gaps. I mean, for example, I made some notes on the RN side. I think our last report we provided to you, the charge was just under $81 an hour. The average pay was about $43 an hour. And you can look at that, you know, all the way down to LPN, CNA, CMA, and see those kinds of gaps. So we've reported that to you in the prior quarters, and we'll have the final report from the past year at your next meeting, and also obviously at your other committee meeting when you talk more about the supplemental the contract staffing issue. We also had some requirements around federal elderly waiver capacity, and we will continue reporting that just because that's an area where we have issues related to funding shortages, and so we will continue reporting that as we look towards the imposition of a wait list. You'll hear more about that in Michelle's presentation today. And then the issue of involuntary discharge, we'll be providing a report to the 2026 legislature as required. We'll continue to collect that data. Haley talked about that as well today, some of the issues that happen with involuntary discharges from state licensed homes. I think Scott mentioned this yesterday. We're excited that at Parsons, the behavioral health stabilization unit that you funded is open, has accepted several admissions. I mean, that's really, really important to have that kind of a controlled, safe treatment environment for individuals across the lifespan that might be experiencing behavioral psychiatric symptoms in addition to their IDD diagnosis. And again, this is not intended for individuals to go to Parsons for long-term or for their lifetime. It's really intended for short-term treatment. And then there's really some collaboration with the Parsons outreach team as those individuals might return back to the community with regards to training and support for caregivers in the community. And you'll hear some updates from Drew about some similar community-based programs. So we've had a lot going on. Michelle will give you some updates on the community support waiver, the progress we're making there, also the progress we're making with the IDD modernization work groups. We're still on track to submit a community support waiver request to CMS later this year. And we will have to take that proposal as well as the results from those IDD work groups to the LCC under House Bill 2240. And we'll talk to you in greater detail about both of those. I think at your next meeting, we should be ready to do that as well. So again, a lot of activity going on there. I think just the last thing I would say, just starting out this, is just giving an invitation. We are reactivating what had been an annual event for many years in Kansas, but stopped a few years ago, the Governor's Conference on Aging. You will be receiving your own invitation to this. It will be October 17th in Manhattan. The Governor's Conference on Aging. The theme will be Rooted in Respect, Growing in Age-Friendly Kansas. We're really, really excited about being able to bring that conference back and being able to, really think together with health professionals, policymakers, and community leaders, really seeking to really elevate a lot of aging-related work that's going on across the state. And you'll hear more in this presentation later about our state plan on aging and some of those areas of focus. So I'll stop there, Mr. Chairman. I know we have a lot of material to present, and I'm actually going to present for Deputy Secretary Brown later in the presentation. He's out ill today, so.
Committee questions for the Secretary? Seeing none, thank you.
All right, I'm going to hand this off to Deputy Secretary Bruner for state hospitals, and he'll also be prepared to talk about some of the survey issues that you were talking about earlier with the Ombudsman.
Good morning. Scott Bruner, I'm Deputy Secretary for Hospitals and Facilities at KADS. And I've just got a couple of updates for you today. On the agenda, one of the items you asked for a further update is the South Central Regional Mental Health Hospital construction. I talked a little bit about this yesterday, but I wanted to give you a couple more details and show a couple of photographs. We did start construction on our 104-bed hospital in South Wichita in February. We're still on track to be completed with construction by the end of October of 2026, and then our plan is to open for admissions in January 2027. Put in that first bullet point, there are the in-ground utilities are in place, the foundations are poured on most of the patient units. The concrete pads are about it's closer to 80% complete now with the time that's passed since we put this together. There's some precast concrete walls for the gymnasiums, the stairwells, the elevator shafts are all in place. The steel structure is starting to go up on the patient wings and actually in our kind of administrative area. So progress is definitely, once we started getting once the site was prepared, the construction's gotten taken off quite a bit in the cycle from there. We meet with our partners in Sedgwick County who have the contract with the general contractor and architect, and then those contractors as well, several times a week, reviewing submittals, requests for information from the subcontractors, trying to translate all the design documents into construction documents and then material that gets delivered. So that takes a good chunk of our team's time to work on that, to provide our input and make sure we're getting the product that we need as we're in the construction process. We've distributed the $25 million in Spark funding to Sedgwick County. There's general fund money in the project as well I talked about yesterday, but that Spark money, getting that out to the county so they could use it to pay the contractor was an important step just in the financing of the project. And then last year you did pass a bill that created the South Central Regional Mental Health Hospital as a state agency. It's a separate agency. It's like a state hospital like Larned and Osawatomie. Designated the counties in the catchment area, and then authorized that when the building is available and open, that we could start admitting criminal defendants for forensic competency. That was a slightly different statute than the Care and Treatment Act, but that's all done and in place. And so I feel like we're making good progress. Did want to show you a couple of photographs, aerial photographs of the site. The one on the left-hand side is from a drone view of the early part of February after construction started. You can see, well, maybe you can see, I mean, it's a little bit small there, but on the lower part of well, let me orient you to the site. So this looks towards MacArthur Road. That's the road that's on the top right-hand side of the image. Meridian is the other major cross street. That's about a block and a half to the left of this photograph. But so we're on the extreme west side of the lot that we're on. So that's looking from the back of the building towards the street. The kind of rectangles you can see in the bottom part of that photograph, each of those represents one of our patient living units. So there's 4 of those wings off each of the central areas, and there's four of those pods. It gets a little clearer when you look at the aerial photo from the end of May. You can see where the concrete pads are that lay out that footprint of the building with the patient wings flaring off from the central locations, and you can kind of see the precast concrete walls for the gymnasium that's in the center of the building there. If you took that picture today, you'd see a lot of steel. You'd see more of the parking lot being completed. So it's fun to watch. It's a lot of effort. It takes a lot of time, but we're excited about where we are with the process. Happy to answer questions about that if you have some. The other couple of topics that I was asked to talk about were for patients that are waiting for state hospital admission, what's happening with that. We talked yesterday about the reimbursement program that we've put in place for counties and hospitals and how much we, under Hospital 2184, again, we've been using that program for a couple of years now. We've paid out a total of $3.4 million to mostly hospitals, some counties, for time that's, again, for a patient that's been approved for admission to a state hospital, but they are waiting for a bed to be available. We're paying for that observation time and transportation for providers that are in that scenario. At the same time, we are looking at other efforts to expand our capacity just so we can reduce that amount of wait time. We are working with other hospitals on the state institutional alternatives, which I spelled correctly, well, one out of the two times it's on the slide. So I'm one for three. But those are community hospitals that work with us to provide a state hospital level of care. We've added some hospitals over the last year in partnership with KVC Camber and a couple of other facilities. And we're continuing to look for opportunities where that can work around the state. It does fill in some gaps in the system that are important to fill. And then the state hospital in South Central is an important part of that capacity expansion. And part of our planning effort will be monitoring construction, of course, but we need to think about programmatically how that hospital will fit into our system to be coordinated to make sure we're filling gaps and again, meeting the needs for South Central Kansas as well. The secretary said I should talk about surveyor vacancy too, which I listened to the ombudsman's testimony on the way over here today. If there are particular questions, I'm happy to take those. The one that I heard for sure was what our vacancy rate is. As of the 1st of June, we had 61 and a half positions assigned to surveyors. That's our federal surveyors that we work, we're under contract with CMS to survey in skilled nursing facilities, and also our surveyors that work inside what we call state licensed facilities, assisted livings, home pluses, other care location, adult care homes like that. So we have 61 and a half total. 32 of those positions are filled. So that's a vacancy rate of about 48%. That's where we've been over the last couple of years in general. It varies from time to time. We have had some success in recruiting surveyors into those units. Registered nurses primarily. We have hired a few licensed practical nurses as well to fill in. Not fill in, they're surveyors, they're trained like the registered nurses. The scope of what they can do is a little bit different, but that has been a good supplement to the team. We have put together, I said I would wait for questions, and then I just kind of went into the whole pitch. But the last point, and then I'm happy to answer questions. We've been working for somewhere close to 6 months on a proposal to the state personnel office to take some of the vacant positions that we have that we think we can eliminate the positions, take the money that's assigned to those positions and redistribute it among the staff to raise the entry-level pay rate and make some other adjustments for existing employees as well. As we talk to nurses and others that interview for survey positions, and when we get to the point of offering them positions, the two things they say why they aren't taking the job that we're offering them is that the pay is too low compared to what they could make as a registered nurse working in other environments, and the demands of their time are too great. So surveyors work a 4-day, 4-10 work week. That gets them 1 day at the end of the week to catch up on travel or kind of extend their daily work so they can travel to locations, get survey work done, get that all done in a 4-day time period. But I think Haley mentioned this too, that often requires them to be on the road essentially 3 nights or 4 nights a week. Not everybody wants to fit that into their life and work-life balance. So we can't do anything about that. We can't do very much about that. We can do things about pay. And so we put this proposal together. We submitted it. We were waiting to see what the impact of the fiscal year 26 pay plan would be, because that made some adjustments in nursing classifications and a few others that we use frequently. So we wanted to weigh the impact of that. We put that proposal to the Department of Personnel Services. Submitted it on Friday. They asked a question. I resubmitted it today. So to review that and see, we'd propose eliminating about 17 positions from this count, but then use that money to redistribute among the other staff. And we think, given what our workload is, number of facilities, that gets us to if we could fill a greater percentage of the remaining positions, that gets us where we need to be to meet our federal requirements and investigate complaints, do the things that we're required to do by statute. Happy to take questions about that, or come back later after others have had a chance to present.
So is it some kind of secret what they are paid? I mean, I hear people talking about the pay. We talk about our nurses and stuff.
I'm sorry, buried the lead on that. So the starting pay for a registered nurse that we're recruiting to be a surveyor is about $64,000 a year. Our proposal is to raise that closer to 70 as a starting wage.
And what did you say the pay was now?
64 to 65, depending on experience.
Okay. I kept hearing this pay, but I always want to associate a dollar amount with it. I'm just
Apologize.
sorry about that. And so there was some discussion earlier about the requirements. What are they?
Most surveyors, for those that are working in skilled nursing facilities that are CMS certified, we require them to be registered nurses. We can expand the survey team to include other professions, and we've tried that with licensed practical nurses. I don't think we've ever hired a social worker for that role, but we focus on registered nurses. The rationale is a couple of reasons. The kinds of issues that we find on survey often require some level of clinical judgment that you have to be a registered nurse to be able to make that assessment. If we had another person on the team that was a social worker or a licensed practical nurse, they couldn't make those same clinical judgments, which means we just have to make sure we have a registered nurse that's available. That's possible. We've been working on how to make that fit. But the registered nurse has all of the capabilities that we need for any of the things that we find on survey, I get most commonly. So that's why we focus on that level. The other issue is that our registered nurse surveyors are exempt employees, so they're salaried. They don't hit an overtime level when they exceed 40 hours in a work week, which they often do. As we've tried to recruit licensed practical nurses or other types of professions, they're not, according to how our state personnel office interprets it, they wouldn't be able to be exempt. They'd be hourly, which we can pay overtime. That's not as big of a concern. It's kind of then meshing the team. You've got some people that are on the survey team that can work as long as they need to, and some that have to stop at 40 hours or get permission to exceed. That's been logistically complicated to figure out, but it's worth exploring and discussing. I think our first step was to say, can we do something about pay first for the positions that we have, and then if we need to continue to investigate other types of classifications or professions, we can continue to work on that. But the base pay we thought was where we needed to address first.
Thank you. Committee questions? Thank you, Scott.
Okay, thank you.
Okay, Drew, you're up.
All right. Thank you, Mr. Chair, members of the committee. Drew Adkins, Commissioner for Behavioral Health at KADS. Always appreciate being able to present in front of this committee. I think I am just talking about a couple of items today. One is, I'm sorry, thank you. Which one? Which direction? This one? There we go. Thank you, Scott. Talking about IDD crisis stabilization projects that we have from the inception when we received the funding from you all in state fiscal year 24, and then also talking about some updates, kind of where we're at with the specialty psychiatric residential treatment facility study that McKinsey and Company did for us last year. So I'm happy to take questions at any point in time, but I'm going to start here with our awarded IDD crisis stabilization projects. This is for state fiscal year 25. And again, just to go back for those members on the committee for a refresher. So we received $2 million, roughly about $2 million, almost $2.1 million to KADS in state fiscal year 24 for the specific purposes of enhancing crisis services for individuals with IDD and co-occurring behavioral health needs. This was something that was going to be new for the Behavioral Health Commission, although we do work a lot with our crisis intervention centers and crisis stabilization units across the state. We were taking a little bit more of a role within the IDD Commission from our sister commission with Home and Community-Based Services. And so we met with InterHab when we received these funds. We had a position that was awarded to us as well to coordinate this that has been very helpful. A lot of the focus on this too was to look at the uninsured population or the underinsured population as well. And so the awardees use these funds to meet the needs of their communities to best support this population. I think we have all of the awardees up there. We have Good Life Innovations, the Johnson County Developmental Supports, Lake Mary Center, OCCK, Sedgwick County, CDDO, and then Twin Valley Developmental Services. And so we have some CDDOs. We also have some direct service providers like Good Life that were awarded some of the funding. In fiscal year 2025, additional funding was awarded to continue the projects that we had. And then for state fiscal year 26, the awardees have been identified, and we're currently working through getting in our internal concurrence process to getting those projects fully rubber stamped through our contract and grants process. Within these projects, just a couple of highlights. I'll note Lake Mary, who's on that list, Lake Mary Center, they established specialized crisis stabilization services. And this was with a collaboration of first responders, educators, caregivers, and behavioral health professionals. This program develops de-escalation strategies to reduce unnecessary hospitalizations and minimize law enforcement involvement. There was also a crisis stabilization call line that was a component of the program and provides telephonic crisis support. Within this document, you'll see the word START, and I think a couple of the bullet points there, even on the first program for Sedgwick County. Just as a refresher or for insight and edification for the committee, that stands for Systemic Therapeutic Assessment, Resources, and Treatment. That's a model that some of our entities, our awardees, have started to implement. So I'm going to move. Here's just another broad, I know that's a lot of words on the screen there, just to highlight a couple of those, but this is the continuation of the awardees that we had. For Good Life has provided to date monthly training for IDD service providers, CDDO staff, and then law enforcement agencies. Good Life has secured a Douglas County location to offer on-site training and BCBA consultation. Initially, these services will be provided for local area professionals and later be available for professionals throughout the state. Also, statewide remote training will be offered ongoing. For Johnson County, they actually host quarterly SIM meetings. That stands for Sequential Intercept Mapping. Meetings with area providers to plan and develop enhanced IDD crisis services. In April 2025, Johnson County provided positive behavior support and intervention trainings for 102 staff from 16 agencies and 15 family members. They've had a lot of great outcomes, especially in the realm of individuals that cross over within our behavioral health population, so those that are qualified as dual diagnosed. They have seen a reduction in need for 988 and 988 use due to BCBA intervention planning. They've also seen a discharge of 3 people into their community they've been able to help from an institutional setting. So that would be, for example, like a Parsons State Hospital. And just to wrap up as well for OCCK, as of April 2025, 88 staff have participated in the START mobile response training, including mental health providers and Riley and Potawatomi jail case managers. Multidisciplinary case consultation and planning is being provided as requested for people with IDD exhibiting behavioral health needs. So for, just as a quick update for our fiscal year 2026 plans, we did have a request for applications that was released on April 1st of 2025. We had 6 organizations that were awarded. The organizations included, I think there's only one change here, that was the $2 million for the funding that we distributed. And we had Kansas University Medical Center that was added to that list. Everyone else was the same as the first original awardees. So we also had some, I believe it was some American Rescue Plan Act funding from our Home and Community-Based Services Commission that was dedicated specifically enhanced funding for supportive services for those with IDD crisis needs and behavioral health needs. And so we have awarded, we put out for bid a contract that was awarded to Guidehouse Incorporated. You'll see they were awarded around $1.6 million to improve crisis services for individuals with complex behavioral health needs. This project runs through the end of the year, and so they've been working pretty quickly to try and have community stakeholder engagement, working with state staff. We are in phase 2 of the project right now, so we've conducted an assessment. We've gotten data collection. We're getting right now input from key external partners. This includes individuals with lived experience, and they're also doing surveys as well. For phase 3 and phase 4, they're actually, I believe, simultaneously doing this from research from other states and other experts, trying to figure out and identify leading practices that can be applied here in Kansas. And then phase 4 would be an enhanced model of care that would be developed, and then having training plans for our individuals, families, service providers, and consumers and crisis responders. Okay, so I may go ahead and switch gears to psychiatric residential treatment facilities.
Let me check if there's any questions. Are there any questions so far? Representative Bueller.
So on the where we're providing services, just a quick question. Are we geographically covering the entire state? It looks like there's deserts just by where the projects have been awarded. Is that correct?
Yeah, that's true. There are, and it gets, Mr. Chair, Representative, thank you for the question. To answer your question directly, yes, there are deserts currently. That's due to the availability of funding that we have. What we're trying to also do is figure out, I did mention that we had a changeover in one of the providers. I believe maybe in southwest Kansas, and there's another area where we don't really have a lot of saturation right now. So we're looking at that whenever we're reviewing some of the opportunities. We just haven't gotten those bids in whenever we have those opportunities. But there are, for this specific work right now, we feel like there are deserts. Now, I don't know that we know entirely sure what all crisis services are being delivered, maybe through a mobile crisis team, through another provider like a CCBHC, but for these purposes, for the CDDOs and the direct service providers, there's a gap right now.
Any further questions? Seeing none, Drew, move on.
Right, thank you, Mr. Chair. So I'm going to talk, this is a pretty common slide that if you've been around, you've seen this before, but if not, this is data that we present on, I believe, each time that we are in front of this committee. It's data that we keep. So for our psychiatric residential treatment facilities, if you're not aware, we do have a wait list to get into those facilities for a myriad of reasons. Decreased staffing, the staffing bandwidth and capacity with our licensed beds and actually staffed beds at the facilities because of aggressive behaviors or behaviors that our providers right now are not equipped to actually handle, and I'll talk a little bit more about that with the McKinsey study. But as of June 20th, our wait list was at about 72 kiddos. Of those 72 kids, 33 were in foster care. From our last report, which I believe would have been, we do these about quarterly, so about 3.5 months ago, that's 14 individual 14 kiddos have increased in that last report. And we had 8 that increased in the foster care population specifically. Our current number of PRTF licensed beds is 450, but 123 of those 450 are not being used due to staffing shortages. The current census is 301 total, of which 98 are foster care youth. So I talked a little bit about this earlier. We had a study that was done. I believe it was born out of a proviso from the 2023 legislative session to do a study on the specialty PRTF, what that would do, what the recommendations would be. And so we got a bid from McKinsey and Company, and they did that study for us. And it came back with some things that I feel like the agency was aware of and potentially pursuing at that point in time. Or continually pursuing, and also some things that we maybe had not thought about. So I'll start here with the first slide just to talk a little bit about the options to address the access gap. Again, I'm not going to go through the entire study. We have the study. It's on our website. Happy to furnish that to the committee if you would like, or you can get that from Lee Keck, our Government Affairs Director. So in the objective column, you'll see there would, for one of the options, you could add capacity for specialized needs. So when I talk about specialized needs, what I mean by that and what we're seeing at the state from our providers, from our stakeholders, and from our internal staff is that there are kids right now that have either increasingly aggressive behaviors, they are in the judicial system, they are justice involved, AKA for that reason, and so they have a need potentially for competency services, competency evaluation, competency restoration services. We have kids that are dually diagnosed, and so at all of our PRTFs, or at most of our PRTFs, they don't have the staffing and the training, the ability to actually serve those kiddos, right? We also see kiddos in youth with problematic sexual behaviors. One of the things that we're very thankful for that the legislature gave to us in this last session was some funding for, we call that PSB training. So we're working with the coalition, the child advocacy coalitions right now to get money out the door so that can be more of a community-based training. We're hoping that can intervene in this before residential treatment and placement has to happen, right? So all of that to contribute to the need that we have with that roughly 70-ish wait list that we have. So adding the capacity for specialized needs could look like increasing staffed beds among PRTFs that currently serve youth with specialized needs, convert unstaffed, non-specialized beds to staffed specialized beds, and then add net new capacity for specialized needs in complex cases. We right now at the agency have a team that meets roughly once a week to talk about with the managed care organizations, with the providers themselves, and with the other agencies to talk about what we can do for the kids and youth that are in need that we cannot find treatment and placement for. So that is an ongoing need. That wait list that we have fluctuates and depends on the time of year from probably about 50 to 60 kids to it's been up to about 100 to 110 kids. And so we are very interested in trying to solve this problem and figuring out what that needs. I'll talk a little bit more about fiscal impact, state plans, legislation, et cetera, here in a minute. There is also an option that was brought up to address the gap that we have to add capacity for non-specialized needs. This would look like increased staffed beds for youth without specialized needs. So that could be actually an addition that wouldn't have to be an either or. And then addressing our broader care continuum for the objective, expanding our outpatient programs and services provided by PRTFs to reduce readmissions. In this last legislative session, we actually did get, and I think this has been the second year in a row, some money for PRTF aftercare services. And what that does is try to ensure that the youth is connected to services on their discharge. What we see and what we want to make sure to cut off is no further readmission and no reason for readmission. And so in those aftercare services, our PRTFs are also engaging the family more to make sure that they're connected to if they need their CCBHC, if they need their CDDO, primary care, some of those things. And so we're thankful for those dollars. I think that was roughly about $250,000. We have actually seen a great need for that, and we've seen great return on our investment. So we found money within our budget internally to also dedicate to that. And so we've got, I think, 3 or 4 providers that are doing that and providing that outside of the legislative appropriation. And then the last option there that I didn't get to cover was expanding community services to address the upstream needs. So when we talk about that, we're talking about prevention services, primary prevention, tertiary prevention, some of those services that we see with some of our other coalitions that are working in other areas of the state and our commission. Right. So this is going to give us some, give you all some examples of the initiatives to address the workforce gap. I'm not going to spend a ton of time on this. Again, I presented on this in length, and we also have the study out there. I just want to highlight a few of the things here. We did, I think, again, roughly maybe 2 years ago, we had a PRTF workforce grant that was given to us by the legislature, I believe, roughly $2 million. We saw significant response back from that from our PRTFs and our providers in general, that they were very, very thankful. I know that may seem pretty obvious when you give providers those dollars, but we saw, I think, a really great return on investment specifically for the PRTFs, because a lot of the time they have a high acuity need for a specialized training that maybe some of the other community-based providers don't have. And so where their need was saying, hey, we have this wait list, here's option A to help that. And so we did see a lot of great investment in that, again, in return on investment on that. We have looked at the per diem rate supplement. I'll talk about that here in a minute, and figuring out right now our average for the PRTF hovers a little bit less than $1,000, somewhere between $800 and $900 right now. We have talked about doing secure units. This is something that we've been talking to Department for Children and Families on, because they do hold the licensing structure and the regulation right now. So we are looking at that as an option. We also have the ability to look at an initiative to have state-run psychiatric hospital children's beds. Right now, we don't necessarily have that. On the mental and behavioral health side, it's my understanding historically we have had that. That's something internally at the agency that we are looking at. I'm working with Scott on and Mike Dixon, the state hospital commissioner, to see what could be done there. We do see a need. We have had that brought to us by a litany of providers and stakeholders, and so that is something that we're addressing. And the rest on this page will actually just talk about adding capacity for some of the non-specialized needs, and then addressing the care continuum. One of the things that I wanted to highlight on that last section there, again, the program design there, we are having grants that go out to implement those PRTF aftercare services. So that is something that we are addressing internally for the post-discharge. And then outpatient services, talk about incentives to expand the step-down outpatient services in the PRTFs or community settings. And so we do think that that dovetails nicely with our aftercare, and just making sure as a state and in the Behavioral Health Commission that we're working with our CCBHCs to make sure they have the workforce necessary to be able to provide these services too, especially if they're specialized. I won't spend a ton of time on this. This shows us some of the fiscal impact of the implementation. It talks about the overall financial impact for upfront investment. I'll get a little bit more specific on some of the things that we're working on here in a couple of moments with the slide. But we look at, and this could be varied, but we look at about an upfront investment of about $12 to $18 million. Some of those annual increments, so that'd be a one-time investment. For some of those options, the annual incremental state Medicaid cost would be about $11 to $17 million when we talk about, potentially a new mental health beds that the state runs. We talk about specialized rates. We talk about training, workforce grants, those types of things. The cost avoided there on the third line we're looking at somewhere between 15 to 22 million, according to McKinsey. So when you get down to the end and you look at the actual net for the cost avoidance, we're talking about a $4 to $5 million cost avoidance at this point. Again, a lot of that could change. It could be varied, but that's what they were able to tell on their assumptions. So on the recommendations, again, I'll kind of take a little bit of a deeper dive. We are looking at having to do a Medicaid state plan amendment. That would have to be, and also a KanCare policy, or internal Medicaid policy to be combined with that. So we would be looking at those two pieces, and we would also be looking at an increase in rates specifically for the psychiatric residential treatment facilities that are saying, hey, we would like to be able to take dual diagnosed youth and kids that are on the wait list and be able to serve them. We need X amount of providers, we need X amount of clinicians and training and staff. And so we would look at that. When we're talking about the rates, we're looking at having something that's about a 50 to 75% increase of their current per diem. And so that equates, again, to some of the fiscal needs, back to that $11 to $17 million. I think we estimate that to be around $10 million. And we do have providers, I think it's important, we do have providers that are wanting to step up. They just don't know exactly how this will work right now with the current outfit that they have and the current regulations and standards. We also would have to do regulation changes. I'm happy to say that we are already working on that, and I believe our regulations set for the PRTFs and specialty services are at the Attorney General's office, so that's exciting. Needless to say, with all of that, that would have to be approved by you all, I believe, due to House Bill 2240, and so that also adds to the timeline that we have when we would be able to submit that and get approval to move forward in that direction. And I think that's all I have before we turn it over to Michelle Hayden. So I'm happy to stand for questions at the appropriate time.
Committee questions? Senator Petty.
I just have one. Back to the slide, I think it was slide 17, where you had about some of the potential pilots. I wondered if, when it came to the CCBHCs, are they all participating in the demonstration program?
Are they, I'm sorry, Mr. Chair, Senator,
Sorry.
did you say?
I think it was slides on that you mentioned about the demonstration program for the PRTF study. Working with the CCBHCs, are they all participating in the demonstration program? Demonstrations?
Mr. Chair, Senator, are you speaking to the PRTF aftercare program itself? Okay. No, that's okay. I just wanted to clarify. So yes, they should be involved at the discharge. That would be part of some of the discharge planning and the treatment planning from them leaving the PRTF. We're working to make sure within our certified community behavioral health clinic reviews too, from a quality perspective, that we're looking at some of the some of the lessons learned that the PRTFs do have the CCBHCs do have a liaison with the PRTFs, and so they're connected at that juncture. And some of that funding that I talk about does help with that because it gives the PRTF a little bit more staffing and a little bit more attention to that to make sure that they're connected.
Thank you.
Committee, further questions? Drew, I just have a couple going back to your one slide. First of all, you know, I don't know why we even have the 123 beds that are in Kansas City that we've had on the list for years, on the list of licensed beds. You know what I'm saying? It's been on there, 123 beds not being used by providers because of staffing shortages. We just need to take that off. You know, it's been on there, but we're never going to get to that point. But anyway, if I subtract that 123 from the 450 total licensed bed 301, there's still 26 left. So could you tell me, and we have a wait list of 72, so it seems to me like at least some of those people could be in the other beds that maybe I'm missing something here as far as just addition and subtraction.
Are you, Mr. Chair, I'm sorry, are you saying that there's 26 beds open right now that actually could be staffed? Is that
Well,
the point you're
that's
trying to
what
make?
your numbers say here.
Right, right. Some of that, I think, has to do with some of our, we call it a PAR, an admission planning and paperwork, and some of that process that takes place. So when we had this, it could be that that just had a delay or a lag with that. I'm not going to say few, but with that amount of beds, I'm assuming that could be the case, is that we had individuals discharged and they just haven't been admitted to that point. But I'm happy to double check on that for you too.
Yeah, I mean, if we could take 26 people off that wait list.
Right.
And then what is the length of time on the wait list for SED?
For,
Well, for pre-RTF.
let me double check on that, Mr. Chair. I don't want to say something and have to come back and correct it. I want to say right now it's 30 to 60 days, but let me double check on that.
Okay. And then the second, on the references to House Bill 2040, there's a 2-week there was an addition, it's changed. The LCC will hear that in 2 weeks. So I'm not sure how much delay 2 weeks would be in the process, but they will, in fact, hear that. That's part of the law. So that will be approved in 2 weeks.
Okay, that's wonderful to hear, Mr. Chair.
Yeah, so anyway, committee, further questions? Seeing none, thank you very much. Next, we have Michelle, patiently waiting.
Good morning. I'm Michelle Hayden. I'm the Long-Term Services and Supports Commissioner for KADS. So we oversee all of the home and community-based services programs. Oops, got a little ahead of myself there. So this is just our usual graph of how many people we're serving on our 7 waivers. Just about close to 30,000 individuals in Kansas are served on home and community-based services programs. Those numbers are from last month. So we're looking at potential new waiting lists for our frail and elderly, technology-assisted waiver for medically fragile children, and our brain injury waiver. And here are, the creations of, shows you what the gap is for those 3 waivers. We are working with our MCOs and providers and interested parties to try and mitigate those waiting lists. We've already had 1 meeting. We've decided to break into smaller groups for each waiver to look at if we have any strategies that we can employ to avoid the waiting lists. So these are the estimated shortfalls for this year, for FY26. We're estimating almost 12 million for FE, and for brain injury, about a little over 2 million. For FY27, we're estimating, this is for SGF, 28.694 million for FE, brain injury, 6,614,000, and for the technology assisted waiver, 3,128,000. So I can talk a little bit about the IDD waiting list cap. That was lowered to 4,000 in this last legislative session. The cap was lowered at the same time. The House Social Services Budget Committee added 500 slots to the waiver. However, through that budget process, the legislature ended up only funding 200 additional slots, but the cap was not adjusted. We currently have close to 4,800 on our IDD waiting list, estimating of estimates for new wait list growth, waiver disenrollments, and offers for the additional 200 slots. We anticipate the waiting list to decrease to 4,482. That number 482 over the 4,000 cap set by the budget provisor in FY26. The cost of the additional slots will be 33.5 million all funds, 13.1 million SGF. But we'll continue to monitor that and give you fresher numbers towards the end of the year so that you can decide, where you want to go with that. So there was a question about our supportive technology grants through our ARPA FMAP programs, and we have just awarded those to all of these providers. You can go to our website and see exactly what they're doing, but a lot of them are working on remote technology, just practical applications for people to become more independent by using assistive technology. And we have approximately $8 million going out to these providers and organizations to help utilize assistive technology. So there was a question about respite care update, and just to give you an update, there is no longer, the TA and SED program managers are split. We have a new TA program manager who was hired in November 2024, and we've hired a new SED program manager just last month. Both TA and SED waivers offer respite services. For the TA program, the service must be delivered by an LPN or RN. And for the SED program, the service must be delivered by a CMHC and the staff supervised by a qualified mental health provider. So I just wanted to give you some update on the IDD workforce status update. We've been working with KU as far as Kansas Direct Support Workforce Development. We've had and WSU and the Self-Advocacy Coalition and a lot of community stakeholders. And I won't go through each slide, but we've been working on promoting the career ladder for DSWs, recruit and retain DSWs to the field. And you can find more on this on our provider directory and matching service registry at ks.gov/careers. Labor market analysis to better understand workforce needs and trends. So we're looking at all sorts of data to help us increase that work group. So these are some of the promotional materials. I will not go over them, but you're welcome to look at those. We're doing a lot of outreach to different parties so that we can draw more people into this field. And there are some more right here. And again, if you go to ks.dsw.org, you can find more information on all the work we're doing on hiring direct support professionals. So the IDD workforce status update, we're also working with our MCOs. They were required to each, in KanCare 3.0, hire a workforce manager. They've also submitted, each have a plan for increasing workforce. And so we're looking through those plans. Both Drew and I are working on the plans they have for increasing workers in the HCBS waivers and behavioral health services, as well as developing and implementing interventions to get capacity. We have also applied for and accepted into the State Peer Learning Collaborative, an ACL-funded effort led by the Direct Care Workforce Strategies Center to strengthen the direct support workforce. So the community support waiver, hot item on everyone's list. Thank you for the $953,000 from the State General Fund to launch the community support waiver the final quarter of this year with CMS approval. That will total $2.5 million all funds and will be able to serve 500 individuals with a cap of $20,000 annually for services. We have been working very hard on this. We have regular meetings with the technical advisory group every month, and we have host town halls also to get feedback as we're writing this waiver so that we make sure we're including Kansas views on this. And services have been chosen and designed. A rate study is in progress to determine rates for services with provider feedback. We are still on track to apply for that waiver towards the end of this year. However, we'll need to wait for House Bill 2240 is being approved as part of our process for the community support waiver. And those are the funds that we have for that. I will say that we have been meeting. I believe in February we had many work groups with Interhab to come up with how we approach meeting the settings final rule. I think we've come up with some good recommendations on that. We are having further meetings with them towards the end of this month and early August to have our final recommendations. We have been providing grant funding to help people, providers come into compliance with settings final rule. And we're pretty excited about the direction we're going on that. So we're working together, trying to get, come to a consensus of how we meet the settings final rule. And I can stand for questions.
Committee questions. Representative Reeves.
Thank you for the presentation. At any time in some of the, looking at workforce capacity and any kind of working groups, are there current direct service workers, who are doing the work? Are they a part of those, these discussions to try to look at where the gaps are and how we can improve?
Yeah, we have been engaging some in this process. We intend to engage more as we move forward. We really want to have the input for the people doing the job as to what they need in order to continue to do the job, and just their on-the-ground experience is very invaluable.
Yeah, I make another comment, Mr. Chair. I've been in programs before, working in agencies, organizations before, where there have been discussions about workforce, and it always included supervisors and never the people that actually are doing the work, the people who are doing the direct service work. And without their input, it never works. It just never does, because they're the ones that are doing, the direct work and would have the best insight as to how to be able to, for us to be able to meet this workforce capacity or the lack of workforce that we have, and what it'll take to attract more workers.
Thank you.
Committee, further questions? So let's talk a little bit about the community support waiver.
Sir.
When are you going to apply for it?
By the end of this year, late fall. And then the CMS has to then have time to approve it.
So this whole year I've been tracking it, and then it was before July 1st, and then it was, next thing I knew, it was maybe September, October. Mm-hmm. What is going on?
So it's quite a process to apply for a waiver. There's multiple steps that we have to take. We also have to get our stakeholders together, which we have done, to all come to consensus of what we want to move forward with. It's always been a lengthy process to do this. We are working very hard on it with our stakeholders. So we're doing the best we can to get it out the door as soon as we can.
Do I need to build a fire under somebody?
I don't think so. I think we have a lot of fire going on.
Well, that's good. This is so frustrating. I know it's a big thing, but it's so frustrating. I think it's very, very important. And one of the things on your slide at 36, one of the things too is you're talking about the actual cost of the community support waiver, but there is an offsetting cost as we remove these folks from the wait list. It's 48,000. I haven't done that math this year, but it's roughly $50,000 a year for someone on the big waiver, the 14 services. So there is a savings on the community support waiver of $28,000 or $30,000 a year per person. So that's part of it. I mean, it looks like a lot of money here, but as we start to, we've put a lot of money into the big waiver. As we start to not put that money in there, there is an offsetting savings in this. And I think that we would be remiss not to kind of mention that, you know, these people are going to cost us $30,000 a year less to serve. So anyway.
Actually, it would be a little more than that.
Okay.
Yep. So we're very interested in, for those that this community support waiver fits their needs, is to ask them to consider that for their services. And we do have a lot of people that are very excited about it coming about. So we do see that people will be wanting to get on that waiver.
Yeah, not counting the ones that are already on the big waiver that don't need it, that are, we're charging, or we're paying $50,000 a year, and they only need the $20,000 services. So when I see this total number, I don't, it's not that much.
Right.
Okay. Committee, further questions? Representative Ballard and then Representative Reed.
Right, thank you. I've had similar conversations because I think we proposed this 2 years ago, the community labor, and I mentioned that to my constituents and how excited we were to have it because it would shorten the list, and at the same time it would provide the services people need, and they wouldn't have to be on the list and go through everything that long list has. And I was asked, well, actually, I went door to door 2 weeks ago, and I was asked that question, and I said, we're working on it. And so I'm trying to think how to word this question. I know everything takes a long time, but is it because CMS is demanding so much information about it and why the other waivers do not fulfill the needs that we have for this? Or is there disagreement about the waiver and how we should handle it? Could you be more specific?
Sure. So a waiver application is divided into appendices A through J, and each one has very specific requirements that you want to fill out in those waivers, and it gets quite technical. There's a 365-page technical assistance manual that we need to use to go through and write these waivers. And so we've been working, you know, appendices by appendices as far as trying to make sure we have all the information in there that they use. We haven't had a new waiver in Kansas for a very long time, and this is our first time, or my team's first time building a waiver. You know, we have experience with, you know, renewing old waivers, but this is a new process. But we are trying to be very careful so that when we do submit to CMS, they have relatively few questions, and they will let us get it approved as soon as possible.
Representative Reeves.
Sorry.
Could I add one piece to that, Mr. Chairman, just to what Michelle said? And the other facet of this that's led to some delay, I mean, does have to do with the work around the corrective action plan that we're under with CMS. And, you know, and as you all know, I mean, many of those facets are things that we've been working hard with the stakeholders on, all of the IDD modernization pieces, the conflict of interest, final settings rule. And CMS has made very clear that anything that we submit to them in context of a new waiver has to be compliant with that. So the work we're doing with stakeholders to try to reach that consensus that Michelle talked about, that's really, really critical to this. That's you know, it's work that's going on concurrently with the writing of the new waiver. And that's why we said it's so important that we get to that consensus. And we have to take that work through the LCC too, which we'll be prepared to do. So as Michelle said, there are a lot of fires under everything going on right now. We are working very hard in all those contexts. We've made a lot of progress in those arenas. But the last thing I want to do is submit a waiver to CMS that they says doesn't fit the final settings rule, isn't compliant with conflict of interest. So we have to, those other pieces that seem a little separate from the community support waiver really aren't in the context of what CMS expects from us. So again, we're working very hard on all those pieces. We should have a report to you by your next meeting of all of that work with the InterHab and the stakeholders. And I hope we have a good consensus and you'll be hearing folks speaking from the same song sheet as we move forward in the system. So I just wanted to add that context piece, because if we're not under that corrective action plan, it's not that submitting a new waiver isn't difficult and complicated and takes a long time, but this just adds a new facet that we have to make sure we have addressed those issues fully. Just wanted to
Appreciate that, and I think some of that will be addressed we'll have an interim committee this year also dealing with that, so I hope that'll help.
And Mr. Chairman, may I asked that question because I've written grants, and what I thought and what my team thought looked good. By the time it went to them, they came back with about 15 other questions. And you thought, ooh, I didn't think about that. So you don't know exactly how they're looking at it, but I'd say keep on doing what you're doing, but there is like an urgency kind of, and it's like we see it almost as an urgency because there's so many people on that waiting list and it's not moving really fast. I mean, we can take 500 off and we're making progress in that area. But again, it's the treatment part that I think is what is becoming urgent for those people. So thank you very much.
Thank you.
Representative Reeves.
Just one, I had one more question for you. How are individuals who are living with disabilities, how is their input being brought about in this process, especially with the workforce status?
Yes, so Mr. Chair, Representative, yes, as I said, for the community support waiver, we have a technical advisory group, and that has people who receive services or want to receive services, family members, providers, managed care organizations. We have quite a large group there. In addition to that, we held a town hall where anybody can come and give input into the work that we're doing. And as far as workforce, which is a separate project, we are looking for direct support professionals or DSWs for their input, because we do realize that's very important. Many years ago, I was a direct support professional. I know that we really want to have the input of what it looks like for those folks on the ground and what they struggle with and what they are doing well so that we can support them better.
Committee, further questions? Very good. Thank you. Thank you, Michelle. And I don't mean to take this personally. This is just something that I want to get done before I die. How's that?
I know. I do take it personally. I'm very devoted to this, as is my team. And we are frustrated that we can't do it as faster. But I assure you, we are working hard every day to get this community support waiver off the ground.
Well, you're off my weekly phone call list, you know.
Okay. Thank you.
Okay, committee. Sorry for digressing. Andy, you have 20 minutes. Madam Secretary, you have 20 minutes.
I'll step in for Andy. He's ill today.
You'll be sitting here talking to an empty room.
Thank you. No, I'll make sure that we get done. This is a little bit of kind of the rats and cats, as they kind of say in the legislative world. Just a few other things you asked for that didn't maybe fit well into someone else's bucket. The first, you've talked about this a little bit this morning already, and then yesterday, in terms of community care coordination update related to KanCare. And as you know, that was part of the MCO contract. And KDHE and KADS have been working closely with the MCOs on this and have approved an MCO request and referral process.
There we go. For members to access community care coordination and have, done just a lot of the administrative pieces. The MCOs will be responsible for ensuring entities that are employing community care coordinators are conflict-free and that they don't provide HCBS services, and also for developing any contingency plans if there are any gaps in community care coordination capacity. One of the focus, community care coordinators, the focus is really that those coordinators would be in members' communities, know about local resources, be the member's primary point of contact. And again, these are not targeted case managers. This is really about addressing specific needs that a KanCare member has, often to coordinate access to non-Medicaid service needs. It'll also be used by MCOs to avoid duplication and gaps in services. And I think one of the important things, and I think this maybe was referenced as well yesterday, is we also want to make sure that this works well and aligns with the kind of work that community health workers are already doing. There's not an overlap or a duplication there. So again, the agencies are talking closely with the MCOs about kind of design. And although this won't be fully implemented, this year, the MCOs are looking to start a pilot program in January. And so we'll have probably have more details on that at your next meeting in terms of what that actually will look like in terms of that pilot. So we're paying a lot of attention to this. It was never intended to be kind of a year one piece with KanCare, but it's clearly on our plate. And as you heard yesterday, there will be a fiscal note attached with that, and we'll have to bring that back to you all in the future as the program gets further designed. The second piece I wanted to talk about is just the State Plan on Aging. KADS is the agency that receives Older Americans Act from the Federal Department of Health and Human Services. I was going to say the Administration on Community Living, but I think as of today, the Administration on Community Living no longer exists in HHS. So I'm not sure what that will look like in the future, but yet we have to submit state plans on aging every 4 years. So we have a new state plan that spans state fiscal year 26 to 29. This has been a long process that really starts from the ground level, working with the plans that our partners in the community, our area agencies on aging have and their area plans. Lots of feedback, lots of listening tours across the state to develop this state plan. And we just provided you just a few of the highlights of just what some of the goals and objectives are in the plan. We've submitted the plan. It's on our webpage if you'd like to look further at it. We need to wait for approval from our federal partners for it to fully go into effect on October 1. So again, we update that plan again every 4 years or so. Really a focus. Some things will look fairly familiar to you in terms of our areas of focus, in terms of streamlining access to information and community-based services. Really a focus on those older Kansans, particularly in rural areas who have the greatest social and economic needs. We know those are the areas also where there are, lesser resources. So definitely an increase on rural areas and what partnerships need to look like across systems. A focus on family caregivers. A focus on partnerships across state agencies and across regional and local organizations. There's some other work we're a part of as well in terms of a multi-sector plan on aging. And then issues around abuse, neglect, and exploitation. So again, the plan is actually on our website, or we'd be happy to provide that to you if any of you have interest in seeing more about that. We were also asked to report related to our KAMIS system. The legislature appropriated $1 million to KADS in state fiscal year 24 to look at upgrades or alternatives to KAMIS, which is a web application that supports those aging programs I was just talking about, the Older Americans Act programs and other HCBS programs. We did not get to that project in that first year that we had that funding. We had other projects that our IT staff were still working on, state hospital records, and we also share across DCF and KADS. Unfortunately, we reappropriated that funding in order to be able to do that work in this past year, but unfortunately, that reappropriation was taken away in the last legislative process. So that funding went away. So we don't have that. We do not have that funding, and we continue to look at ways to modernize. We've got a number of projects going on that we've talked to you about before, like the electronic passer for passer screening that's well underway, that we're excited about that project, and some other options. But the actual KMIS project is not on the table at this point because we were not able to retain that funding through the legislative process last session. And another item you had asked us to report on had to do with ABA therapy utilization. The ABA, Applied Behavior Analysis, are services that are really used related to services for individuals with autism. There's a number of Medicaid codes related to this. Some of these have to be performed by a BCBA, that's a board-certified behavior analyst or an assistant behavior analyst, and those professions are licensed by BSRB or a similar qualified professional with a master's degree with experience with autism. And then there's a code in the middle of that page that is a therapy code that can be performed by a registered behavior technician who works under the supervision of a BCBA. If you just look at this table just briefly, you can see some increases in those numbers in terms of the focus of the unduplicated number of persons receiving those ABA services, particularly in the last couple years. The initial assessment in 97151, some of the therapies in 97153. And then on the next page, you can actually see the amounts paid to providers under those services. And again, some increases. I mean, we certainly have shortages in the state, as most states do. And this would also be one of those things, if you had a map, you would certainly see a desert as you would go west, although we've had some improvement in that arena. But you had asked us to just kind of report on that, and that kind of fits well with the next piece, which had to do with the Autism Task Force recommendations. I formed an Autism Task Team, and this was back in 2021, just based on concerns and areas of focus about gaps in care and services for individuals with autism. We did give you a link to the full report, but I just wanted to mention just a few recommendations that really we've seen some progress on. I just mentioned the first one. You authorized increases in codes for that therapy code effective July 1 of 2024. And again, that certainly has helped to increase access. There also were recommendations that dovetail with what we've been talking about with IDD relating to the community supports waiver expected to launch. And also some recommendations related to ensuring access to state plan services, and some of the work related to EPSDT is certainly important in this arena, as well as the IDD crisis capacity building projects that were just talked about. So again, this is these are just like three things that were in that report. It's a pretty lengthy report. I was thinking it's kind of like the issues list that Bethel has. So if anyone would like more detail on that, we can certainly provide you more. But we just wanted to give you some highlights of some things that had come out of that task force, and actually some progress that had happened actually as a result of that. So again, those were the things I wanted to talk about just to close it up, Mr. Chairman. I told you I'd keep you within time and make sure you have some time for questions.
Thank you for that. Committee questions? You get off pretty easy when it's close to lunch.
At least one.
Representative Reeves.
Thank you, Madam Secretary. On slide 45, on that Autism Task Force recommendations, one of the recommendations was to either remove or raising the age limit to 21 for the use of that therapy code, ABA therapy code. How high, where does it go now? What's the age range, I guess, with that code now? Do you know?
I'm not sure of the, let me get back with you on the answer to that.
Because I know I've seen this a lot of times, that the request to raise it up to 21, but I can't remember what the.
I mean, I'm assuming it's 18, but I want to check that factually and get back to you, so.
Senator Owens. Oh, I thought. Representative Ballard.
Again, how many people are on this waiver?
On the autism waiver, yeah, it's a very
I
small
think when
waiver.
I looked at it before, it was roughly like 199 or 169 were on the waiting list, but we only had like maybe 60 some on it.
Yeah, it's back on. We actually have 61 people. It's a very, very small waiver. I think what I would say about that, though, is that most of the services that individuals receive under that waiver are services that they could receive under the state plan. So, so it's a little bit of a unique waiver from that perspective. So individuals are receiving services through the state plan that, like when I talk about ABA and things like that, those aren't just people on the waiver that can get that service.
That was the
So.
other part where I was going. I knew it was 60 something I had seen, but I just wondered why it was so small. But they are reserving additional services.
Yeah, there are services on the state plan for those eligible for Medicaid, right? So, yeah.
Thank you.
Any further questions? One thing I just wanted to clear up when we were talking about the wait list and the concern about the cap with 400. So I would venture to say how many last year we had a cap of 500, but we offered a lot of people services that they did not take. And so that 4,000 number, and we're, 4,700 or whatever, 200 off of that, but there's going to be a lot of people just like last year that did not take those services that you offered that were taken off the wait list.
Yeah, I think, thank you for the question, Representative. It's been a complicated piece because you're right, we were able to take more off the wait list. So right now, we're right around the previous 4,800 cap. And then you added 200 slots, right? Which theoretically then would get us down to about 4,600. We also think we'll be able to remove about an additional 150 through, as you said, back to acceptance rates or non-acceptance rates in terms of offer rounds, which would get us down to about 4,500. I think unfortunately in the process, the cap was reduced further than the slots were put in. The cap was reduced based on the House Social Service Budget Committee recommendation. The cap was reduced by 500. And in the conference committee, or in whatever happened in the budget last year, right? When it ended up being 200 slots, the cap wasn't adjusted for that. So, so that's our point, is that there's not enough space to make up that difference. If the cap if the 500 slots had been authorized, we'd be pretty close in terms of the cap that was actually put into the bill. And if the cap obviously had been addressed when the slots were changed. That's the issue that we have. It's kind of, things just didn't get matched up at the end there. But again, we will be able to serve, we think, more than the 200 individuals, probably about another 150 more, based on what our experience was this past year with the 500, where we were able to serve, I think, more like 750 or 800. So
I appreciate that. You never want to set a goal that you can get to easily.
Hey. I won't answer that one, Representative. I was going to say with you as our chair, and we are always happy to be challenged. So I think we all have the same goals in mind. So thank you.
Very good. Thank you for your work. Committee, further questions? None? Okay. Committee, I know this might be a stretch, and maybe I should ask the MCOs. What if we shorten lunch by 15 minutes? Would that? Never mind. It was just a thought. See you at 1:30. Okay, we're going to go ahead and start the meeting. We'll let our colleagues trickle in here as they, maybe they do and maybe they may not come back. So we don't know. Okay, the first item of business is Managed Care Organization Network updates. We've got. Trying to set the mood, Pat? Nap after lunch. Very good. Thank you.
And status for that. So once again, I'm Dr. Teresa Wesley, Chief Medical Officer with United Healthcare, and I have the distinguished pleasure to represent all of the managed care organizations here today, Community and State Plan of Kansas, Sunflower, as well as Healthy Blue. You have before you our presentation, and I'm just going to highlight a lot of these talking points that I've actually set out on the agenda. So first of all, let's establish by defining complex wheelchairs. It is a subset, I'm not going to read it verbatim here, but I want to point out a few key points. It is a subset of durable medical equipment that includes manual complex wheelchairs and rehabilitative wheelchairs, as well as power complex rehabilitative chairs. And the difference is, in summary, is that complex wheelchairs are medically necessary for individuals who, and they are configured for those individuals who have severe debilities that make it difficult for them to ambulate on their own. And so when we're referring to wheelchairs, it is divided up into three components. It is the chair, the options and accessories, as well as the seating. And all of them have their established criteria for reference. And then going to the next slide, we're going to talk about the equipment categories for these wheelchairs. And so before you have the manual rehabilitative wheelchair. It's a highly configured chair for individuals to help with their ambulation. And some of the common codes that you may have seen or may have heard about are the K0005 as well as the K0009 and the E1161 and pediatrics E12XXX. And the power complex rehabilitative chairs are a little bit more in detail in regards to what it's able to do for the individual who has more debilities. It's designed for individuals with complex medical needs and that require advanced intervention in regards to seating, positioning, and mobility. In most instances, when you think of a complex rehabilitative power chair, you think of an individual who has a debility like, for example, Christopher Reeves. There are about 30 codes that fit into that category of chairs. And these codes that you may have point of reference would be the K0851 and the K0856. And within this category, you may have heard of Power 3 complex power wheelchairs, and that fits within that category. Like I shared before, also included in this is accessories, modifiers for wheelchairs. And this makes the wheelchair more customizable for the individual and their individual needs. You have the seat and the back cushions, as well as power tilt, as well as recline options. You have headrests, leg rests, as well as other positioning supports. Now let's talk about the criteria. The Kansas Medicaid Guidelines, or KMAP, which is the Kansas Medical Assistance Program, and you can find that in KMAP on page 80, that is our North Star for all the managed care organizations. And basically what it entails is the criteria required to actually qualify for these types of wheelchairs. They're for individuals that are not able to sit safely in a conventional seating surface. They require a specialized position for safety to safely perform their mobility-related activities of daily living. And they have one or more of the following limitations: significant head or trunk instability or weakness, as well as significant hypotonicity, which is lack of tone, hypertonicity, which is more rigor in tone, writhing movements, ataxia, loss of muscle control and coordination, spasticity, spasms, and that result in uncontrollable movements and position change. Absence or latency of protective reactions. They're not able to independently protect themselves from a fall. Inability to maintain unsupported seating positions independently. And just so you know, and this is wonderful, as of January 1 of 2025, the specialized wheelchair seating assessments are not limited to previously identified wheelchair seating clinics. And Christine touched on that this morning. Another point of reference for criteria is that of our nationally recognized, widely accepted source for clinical guidance. And for that piece, we actually, after utilizing KMAP, can lean into interqual. There's one MCO that leans into MCG. Then, if there is a silence in KMAP, as well as within the nationally recognized accepted source of guidelines on any particular thing, such as accessories, then that's when the managed care organization can lean into their own unique policies that are approved by the state. Now we're going to talk about and give a high-level overview of a visual of the general authorization process that all three MCOs utilize. First, the prior authorization is submitted. The managed care organization, utilizing its internal processes, has medical professionals review, such as medical directors. For example, at United Healthcare, we have a complex rehabilitative technology specialty team made up of medical directors and RN, and we have an assistive technology professional, also known as an ATP, that supports the team as well. The information is reviewed, and if additional information is needed, then there is an outreach to the provider. The determination is made, and communication is rendered. If there is an adverse determination, a peer-to-peer is offered. Overall, if there's lack of needed adequacy to fulfill the KMAP criteria, then that's when the denial comes. On the next slide, there's a breakdown of individualized data, and I have the privilege of being able to share the information before you. There's information regarding the initial denial rate, the average time for final approval, median time for final approval, number of requests, average cost, Medicaid payments, average time when ordered by seating clinic, median time when ordered by seating clinic, average time when not ordered by seating clinic, and median time when not ordered by seating clinic. Common reasons for denial is a discrepancy between documentation or lack of growth documentation or lack of needed adequacy to fulfill KMAP criteria. The timeliness of approvals, essentially, it can be a little bit confusing to understand because in essence, and sometimes it appears to be a lengthy period to gain authorization and resulting in a high denial rate. What most do not understand is that the time is required for each of the decisions includes the duration well before the health plan is even made aware of the case. The signification proportion of complex wheelchairs relative to standard power wheelchairs implies that the initial request may indeed not meet the service level supported by the existing documentation. And additionally, history shows that many adverse determinations for pediatric wheelchairs are due to equipment classified as a non-growing stroller, whereas the state has clarified in its previous policies that those were not covered. At United Healthcare, and collaboration with the other two managed care organizations, we have worked tirelessly to work with our state collaborator to update policies for the enrichment of each and every member that we serve. We have worked with each other in a collaborative agreement and arrangement to update the KMAP manual for wheelchairs. The objective of this update is to create the KMAP manual to make it a one-stop shop for reference guidelines and to be an updated real-time resource for reviewers can utilize rather than going outside of KMAP to seek clarity from other clinical guidelines. United is honored to have been a part of leading in this process and working with the state and with our MCO counterparts. In regards to reasonable use, average median lifespan of these complex wheelchairs, there's a lot of information that goes into the possibilities as to where the origin of a wheelchair actually can come about. Most of the information is housed within the state, and on average, the average lifetime of the wheelchair is that of 5 years. In certain instances, depending on wear and tear, it can actually go up to 7.5 years. And this information is actually coming from CMS as well. All three of the managed care organizations continue to work in collaboration with our KDHE chief medical officers to enrich the experience for each and every individual member, as well as the providers and their families. Committee, I will stand for questions at the appropriate time, as well as my counterparts.
Very good. Thank you. Thank you. Committee questions? While Representative Bueller's getting a question, I do have some. I'm looking at your chart here, authorization data. So from our testimony earlier today, we have doctors and therapists and everybody telling you guys that you need a wheelchair. Mm-hmm. And yet I see with United, I see a 38% denial rate and a 29% on Sunflower. And then what would be the, do you have the numbers that would be the actual time that how many times they were denied before they got it? I mean, this says initial denial rate. So I'm assuming that it was denied the first time and then they maybe applied again and then maybe another time and then finally approved it?
So in various aspects of the wheelchair journey and request journey, there is a process through the prior authorization system, as we discussed, and I appreciate you for asking this question. This does not include, and it also includes the redeterminations and evaluations. So there may be some split decisioning that could be included in this. And we have all stated at a roundtable with the other managed care organizations that indeed we have the same opportunities for educating our DME providers as well as our additional providers in providing the information needed to make the appropriate determinations, and we've all stated that. At United, we have stuck stringently to our KMAP guidelines, and that is why, and a lot of those denials actually come from the growth restrictions, and that is why we have been spearheading and working with them in regards to updating the policy, and the policy will be updated in September 1st of 2025.
September 1st?
Yes, sir.
Okay.
Mm-hmm.
Representative Bueller.
Thank you, Mr. Chair. So when I'm looking at your flow chart, I mean, it appears to me that there is a block missing, and it should be the first block is that you have a physician that orders the device, and then you get into your prior authorizations loop. Is that correct?
Yes, there's a physician that orders the device, and then we get into our PA loop. Yes.
And so, again, I reference that back to some of the committee testimony that we had this past session, and the frustration with this is that, and for those who are in whether it's the manual complex, rehabilitative wheelchair, or the power complex, especially with regard to repair parts and those kind of things, and people getting caught in the loop of equipment they already have and they need repair parts for it, and they get back into this do loop of the prior authorization makes absolutely no sense to me. And then also maybe back to Representative Carpenter's comments about the length of time it takes to the initial, or pardon me, it's not the time. To some degree, it is time. It's also the initial denial rate. And it goes back to your flow chart. There's a physician in this process who's highly educated. It doesn't seem to me that if you've got a highly educated physician, that there ought to be an initial denial rate of almost 40% from United Healthcare. That just seems off to me. And I understand that the insurance that we're trying to protect taxpayers of Kansans, but these are people with really unique needs. And I know I'm preaching to the choir, but as we talked to those people last year, that's their lived experience. And so that would be the area that I would seek to find some improvement for those people who live in these wheelchairs. It's not in a wheelchair, it's their exoskeleton in many cases. I don't know if you have a comment or a
I do
thought
have
on
a
that,
comment on that, and I totally agree with everything that you've stated. And we are boots on the ground in regards to updating the policies, and we have updated them to make sure that it is as seamless as possible for the individuals who are requesting this, because it is indeed a part of their life and impacting their independence. And to that point that I made earlier, that there is a lot of time in the lag time in regards to when the actual request is made in a doctor's office, and then when the evaluation is done, and then when the managed care organization receives it. When we go through these processes, there was a lot of denials in regards to growth and growth capabilities and limitations. And so we brought that to the state and thus created a work group to spearhead those changes. And all three of the managed care organizations attest to that being an issue. However, it appears that we were definitely aligned and stringent in regards to the KMAP criteria, and thus we are advocating to, and made the changes that go live coming up soon.
And that's September?
Yes, sir. September 1st, 2025.
Any further questions? Senator Petty.
Thank you, Mr. Chairman. So when I'm looking at the authorization data, and it says initial denial rate, would that encompass whether it's a denial for a upgrade or whether it's denial for initial chair?
So that includes all of them, encompassing as far as initial chair or upgrade. Those are all inclusive within that.
All right, thank you.
Committee, further questions? Just a quick one. So you're going to cover, we've had the definition complex, the denial process. Are you going to cover, is there another slide here, or is it all in that one?
It's all encompassing within that Visio. Yes, sir, you're correct.
I didn't see much on the denial process or the number. I didn't see a lot of the base costs. I guess I missed that part of it. Okay, very good. Committee, further questions? Seeing none, thank you very much, Teresa, for being here.
Thank you.
Okay, next we have, there is a Healthy Blue person here available for questions, and also someone from Sunflower, if committee has questions about wheelchairs.
Thank you.
Representative Buehler.
I would just like to know if they have any, and I get that Dr. Wesley was representing the group. I would be curious as to if any representatives from the other MCOs have an opinion they would like to share with the committee. And if not, that's fine. Excuse me. Thank you.
Is there anything else you'd like to share? Okay. All right. Very good. Thank you. Moving on. Susan Harris. Is that you? Okay. Welcome to committee.
There we go. Hi. Thank you for allowing me to come speak with you today regarding the CHAMPS program that the Older Americans Act and the AAAs have in the state of Kansas. I appreciate the opportunity. I am the executive director for the Jayhawk Area Agency on Aging. We serve Shawnee, Jefferson, and Douglas County, and as you hopefully are all aware, there's 10 other area agencies on aging that serve all the remainder of the counties in the state of Kansas. The CHAMPS program is a program for congregate meals funded under Older Americans Act C1 funding. It is the name of a particular program that several of the AAAs have, but it is a voucher type program for the Older Americans Act services for congregate meals. We started ours in July of 2011, actually in a small cafe in Oskaloosa, Kansas. So it is completely a program that is completely doable in rural areas. We started that program because we saw the congregate meal sites attendance declining, and it was a way to further serve the older adults in that area. Since then, we've expanded. Jayhawk has 14 sites total in our 3-county area. Many of them are at grocery stores within their deli areas, Dillon's and Hy-Vee specifically, and we have some in restaurants in all 3 of our county areas. There are other AAAs throughout the state of Kansas. There's 5 of us total that do have either a CHAMPS program or a voucher program. They may not call it CHAMPS, but it is a voucher program. Those would be Johnson County Area Agency on Aging, East Central Kansas Area Agency on Aging, Central Plains Area Agency on Aging, and then Southeast Kansas Area Agency on Aging. So those are the 5 that have them. CHAMPS itself stands for Choosing Healthy, Appetizing Meal Plan Solutions for Seniors. It's a mouthful of an acronym, but it's as I said, an alternative to traditional congregate dining sites where you might find those at senior centers or other independent living apartments and things. It allows the older adults the opportunity of not only where they eat, but when they eat. Anytime that particular restaurant or deli or cafe is open, and they can have breakfast, lunch, or dinner. It also allows them the opportunity to eat with whomever they want. They can go with family members, and the family can buy a meal, and they can get their CHAMPS meal through the program. Most of the CHAMPS programs or the voucher programs have an orientation type process where they come learn about the program, and through that they're explain to them that the meals are based on federal guidelines, because this is federal dollars, and based on the percentage of the dietary reference intakes through the dietary guidelines for Americans. Each meal is supposed to encompass 1/3 of those regulations. So some restaurants, it is difficult to come up with CHAMPS menu offerings, especially some of those small town mom and pops where, they're cooking the green beans in the bacon fat and, it tastes really, really good. Those things may not meet the dietary requirements, but it is possible to work with the restaurants and a dietitian. We contract with one. Some of the AAAs actually have dietitians on staff, but to really look at the menu offerings at the restaurants and piece together a meal that would work amongst what all they're already serving. I have provided in my written testimony a link to the dietary resource if you're interested in delving that far into the meal requirements. But we hold, through our orientations here at Jayhawk, we hold 2 in-person orientations a month, one in Shawnee County, one in Douglas County. And then as we get groups of people interested in Jefferson County, we will hold orientations in that county as well. We also have an online option for orientation where people can watch a video about the program, again, where we explain the dietary guidelines, how it works. We also strongly encourage through that orientation and an understanding of donations for the program, because donations to the Older Americans Act programs just allow us to expand those dollars further. And then, of course, with any federal program, there is paperwork that has to be filled out where we collect demographics and information regarding the customer. And then they are given a CHAMPS swipe card, looks just similar to a debit card, and then wherever they choose to go at any of the participating restaurants, they can choose what they're having off of the menu options and then use that swipe card, and that's how the meal is paid for. When folks need to reload their card or add more meals to their card, they can reach out to our office. And again, our suggested donation is $3.50 a meal. We don't require that as a donation, though. If folks can donate, we gladly accept. If they can donate more, wonderful. If they can't donate that much or any at all, that is fine as well. They are not denied due to inability to donate to the program. That was very fast, but that's a nutshell. Are there any questions?
Very good. Thank you for that committee. Representative Reeves.
I see that, you find the question here. So it's been expanded 14 sites throughout Jayhawk Planning Services of Shawnee, Jeff, Douglas counties. Okay, and it says locations include grocery store delis, a rural hospital, and restaurants. So I can see where the delis and the restaurants, how they would participate. How does it work with the hospital?
The hospital, so it's actually, our rural hospital that we're utilizing is in Winchester, the FW Houston Hospital. So they were able to come up with menu selections that worked with their dietitian for the CHAMPS program. And they go to that hospital, to the cafeteria, and order their meal. And they can either eat it there in the cafeteria, or that particular hospital also has a nursing home kind of attached to it with a sun porch that they can opt to go to there to eat it as well, or take it to go. We do allow folks to take it to go. We have quite a few caregivers that actually utilize that for their loved one, where they can, on their way to visit their mother or their grandmother or whomever, stop and pick up a meal with that person's card. And then when they go visit, they can just be a family member visiting and don't have to worry that night about cooking a meal.
Committee, further questions? Representative Petty. Oops, I knew I was going to do that.
You know, we're all elected.
Um,
So my question is.
Senator Petty, just
Thank you.
There you go.
On whether it's the hospital side or whether it's a restaurant. So if I was if I had a CHAMP card, when I go in, are there specific menu items that have like the CHAMP logo by them or whatever?
Yes, there are specific menu items, so those restaurants are aware of what is allowed and not allowed. At the Dillon stores, for instance, in their deli cases, there's little, I don't know what to call them, a little placard next to what would count as a meal or as an option selection. Mm-hmm. Yeah.
Representative Ballard.
Thank you, Mr. Chairman. Okay, you mentioned CHAMPS and explained what it was in vouchers. Is there any difference in those two?
Not a whole lot, other than with the voucher program, and I believe it is just the East Central that is not called CHAMPS, and it's a voucher program, and it's, you actually have to go to the office and they give you a coupon type voucher that you present as opposed to a swipe card.
That's the difference.
Yeah, that's pretty much the only difference. Otherwise, it's a C1 Congregate funded Older Americans Act program.
Approximately how many do you serve?
That is an amazing question. I'm going to say about 5,000 people are on our program. I couldn't give you a number statewide. I don't know that information.
Okay, thank you.
Very good. Well, thank you for that. I first, when I spoke to the aging folks last year, I had one of the previous representatives called me up and said, what, you know, they're struggling with their local restaurants in small towns. And he was like, isn't there something that, and the senior center down the street is fixing all these meals, which is kind of competing with the restaurant. And so I made some calls, and voila, there was a program that they could serve the meals at the restaurant and get reimbursed and everything. But the big hangup, like you said, has been the dietitian, because they have certain guidelines. But I still think it's a doable thing, and I hope that all of us could work with getting that word out there to our local senior folks, that they can go down, that the restaurant could be involved in this. So
Yeah, absolutely. And I just will add that East Central Kansas, Southeast Kansas, they just opened a site in Trago, Kansas, of all places. Very, very small community. So
very good. Very good. All right. No further questions, committee. Thank you very much for being here.
Thank you.
Okay. Sorry. Senator Peck.
Thank you, Mr. Chairman. I've been sitting here debating whether I should ask a question because I want to make sure I heard right, so I'm going to ask that first. Did I hear you say that a family member headed to visit a senior could take their CHAMPS card and get the senior's meal and take it to them?
Yes, we do. We at Jayhawk do allow that through our CHAMPS program. Not every CHAMPS provider allows the grab-and-go meal option for that purpose, but
How do we make certain that there's no fraudulent use of these CHAMPS? I go get the meal. I say, this is for Dad. Dad never sees the food. I consume it.
that is a great question. Unfortunately, we don't have the ability to, prove that that meal made it to the older adult that it was intended for. We hope that that is happening, and we're hoping that those caregivers that are doing it. But as far as they're only allowed one swipe per day, so the card itself and the program itself doesn't allow more than one meal. But yeah, that is unfortunately a risk that somebody not on the up and up may not be taking that meal.
Not necessarily verify with the card holder that they received a meal that day.
We're not currently doing that. I mean, that would be administrative task that we could take on, but.
Which would be a challenge, but.
Correct.
I can just see abuse potentially happening.
No, I completely understand your concern. Yeah, yeah.
Mr. Chairman.
Any further questions? Representative Ballard.
Sorry. In response to the question you just heard, what if I am the individual and I send my son to pick up for me? Since you don't check, we're on the assumption that that was legitimate, he would bring it back. But if you call my house and said, well, did you receive my meal? I would be a little offended because, I mean, that was a family member of mine that came for that. So I'm wondering, was the implication that somebody fraudulently would try to get a meal free and not be qualified for it? Was that the purpose of that question? Are we talking a large community or a small community?
We're talking a smaller number of individuals that are
So
doing
there's
that
likely
through
someone
caregiving.
who's working would recognize that maybe this is a family or somebody that comes in because it's very small.
Correct, yeah, and the requirements are that you have to be 60 or older. So, a very younger looking person, the eatery or the deli may question, whose meal are you getting? But unfortunately, we don't have a way of knowing that your son went to pick up that meal. We know your card was used, but not necessarily who it was used by.
There's somebody who would question it.
Yes.
Thank you, that's what I wanted to know. Thank you.
Senator Petty.
Just as a follow-up, because I think you did say this. So we see here that this CHAMPS program is being used in several parts of the state. But you were referring to with this particular option, it's just yours
local
that's
area.
allowing that.
Yes.
Okay, thanks.
Yeah. So each area can set slightly different guidelines as long as they fall within the federal requirements. Yes.
Very good. Further questions? Thank you, Susan, for being here.
you.
Appreciate it. Let's try to get the word out and get more of these going. Okay, committee, we're not going to take a break now. What's that?
Can we take just enough time to let them in because we have several people in the hallway that are going to testify?
There's not room in here for them.
Right, but they're testifying. So do you want me to open the doors?
Yeah.
Okay.
Oh, of course. I'm like, there's chairs out there. All right, come on in, folks that are out there. And all right, is that everybody out there? Apparently. Okay, very good. So we have 25 folks here, and so what we've done is 4 minutes apiece. So and you will be timed. So, all right, very good. So first off, Mike, time's up. We're making time. We'll make time for everybody else.
See, I figured he'd at least wait till I introduced myself and then, oh, time's up. No, thank you, Mr. Chair. And I will do my best to try and set that tone to be under and hopefully yield some time back to everyone at the end. But so I'm Mike Burgess, and I'm the Director of Policy and Outreach at the Disability Rights Center of Kansas. And appreciate the opportunity to be here today and share this. The first thing I just want to hit, and I know you all know this, and I know the schedule's tight, but we will continue to appeal to the LCC to give you all more days so we can ensure that you have time for public comment during this. Because as you all know, written only is not the same thing as when people can come here in person and you all can ask questions. And this is just such an important committee, and the work that you all do to be able to have that chance for people to come and share their stories and you all to ask questions is so important. So thank you for having the public comment and giving us this chance. Next, just wanted to update you on the IDD and PD waiting list progress. And I know you had things earlier today. I appreciated the great questions. I think the agency they have to be conservative with the numbers, so I'm hoping that it is smaller. But I do hope that if we do end up having to use the waiting list cap this year, that you all will do that and continue to make sure that we do not move backward. Because again, that is a brilliant idea. And I think I've shared this before. We had other states contact us like, well, how did this? I'm like, well, we had the legislature came up with this. So it was legislators, and it's a bold statement and it's a brilliant idea. So I want to, again, applaud you for your leadership on this. We're year 2 of the 5-year plan to eliminate the waiting list, and we just got to keep making progress. So next, and I think there was, again, earlier session yesterday, information on the waiting list mitigation for the brain injury, frail elderly, and TA waivers. I'm happy to participate in those, and I think it's probably going to be a twofold thing. I think it sounds like there's some administrative things that we can do to kind of make sure that people that no longer need the waiver, that we move them off while respecting their rights, obviously, but move them off as quickly as we can, and then just come in with a plan to address it, but we may end up needing a little bit of funding there as well. So obviously, I want to encourage you all to stay engaged on that and make sure that we don't end up with waiting lists on those other waivers. Just wanted to provide a very brief update on the IDD stakeholder meetings that KADS and Interhab convened. It was, my March and April were pretty crazy because they ended up forming 8 subgroups, and I, just to make sure and have kind of a holistic view, volunteered for all 8 of those. So I had 8 one-hour meetings a week for 2 months, but it was an amazing opportunity to really get a lot of stakeholders together. And I think there was a lot of good process and recommendations that came out of that. And it's a give and take, and it was a consensus process. No one was truly happy with everything, but we all came together and had meaningful discussions on those. And then just the final thing I wanted to point out, KADS did a contract on an Employment First pilot, and KU, and you all have been briefed on this as well. I was fortunate enough to be on their steering committee and get regular updates on it, and that's just been an amazing success with 4 providers, and we haven't really done the funding and the other pieces to the policy, but just with training and an emphasis on Employment First, they have had amazing results, and they've achieved in a little over a year 170 jobs at an average hourly wage of $13 an hour, and I think most folks are pretty close to that $20 or 20 hours a week. What we've been reported on. So they're meaningful jobs, meaningful wages, meaningful things, and this is just with the training component. So I think as we get the other pieces in place, you know, that thing is gonna, there's a lot of opportunity out there. And so with that, Mr. Chair, I'd be happy to stand for questions at the appropriate time.
Committee questions? Seeing none, you're off the hook.
All right, well, thank you. It's great seeing you all.
Next, we have Kylie.
All right. Good afternoon, Chairman and members of the committee. My name is Kylie Childs. I'm the Director of Government Affairs with Leading Age Kansas, the state trade association for nonprofit and other mission-driven aging services providers. So you have our full written testimony outlining several updates and issues concerning aging services providers, but I'm going to highlight one key one at the top of that for you today. Many providers have continued to face delayed payments and prior authorization denials with Healthy Blue. So while individual providers are working with their reps, we've also had some one-on-one meetings and some group meetings with the other associations and raising those concerns. They did acknowledge there is currently a coding issue in their claims system, and that's what's contributing to some of the delayed payments. So they are working on that, and we appreciate their help with that. We would just like you guys to have eyes on that, since it could take another couple months, and this has been going on since around that February timeline. It sounds like the prior authorization denial issues stemmed from the transition from Aetna to Healthy Blue, so maybe a lack of communication or some communication gaps there that could have helped prepare providers for that starting in May. But we are hopeful that we'll be able to continue that communication and fill that gap. We've worked with our other long-term care associations and the other MCOs to start up our long-term care and MCO association meeting so that we can start meeting quarterly again and try and address some of these issues timelier. So that's all I have prepared for you today in verbal comments. There is some additional stuff in our written testimony, but I'm happy to stand for questions at the appropriate time.
Committee questions? Seeing none, thank you. Thank you very much for being here. Next, we have Tanya. Welcome to committee.
Thank you, Mr. Chairman. It's great to see you. It's great to be here this afternoon. Again, my name is Tanya Dorfbruner. I'm the Executive Director of Oral Health Kansas, and we are the state's oral health consumer advocacy organization. I'm here to talk about a couple of different things, but really I want to really start out by saying thank you for the Medicaid dental rate increase this year. It went into effect July 1st. I'm going to talk a little bit about that. Your investment, as you know, is a really key part of the multi-stakeholder Pathways to Oral Health project that we are working on that's entirely dedicated to improving the provider network. I think you all know that only about 30% of dentists in the state do accept Medicaid, so we're working on that, and we think this rate increase is going to have a big impact. In fact, just yesterday we presented on a webinar to some of the MCO care coordinators, and one of them told us she has noticed a change when she calls to find a dentist for a member. She said she wanted to thank everybody for the work we're doing on improving the Medicaid dental program, and it said it's really been helping. So I think that's to all of us, so I wanted to pass on that thank you. So as I said, the rate increase went into effect July 1st. As you know, it wasn't quite as much as we needed to do to get to the level we were hoping. So in order to implement it in a way that would have the most impact, we worked with the Kansas Dental Association and did a survey of dental providers to prioritize the increase. Because if you would have done across the board, it just would have diluted and not been super helpful. So I'm going to share what that result was here in a second, but just want to share, in addition to the concrete feedback we received, we also received several comments, and I'll be sharing more of those as we move forward in time. But many of them pointed to the fact that this is still a really serious issue, and one of them said the only way to encourage more dental offices to be Medicaid providers is to increase your fee schedule. So in the survey, the providers really prioritized the services that needed the rate increase most urgently, and the new increase really follows those recommendations. I really want to applaud especially Director Osterland and her team for following those recommendations. I think that speaks highly of her team, that they listened so carefully to what the recommendations were. So the recommendations and the way the rates came out were to increase exams by about 50%, cleanings by about 35%, X-rays and fillings by 20, and then all other codes by 10. So everything got touched a little bit, but the highest priority really got a pretty significant increase. So I'll keep you up to date on the implementation and how things are going. We're 14 days into it, so it's not anything to say other than we're sharing the news right now. You heard this morning some great updates from Director Osterland around sedation dental care too, so I also wanted to thank you for your supporting the rate increase for hospital sedation. That's the GO330 code. And as you know, the interim committee last fall recommended that you all supported that, and I think it's going to make a big difference. Another big barrier, and we've talked about this multiple times, but just updating you, is just knowing where people can access sedation dental care. So as you probably know, there's lots of different levels of sedation care. It ranges from just nitrous oxide in the office to there could be it could be in-office sedation with a mobile anesthesia provider, or it could be in the hospital, it could be lots of different things. So we're working with the MCOs, and in September we'll be launching a survey of providers to get a sense of, from all of them, which levels do you provide? If you do, what populations do you serve? So we'll have a really better sense of, do you offer sedation, but what does that really mean? So we'll be updating you about that as we go forward too. So just a few last comments. I put some resources in my testimony, and you've got some links in there. We invite you especially to take a look at our new Pathways to Oral Health website. I don't think it was even up when we were here back in March. This is, again, our project to try to increase the number of dental providers in the state. There's a great little video, so encourage you to check that out, share that. Also, just quite frankly, if you know of dental offices in your district that might want to become Medicaid providers, have them come and talk to us. There's a lot has changed because of your work. A lot has changed, and since the last time they took a look. So we'd like to work with them and help them maybe think about that. We're also providing a couple of new educational series for providers in August and September, so we can update you on that if you're interested. And just lastly, we'll be back next year to keep asking to finish the job and get those rates up. So thank you.
Very good. Thank you, Tanya. Questions for Tanya? Representative Ruiz.
It's probably not the right time to ask for this, but I'm really concerned about folks who have gum disease and need to have their teeth cleaned more often, like every 3 months.
Yeah.
And I know how costly that is. And Medicaid seems to cover twice, two cleanings, right? Have you heard of any states who are trying to look at specifically for gum disease and
there are
cleanings for every 3 months?
No, that's a really great question. And there are states that look at, maybe especially it might work with the MCOs doing some value-added benefits that are kind of creative. And that's one reason we're really happy they can get creative now. There are some states that do things like if you have a higher risk that you are going to need it more often. So there certainly is precedent for other states to do that. I can check into more specifically what states might do that around gum disease, but other things as well. That's a great question. Thank you for that.
Committee, further questions? Seeing none, very good.
Thank you,
Tanya. Rick, I don't see Rick. There you are. I was looking all over for you. Yeah, Rick Elskamp. Thank you for being here, Rick.
Thank you. Thank you for your continued work on behalf of the dependents and the disabled community. My name is Rick Elskamp. Me and my wife Anna are parents and guardians of our 24-year-old daughter Sheridan. She's on the IDD waiver, has several challenges related to her disability, which require full-time attendance at a day support service for her care. a primary challenge with Sheridan is unpredictable, aggressive behaviors. Now that she attends day support, all these challenges are clearly documented for her entire care team, including day support providers. We've spoken with numerous day support owners and operators about these issues, and they've reassured us that this is not out of the ordinary. It's something that they deal with as part of their jobs, and they have resources available to deal with that. To my point today, I would like to ask all on this committee and in attendance, would you feel it is appropriate and within policy for a day support provider, rather than follow the documented methods and service plans in place for delivering services in a situation such as ours, to make the intentional choice to call law enforcement, file battery charges, and issue a no trespass order against a client, all with the intent to bar the individual from their property, essentially kicking them out with no warning to the parents, guardians, or any due process. That's exactly what happened to our family earlier this year, in March 17th, actually. The facts of this situation were clear. However, after several calls and emails to officials at our CDDO and KADS, the result of the investigation that KADS conducted concluded that the day support provider was in full compliance in policy. We were shocked. The most concerning is the fact that the provider had submitted false statements that Sheridan was not dismissed by them, but rather could not return due to a lawful police order, which allowed them to avoid the requirement to submit a dismissal report to the CDDO or KADS. That day, when we, both me and my wife, went the day of that incident, the responding police officers told me directly that they were not making the decision for the filing of charges or the no trespass order. That was totally on the service providers. It was not their call. So of course, we were already looking for a different day support provider anyway, but they pretty much locked us out by doing this. All this information, including the police reports and the officer statements, were given to the KADS surveyor when this was investigated. And we were left truly scrambling to work our jobs, support Sheridan for a month without day support, and also deal with the legal issues that this had created for our family. During this process, I found out that policy Article 63 was really the only document that they used to manage and supervise day support providers. That and the CDDOs are given the leeway to make their own policy and enforce a policy for affiliate providers. I mean, it seems to me there should be more control, something updated in this Article 63. The last revision date was February of 2010, and there's been several changes since then. There just needs to be specific protections in place for parents and guardians to keep our situation from happening or to anyone ever again, and ask that something be done to make more policy and not allow this to happen. I'm sorry, I just don't know how better way to word it than that.
Thank you, Rick. Committee questions?
Yeah.
So as you know, I've been following this, and it's not over yet.
Yes.
So anyway, but how's your new folks going?
Oh, we're dealing with it. I just again, the fact that KADS has come back and said that they were in policy, and they pretty much believe that their statement that it wasn't them who did it, but I provided the documentation, I provided the police narrative. It's all in writing, and so our view is KADS is condoning this type of action, and that's not right.
Very good.
So,
thank you for that. Committee, further questions? Representative Ruse.
Thank you so much for being here. And Article 63, is that statute, Chapter 63, or what's it?
It's just referred to as Article 63. And it's just it's like a 15-page PDF. Most of it has to do with the process on getting a license for a HCBS service provider and how to keep your license renewed. There are a few things about delivering services, but one is for providing false statements, which obviously they did, and also providing dismissal reports, which were not done. So,
thank you.
Thank you.
Very good. Thank you very much, Rick.
Thank you.
Thank you. Okay, next we have Jeff Glasgow. There you are. Very good. Welcome to committee.
Thank you. I'm going to make the creaking sound. Thank you, Representative Carpenter. It's good to see everybody again. As you know, I'm Jeff Glasgow. I'm the principal owner at Advanced Specialty Anesthesia. We're also known as ASA. I'm also representing another practice of SAS of Wichita as well. We've provided over 4 written testimonies in the past 8 months regarding the unequal compensation for sedation services of children and special needs adults of the KanCare program. We ask that this committee put a recommendation into your report that a Medicaid code be established by KDHE for mobile anesthesia in a dental office setting for the case rate of $2,915.18 for qualified mobile anesthesia practices. Now, this is not a new cost. This is already budgeted for the 2026 facilities. The state general fund will not be affected, and this is simply an allocation for mobility. In my written testimony, I've explained the cost and the effectiveness of our practice, and we continue to excel providing services to the most impacted populations of KanCare children and special needs adults. We have over 60,000 Kansans that have a disability with a cognitive issue, and these patients have Medicare as their primary and Kansas Medicaid as their secondary. These patients are called the dual eligible special needs plans, or DSNP. I've explained in detail in my written testimony that providing these services are a negative cost to us. We lose money seeing these patients. The reimbursement doesn't cover the anesthesia provider, supplies, or medications, and this is a loss in revenue. So we lose money, but continue to provide the service across Kansas. But a facility gets paid, and I've explained in the past why dentists don't like to go to facilities and why dentists don't like to go to facilities. The state has a 30% responsibility for the DSNP population. So, as always, I'm here for a compromise. I'm providing the same product. I have the same equal costs and equal liabilities. I'm providing a mobile facility for all of Kansas, and that is Kansas City to Atwood, Atwood to Liberal, Liberal to Pittsburgh, and everything in the middle. I should not be penalized or discriminated on reimbursement because of our mobility, and also we've provided over 20 years of commitment to serve Kansas. By recommending a code to the KDHE for mobile anesthesia and dental office setting for the case rate of $2,915.18 from the KanCare MCO cases, this will offset the loss that we take when we see the DSNP patients. I've provided guidelines to KDHE for qualified mobile anesthesia practices. I've also provided pictures in my testimony to show that what we do with 18-month to 4-year-olds on a daily basis, and I'm always open for questions.
Very good. Thank you. Committee questions. I think there was some discussion from KDHE earlier about trying to work on that mobile code.
Yes.
So
we are in discussions with them.
Okay.
We just need your recommendation for a code that says mobile anesthesia in the dental office, this amount of money.
Okay, very good. Thank you.
Thank you.
Thank you very much. Okay, next we have Jeremy. Okay. Thank you for that. Next we have Ryan. Ryan, welcome to committee.
Hello. My name is Ryan Jolly, and I'm speaking today as a member of the Kansas chapter of a national grassroots organization called Little Lobbyists. It's an organization that advocates on behalf of disabled children around the country. Myself, my children, and the other families that have joined us today are here to show you that we are the faces of Kansas Medicaid. We're not line items on a spreadsheet. We're families just like yours that are doing our very best to live good lives for ourselves and our disabled children in the state that we all love. 2 of my children, and many of the others in attendance today, receive services under the Home and Community-Based Services Waiver provision of KanCare. The waiver that my children rely on is a Technology Assistance, or TA, waiver. And the word technology in that waiver name may lead you to thoughts about a cool app on your phone or the new iPad release. But the technology that we're talking about covered by this waiver is life-saving medical equipment that provides feeding pumps and special formula for children that can't eat, respiratory support for children that can't breathe on their own, monitoring equipment for children that can't regulate their body systems, and so on. One of the most significant features of the waiver is a feature that is simply not found in commercial insurance plans. It's home nursing. The staff that is required to utilize this equipment and provide direct care for our children is only available to us under the TA waiver. By taking on those responsibilities, our nursing staff make it possible for us parents to work to support our families, to earn a living, to contribute to our economy, and pay taxes. This waiver is intended for, and I'm quoting the waiver here, children aged 0 to 21 that require hospital-level care to prevent further disability or death. In other words, the technology that supports the necessities of life to sustain their lives is what this waiver provides for them. That hospital-level care is only available in 2 settings, at home under the waiver or in a hospital bed. We understand, as do you, that when sweeping Medicaid cuts are enacted, the optional benefits will see a cut in services first, or there will be outright discontinuation of services like the home and community-based waivers. They are an optional benefit. The TA waiver, the thing that we rely on to keep our kids alive, is optional. I come to you today on behalf of my children, the families in attendance, and the roughly 850 TA waiver children in Kansas to ask you, our legislators, a question. What is the plan? How does our legislature intend to provide the hospital-level care these children require once home and community-based services are cut? Some have suggested that because hospital benefits are mandatory under the Medicaid program, they may fare better when these cuts come down. Therefore, care in a hospital may be an alternative for our children once that waiver is cut. We're going to set aside the utter inhumanity and cruelty of that. And let me remind you, or perhaps share with you for the first time, in the entire state of Kansas, there are fewer than 250 dedicated medical inpatient beds for children. 850 children requiring hospital beds for hospital-level care because their home-based services are cut, and only 250 in the entire state. So I ask again, on behalf of the most vulnerable children in Kansas, what is the plan? How does our legislature intend to provide the hospital-level care these children require once the services that keep them alive at home are cut?
Thank
I'll
you,
stand for
Ryan.
questions.
Representative,
It's all right, Mr. Chairman, you just missed me. It's okay.
I did.
It's all right.
For context, he was my seatmate for, so anyway, Senator.
Yeah, thank you for being here. So, earlier yesterday, we reviewed some of the changes to Medicaid regarding the HR 1 that recently was signed by the president. I didn't see anything in there about these waivers being cut. Are you speaking about something that you're anticipating coming or cuts that you know have come?
I'm going to use a little bit of critical thinking here. And when the federal funding is cut, I would imagine that the legislature and this committee are going to look at what is mandatory to continue participation in the federal Medicaid plan and look at the mandatory spending, which then puts optional spending on the table for cutting. These home and community-based services are optional benefits. So we anticipate that they will be first on the chopping block because they are not required.
Okay, and I completely respect that, and I want to be very careful and sensitive when I say that this legislature has been very specific about increasing funding for HCBS waivers, for IDD, PDD, and all of the waivers, at least the years that I've been here. So while I don't know if anything is coming from the federal government during our review of KanCare and the changes, this wasn't mentioned in there, but I just want you to be rest assured that this legislature has sunk even more and more funds into this program. And I don't say sunk in any of a derogatory term. This is an incredibly important function of government. Taking care of these children and these adults on these waivers is incredibly important to many of us. And I just want you to know that, you know, we're very cognizant of what you're saying. And, but I just wanted to clarify because I haven't been made aware of any cuts. Thank you.
I, like many people, watch these committee hearings from home on live stream. You all look very different in real life than you do on the live stream. And on behalf of families like mine, we appreciate the efforts that the committee has put into place. We're looking down the future. In the lives of our children, we don't wing anything. We've got an A plan and a B plan, and if your backup plan doesn't have its own backup plan, then you don't even have a plan. So looking forward to the future, we're trying to anticipate what we can see happening. And we appreciate the efforts of the committee to fund the home and community-based services. But we also acknowledge that when whatever these funding cuts look like, there will be cuts. That's just what the legislation says is going to happen. That the same consideration and same concern about our most vulnerable children be at front of mind for this committee. And we appreciate that dedication. We're going to hold you guys to that dedication to our kids.
Many questions? Further questions? I would echo the senators. I'd put this legislature up against anybody as far as what we've done for the folks in this state, and we have no intentions in doing that. And I probably have my ear to the ground as much as anybody on these federal cuts, and I have not heard anything. Although I do know KDHE is still looking through the impact of HR 1, but no.
Well,
I appreciate your concern.
Representative Carpenter, our families look at it as a partnership. Our families in need with this committee and our elected representatives. We have no doubt that everyone has the best of intentions. We're just trying to keep our needs in the forefront because it really is life and death for our children.
And I can appreciate that very much. Representative Ballard.
Thank you. Thank you, Mr. Chairman. And I appreciate that very much. I've been on social services budget for many, many years, and that has been a top priority of mine. And I would also say of my colleagues. In fact, you have the chairperson of social services sitting to the left of our chair today. I do, however, have concerns that you might have too, that when you read in the paper or you watch TV or anything else, that you see this has been cut, that's been cut, that's been cut, that's been cut. And then you assume that perhaps that's going to be cut as well. So, you know, I'm with you on the plan A and B, and then what C has to go to whatever next. But I would really have to say, we have been fighting awfully hard to keep our clientele, our consumers in mind when we do the funding on many things. And I think other people would say, yeah, we're doing a pretty good job. We're not patting ourselves on the back, but we just know how important it is. And you know, if I say I was just fighting by myself, I would be a little more skeptical, but I'm not just fighting by myself. That's a whole committee with 9 people. And we put HCBS services as well as oral health, any of those other things as a top priority. So I thank you very much for coming today to remind us, please, continue to do what you're doing.
We appreciate having so many allies on the committee.
Thank you.
Thank you.
Very good. Thank you, Ryan. Okay, next we have Patrick. Patrick, welcome to committee, and I think you are a stranger to this committee.
I am. Normally you will see Rachel Newman or her sister, Sam, who is our Chief Operating Officer at COF, kind of take the stage with that a majority
Very good.
of the time.
Welcome.
So thank you. Mr. Chair, members of the committee, thank you for the opportunity to share testimony today on behalf of families, professionals, and organizations that serve Kansans with intellectual and developmental disabilities. As board president of InterHab, it's an honor to be with you today, especially during this time of leadership change for us. In our new executive role. While we're in the process of that transition, I want to remind everybody InterHab remains strong, focused, and committed to serving individuals and also families with Kansans with IDD. We are grateful for your commitment, as was just shared, to the IDD community, your leadership, particularly through rate increases, weight loss slots, funded last session. We also know that challenges remain, and we know that we have a shared commitment for that along the way. Throughout this period of transition, the conversations we've had with stakeholders have reflected clear, consistent messages. We're united in that commitment, supporting all Kansans, providers, families, advocates, state partners. We're all focused on that same goal, which is ensuring individuals receive the support they need to live full, meaningful lives. We also want to acknowledge the tremendous effort put into the KADS work groups. These work groups, as mentioned before, were 8 subgroups focused on conflict of interest, assessment tool revision, and unbundling the day services. We're grateful for everybody that dedicated their time and expertise during this work. In closing, again, I want to thank you guys for your partnership and leadership. While obviously transition brings change, it also brings opportunity for us to move forward and keep on with collaboration and keep moving forward for everybody involved. So I will stand for any questions today.
Very good. Thank you. Committee questions. Representative Bueller.
Thank you, Mr. Chair. So Megan is the acting director, is that correct?
That is correct,
And
Megan
how
Shreve.
far down the path of whether she's permanent or not?
Sure. We should have that answer by beginning of October. We will know that.
Okay.
That's the transition timeline we have set up right now.
Okay, thank you. Thank you, Mr. Chair.
We look forward to it. How do you think your meetings are going then? We're supposed to have a report, what, next month, I think?
Yeah, absolutely. From Megan's perspective, they're going very well right now. We've met with KADS leadership and then also other stakeholder organizations as well too. All positive relationships coming right now.
Very good. Thank you. Committee further questions? Seeing none, you're off the hook. Okay, next we have no stranger to the committee, Aldona. Where are you at? There you are. Welcome to the committee.
Thank you. Representative Carpenter and members of the KanCare Oversight Committee, my name is Aldana Carney, and I'm the parent guardian to Neil Carney. Many of you have pictures of him, who is a 30-year-old young man with severe nonverbal autism. Neil has many complex needs and behavioral challenges. There are very few options for services for someone like Neil. We have battled for years to get something in place for him that is stable and secure. My husband and I are not going to live forever. Our biggest fear as parents is who will take care of him when we are gone, and will he have his needs met? The quality of life that we have worked so hard on to have in place for Neil seems very uncertain and in jeopardy right now. Frankly, I'm terrified. Neil is in Starkey's residential program and attends Catholic Charities Day program Monday through Friday. These services are primarily funded through Medicaid. Neil will need the same level of supports and services for his entire life. Yet, we have to fill out the Medicaid application each year. I break out into a cold sweat every time that application comes in the mail, in fear that I will fill it out incorrectly and he might lose his services. I don't know if any of you have ever had to fill out that application, but it's very confusing and frustrating. I believe that Kansas needs to push to make Medicaid benefits permanent for some disabled people. Neil will never hold a job and certainly can't go out into the community 5 hours a day, as KADS is now suggesting, but that doesn't mean that his life and choices should not hold value. Attending his day services during the week is his way of getting out into the community. The mothers and fathers here today are here because we love our children fiercely. We understand what they need. And as I like to say, we advocate like a mother. We are their voices, but they're our hearts. Thank you for your time and attention.
Very good. Thank you, Aldona. Committee questions? Thank you. Okay, next we have Cammie. Welcome to committee.
So Representative Carpenter and esteemed committee members, I'm grateful for the opportunity to tell you about my daughter, Charity. Charity is 41. She has Down syndrome. And for 20 years, basically all of her adult life, she has found purpose and sense of belonging and acceptance and joy in the Starkey Work Activity Program. She contributes to society by paying taxes, and she is proud to earn her own spending money. Last May, Charity had a total hip replacement, an invasive, painful procedure, and yet 4 days post-op, she wanted to get out of bed and go back to work. That is a testimony to how much she loves her job. Now, due to the IDD waiver modernization, that job is in jeopardy. If unbundling takes place as proposed, Charity and hundreds of other Kansas IDD waiver participants, through no fault of their own, will effectively be fired. Why? Simply because they choose to work in centers alongside their disabled peers, doing work commensurate with their capacity. And that will be regarded as not acceptable. Meanwhile, competitive integrated employment is exalted as the only worthy career path. But I have personally spoken to service providers in Alaska and Illinois, where center-based work has shut down and previously employed people have not found competitive work and now sit idle. Kansas doesn't have to follow the failed footsteps of Illinois and Alaska and who knows how many other states across the nation. Kansas can stand up and say, in our state, everyone on the IDD waiver who wants to work has the right to work, whether competitive or center-based. In Kansas, we don't take jobs away from hardworking people because that just doesn't make sense. I want to raise one other point quickly before I stand for questions, and that is many of us, parents, guardians, family members, don't understand and are very concerned, and since you all are the keepers of the budget, I will raise this to you, why thousands, millions of dollars have been spent by KADS to pay contractors and subcontractors and consultants to tell us how to modernize. We don't need to be told what to do. We know what to do. What we wish would happen with that money instead is that it would go to capacity building, to staff retention, to taking people off the waiting list. I stand for questions.
Very good. Thank you, Cammie. Committee questions? Seeing none, thank you very much for being here.
Thank you.
Okay, next we have Melanie. Melanie, good morning.
Afternoon, I guess it is. Representative Carpenter and members of the committee, and I'm going to try and get through this. My name is Melanie Jacobs, and this is my daughter, Sandra. I'm here today as a parent, guardian, and a lifelong advocate. Sandra came to us as a foster child when she had just turned 1 year old. We were blessed to adopt her at the age of 5. She came to us with many complex medical needs, but her primary diagnosis is quadriplegic cerebral palsy. Most of her care was done at Children's Mercy Hospital in Kansas City, a 3-hour drive from Wichita. When we adopted Sandra, we were told she would not live to be a teenager. This year, she turned 28. Why am I sharing this with you? Because as parents who adopted later in life, we made a commitment to keep Sandra at home for however long that may be, wherever she is safe and loved. But I am here today to tell you that keeping that promise is becoming harder and harder. Medicaid currently pays for only 25 hours per week of day services. That makes it nearly impossible for working families. Families are having to consider placing their loved ones in residential, even when desperately they want to keep their child at home. Trying to access more personal care hours is an uphill battle. Families are constantly being asked to prove again and again the severity and extent of their child's needs, even when those needs are lifelong and well documented. The lack of hours, the staffing shortage, and the constant administrative hurdles are wearing us down. We all know it is far more cost-effective for the state to support someone at home than to fund full-time residential care. We didn't adopt Sandra because it would be easy. We adopted her because every child deserves a loving home. And for 27 years, we have fought to give her a life filled with dignity, comfort, and care.
But love alone isn't enough. We need a system that supports our commitment, not one that creates roadblocks at every turn. Thank you for your time.
Thank you, Melanie. Committee questions? Seeing none, thank you again for being here. Pat, Leon? Pat, welcome to committee.
Thank you. My 34-year-old son, Chris, has Down syndrome, and he is academically at a second grade level. I have great concern that KADS proposed unbundling changes could shut down center-based work programs like he participates in. During the 6 years after high school that Chris waited to get funding, he developed mental health and behavior issues. Upon getting funding, traditional day service programs didn't work. What did work was getting a job. The Goodwill Skill Development Adult Day Program has been life-changing, providing the structure Chris flourished in during his school years. He received the 2022 Achiever of the Year Award, gained independence, and even moved into residential services, which he proudly calls his apartment. Unbundling may shut down work opportunities like this. It may force individuals who want to work to do so in an integrated setting in the community alongside a majority of non-disabled workers and earn at least a minimum wage. That is a wonderful aspiration, but as data shows, it is not realistic. Per an April 29, 2025 GAO report, 16 states have discontinued center-based work programs that pay sub-minimum wage. Only 11 of those states tracked the outcomes, and 2 of them shared their findings with the GAO. In Colorado, roughly 50%, 50% of individuals with IDD were not able to secure integrated employment. And in Oregon, roughly 60% were not able to be employed. Chris loves his job and is proud of his paycheck. His favorite task is to package fiber, and he's actually paid $7.50 an hour. Is that something you or I would want to do? Probably not, but it is what he wants to do, and it's in a supportive environment where he's comfortable doing it. The overreaching unbundling proposal could affect his job. Even though he's paid above minimum wage, it's not, quote, integrated out in the community. I believe that Chris leaving his apartment is going out in the community and feel it's actually discrimination to view the IDD individuals and staff members he works with as not a real group of people. Every individual in Kansas with IDD already has the right to choose their services and to make changes at any time they want to. Please do not limit choices and destroy dreams by allowing unbundling definitions to shut down center-based work programs.
Very good, Pat. Thank you for that. Committee questions? Representative Ballard.
Thank you.
Thank you again. Okay, next we have Colin. Colin McKinney. Welcome.
Good to be here, Mr. Chairman, members of the committee. As you can tell, there's a lot. Oh, I'm Colin McKinney. I'm the CEO at Starkey. We are one of the largest providers in the state for adults with intellectual and developmental disabilities. And as you can tell, there is a lot going on in the IDD network at this point in time. We've talked an awful lot about various initiatives that are taking place and what we're calling the modernization discussions. Way too many topics to fit into this short 2 days of hearings that you have. But I'm just, you've got my written testimony. I'm just going to pull out a couple of key things that I kind of want to reinforce here. Serving those individuals with a dual diagnosis, some sort of complex behavioral support needs, is one of the biggest challenges that we face at this point in time. And strangely enough, as it relates to our organization, and I will tell you that going back in time to 2007, we started a small program for 2 people with complex support needs. And over the intervening 18 or so years, we now have 50 people in that program with that type of complex support need. We've gotten pretty good at providing those services, but honestly, it shouldn't have happened that way. we have had to become experts in a portion of this program which is grossly underfunded. As you look at the average reimbursement rate for individuals across the state system, you would think that those with the most difficult support needs, the ones that require the most intensive staffing, would have the highest reimbursement rate. And I can tell you that that is absolutely not the case. And so one concept that I want to leave with you here, and we'll follow up in future committee hearings, is as we look at what will the new reimbursement structure look like for our system, it has to pull out those types of inconsistencies and gross underfunding and address those as we get to the new system that will kick in on July 1 of 2026. So we've got a lot of work to do there. I was glad to hear the earlier report on the update on the grants that various organizations had received, and I think they all have positive things to say about what they were able to accomplish through year one of those grants. But something that I've heard a number of times is, all we have is these very choppy allocations of resources. We can't really build a long-term program on these single-year grant allocations. And so I think if those entities were here today to talk to you, they would probably say, is there some way that we can talk about a multi-year grant that would allow them to build a program to help meet complex support needs over a series of years? And the last thing I would tell you, and I think you received an update on this as well, we were heartened to hear that the crisis stabilization beds at Parsons had finally opened. I believe that the resources for those had been allocated in the 2022 legislative session, if I remember correctly. So it took 3 years, if my math is correct, to get those beds open. By the time we were aware of them, 2 were filled, and the third one was in the process of being filled. And that was the resource we were all looking to. Maybe we can find some immediate short-term crisis intervention support services. And by the time we're aware of it, probably all 3 of those beds are filled already. So something that we need to look at going forward is, can we create that type of resource in other areas around the state? You've also heard a lot about updates on the new state hospital beds that will be built in Wichita. 104 beds, none of them for this population. And so we have to do something to meet this need for this group of people. We're good at what we do, but there are times when we need the other community stakeholders to help us meet those types of complex support needs, and we hope that you all can help make that happen. Happy to stand for any questions.
Committee questions?
Thank you.
Thank you, Colin. Next, we have Sean Gatewood.
Thank you, Mr. Chairman, members of the committee, for allowing me to testify today. You have my testimony. I'm just going to focus in on one central topic on there. We talk quite a bit in this committee and in the health committees and the finance committees about wait lists all the time. And as a body, the legislature's made a lot of progress on the IDD and the PD wait lists. But I'm here to kind of sound a little bit of an alarm today on 3 other waivers. The TA, technical assistance, the BI, the brain injury, and the FE waivers of frail elderly. Currently, there is no waiting list for those. I would like to keep it that way. KADS requested funds and slots during last legislative session to prevent, as we have an aging population, to prevent waiting lists in those particular waivers. That funding did not make it through the process, and right now KADS is preparing to have a wait list if that is to come about. So we have about a year here before the next fiscal year starts, and I just want you all to be aware and give a little bit to the newer members of the committee sort of a background of what those waivers are. So TA, the technical assistance, that is folks that are pretty medically fragile, think feeding tubes, ventilators, things of that nature, that otherwise they would likely, without that waiver, not be sustained outside of an institution, a hospital, a nursing home, things like that. And so as, from a finance or a placement perspective, it's much better for them to be at home. They are stable. They just need that assistance to be able to literally to live. BI is brain injury, so that is one of the few waivers that we have, I think the only one, that is rehab. So you're getting them back. You're getting functionality back. And the longer that wait goes, the less return on investment the state of Kansas and its people gets from, what that person's potential is. And then FE, the frail elderly, most of those folks, they are coming to us in crisis. So I'm going to speak a little bit back home here. But in my case, you know, Granny, she was out on the farm, everybody left, and we would talk to Granny and everything all the time, but then all of a sudden, Granny left her car out in the pasture, didn't know whose it was, and she was kind of in danger of burning the house down, and we just didn't know. Everybody's checking in, but it seemed like everything was okay until it wasn't. And that's what happened there, and that's what folks on the FE waiver, that's the kind of people that's how that's presenting. So I don't know how you manage any of those populations with a waiting list, given current resources. So I just wanted to bring it to your attention so that we can all avoid having further wait list problems that we have to discuss all the time. And I will stand for questions at the appropriate time.
Committee questions? Seeing none.
Thank you.
Oh, Representative Reeves.
Thank you, Mr. Chair. Sean, you kind of said something, it's on my head right now. I know that we've been, really, I think as a legislature, we've been really good with trying to find funding for the waivers. And we made some comments of a few minutes ago about we're going to continue to do that. But I don't know how we do that when we have a potential of having wait lists on 3 of the waivers. Can you say anything else about that? I mean, because it doesn't match. I know we tried to get funding for the TA waiver, I believe, and we weren't able to do that. We tried to have 500 slots for the IDD, and we weren't able to do that. We got 200, which is better than nothing. But I truly wish we could do more, and I am happy to hear many of the members talk about that. We're going to really work hard for that, but I don't think that we know enough what the wait list is going to be like for these 3 waivers, how serious it is.
Representative, I share your concern. Obviously I share your concern, and it does worry me as far as what the current wait lists are, and we're making strides on that. The new community support waiver coming out, I think, holds a lot of promise, and many members of this committee have kind of kept after that. Those things are all wonderful, and I think folks are, hearts are in the right place on it. I think that there is a certain level of, we get into this Medicaid stuff, people start throwing around TA, BI, FE, whatever. I think sometimes things kind of get lost in the shuffle as to exactly what it is. But I think that's part of what the wonderful part of this committee is, because this committee brings together, leadership from the insurance, the finance, the policy committees, and then you all can kind of carry forth. So I'm hoping, with having the baseline understanding of what these things are, and I think the people on this committee have an understanding of how important it is, that we can, outside of sort of partisanship or whatever else, kind of carry that message forward to leadership and whatever. The other thing is I'm a little concerned, last year's legislative session, I think part of the problem was sort of the nature. It was very different in the pace and how the budget went through. And I think that this was just one of those things that it sort of fell off. So again, I'm very much hopeful that the leadership on this committee can, be watching early, be invested early, and bring solutions through the process. So I'm going to remain optimistic.
Any further questions? Seeing none, thank you, Sean, very
Thank you,
much
Mr. Chairman.
for being here. Next, we have Con Olson. Welcome to committee.
Thank you, Mr. Chair. I'm Con Olson. I'm a board member for the Kansas EMS Association. The ambulance service I work for covers 4 rural Kansas counties, 2 of which don't have hospitals. And I would like to talk to you a little bit about several programs that are out there as a potential to help be not only a stopgap, but help alleviate some healthcare expense, reducing those expenses, and getting individuals to the right place in the most appropriate manner. To tag on to Mr. Gatewood's story, when there is a crisis, we are the ones who are most often contacted, and that we are there when something goes wrong in a community with an individual that nobody realized was in crisis, whether that's mental health, whether that's somebody who needs assistance, just being able to stay home safely or manage a chronic disease. But however, the funding mechanism for the healthcare system requires us to transport someone to the hospital, thus creating a transport ambulance bill as well as an emergency room bill, when neither are probably the most appropriate choice. So when we can treat them at home on those low acuity patients, give them quality care where they can be well taken care of and resolve a vast majority of the situations at home, we've avoided that ambulance transport expense and that emergency room expense. When they need more, we can help navigate them to the appropriate resource using our community paramedicine program and transporting them to the most appropriate destination, whether that's a behavioral crisis center, whether that is helping them navigate through the system to find a case manager and get them just the little things that they need to be able to stay at home safely. In 2 of our counties, we have paramedics that spend part of their shift working with those individuals that have been notified by our crews where they need that little bit of extra assistance. Sometimes it is really working interactively with their primary care physician and getting them physical therapy. Sometimes it's nothing more than setting them up with a safety alarm, so if they should fall, they have a way to activate EMS. Sometimes it's looking for Meals on Wheels. Sometimes it's looking for ways to be able to get them more appropriate care that we can't do it in the home, or they need a specialist provider, but that the emergency room is not the place for them. So through treatment in place, alternative destinations, community paramedicine, we look to lower health care costs, get the patient to the right destination the first time so that they can navigate through the system. Our 2 paramedics that do this for us have helped reduce our ambulance response call volume by about 2 to 3% a year, especially when we're having to respond to certain individuals on a multi-time per week basis, where those things are needed. And those are 3 great programs. We look for them to help reduce costs in the healthcare system and on the KanCare side as well, of course, and then get the patient the best care where they need to be at the most appropriate time. So I'm happy to stand for questions.
Very good, thank you. Representative Buehler.
Thank you, Mr. Chair. I'm looking at your policy recommendations. I don't see anything statutorily that needs to be changed. Is that correct?
We don't believe so. I mean, there may become a time where we have to navigate through some certification and licensure to be able to make this reimbursable with insurance companies if they don't necessarily recognize a specific license. While there's no national body that oversees community paramedicine, there are certificate programs out there, much like a specialist in other medical fields. But currently, there does not appear to be an issue with statutory regulation when it comes to certification and licensure.
Okay, so, I mean, I support the community paramedicine. I think it's great. And I guess I'm really going for, is there any potential conflict with scope or licensure creep with either nurses, any other? We seem to run across that. People get real touchy with their turf.
Yes, and we try to have those conversations ahead of time because sometimes it is a matter of us being able to assist nurses in home health agencies and hospice agencies and those types of organizations, because maybe the family's called 911, we're there at that given time in an unscheduled point. Maybe that agency can't work that patient into their schedule at that immediate time. We're here, we can consult with their case manager, their home health nurse, their primary care physician, and kind of navigate, okay, what is the most appropriate thing to do for this patient until the home health agency can come out and work with them, or they need to be taken to an urgent care center, or they're in some sort of behavioral crisis.
Okay, thank you. Thank you, Mr. Chair.
Oh, Representative Ruiz.
Thank you so much for your presentation. Are there states around us that are getting reimbursed, that EMS is being reimbursed for the for the treatment in place?
For treatment in place, it is not widely accepted yet as a reimbursement model. Medicare, right prior to the onset of COVID in 2020, had a pilot project going on and had some pretty good success, and then life as we knew it got derailed and the project kind of came to a stop to concentrate on other things. So while it was there briefly, it did prove that there is what's best for the patient can happen, as well as savings in the healthcare system.
So on your policy recommendations, the second one is allow EMS to be reimbursed for patient care delivered without transport.
Correct.
Right, okay. Are there states around us who are doing that?
To some extent, Missouri is. They have a pretty robust policy set forth for community paramedicine and treatment to be able to get the person the care they need at home. And if they don't need transported, they're stable enough to stay at home. And then if they do need to go on to a different facility, they get them to the right facility, or maybe it's just being there to help manage them on a long-term basis.
And one last question. So let's say you go to a home, someone has fallen.
Yes.
And there's another person living in the home, but they can't pick up the person to,
Correct.
off the floor. So EMS, you're there, help the individual get up. And on a situation like that, what might be the average time that EMS is there with that person?
We judge it from the time the response is initiated, because we look at drive time, whatever ties up that unit and commits it to that patient time. You're looking in a rural setting, probably 35 to 45 minutes.
Okay, thank you.
Senator Petty.
Thank you, Mr. Chairman. You mentioned that there were several communities in Kansas that already are using the community paramedics. Would you tell us where those are?
Yes. There currently is a pilot project going on with Dickinson County and I forgot Chrissy's location. Norwich, thank you. Norwich, Kansas. And then there are a variety of organizations within the first response mechanism in Kansas City that do it through KCK Fire, who you'll hear from next, as well as a couple other fire agencies there. Our two focus pretty much solely on navigation at this point and spending time getting them the appropriate resource, whether it's in the behavioral side or elsewhere. So while there are several across the state, they are very different in being able to adapt to what a community needs. What's appropriate in a metro area may not be what's needed in the rural setting, and even one rural setting to another may vary based upon the fact, like 2 of my counties don't have hospitals, and the other 2 do. So sometimes there's that variance there in what's appropriate for and what's needed for the stopgap in that county, because we have become the stopgap.
So in those communities that you just mentioned, I'm not quite sure what you were referring, I'm not quite sure what you said about Kansas City, Kansas, but the other 2, how are they, have they passed local ordinances, or if they, or their fire departments, do they both have, they must both have their own fire departments?
One is run through the county, and the other one's a volunteer service run through the city at Norwich. So it is a local decision. It's a pilot program that they're working on to look and proof of concept in being able to give the patient the care they need and save costs to the community. So.
And what did you say is in Kansas City, Kansas, though?
Pardon?
What did you say about Kansas City, Kansas?
They have a program that you'll hear from next. The EMS chief from KCK Fire is after me.
Thanks.
Senator Owens.
Thank you, Mr. Chairman, and thank you for being here. The concept of community paramedicine seems really intriguing to me. I think a lot of details and structure has to be put in place, because here's my concern when I hear about it, and I heard you present, is kind of the current guideline is if you call an ambulance and you don't transport, they're not getting a bill.
Correct.
Right? Is this an attempt to change that?
No.
Okay.
This is to find the patient who is in some sort of crisis. The lift assistance that the representative referred to earlier, while it's a local decision whether or not to service bills for that, a vast majority do not. If they go out and go to a car wreck or some other type of minor trauma, and the patient doesn't get transported, if there was no invasive procedures, there's typically no bill. It is, for example, that diabetic patient that has a hypoglycemic episode, we go treat them at the scene, improve their sugar, bring them back to an orientated state of mind. They're refusing to be transported because we've solved the crisis. It is a patient bill at that point because we've used invasive procedures and medications to fix them, but the insurance will not acknowledge that because we did not transport them, which is appropriate. But in order for cost of services to be reimbursed, then we would have to put them through a transport bill and then an emergency room bill, and it just tacks on to the healthcare system. So there's a variety of conditions out there like that we can go to the home, work with them, treat them in place, and thus get them stabilized. Maybe they need to go on to their primary care, maybe they're good for the day. But when we use those invasive procedures, there's no mechanism without creating a much bigger unnecessary bill.
I think that's really a great example, and just a step in the right direction of how we kind of define that with that invasive procedure piece. Because, yeah, I totally agree with you. I mean, you saved an enormous amount of funds by stabilizing their sugars. I just don't want it to become, because as we know, fire and EMS is a taxpayer-funded service. I don't want it to become an additional bill every time somebody, shows up and it's not an invasive procedure. So thank you for that.
So that's the process we look to avoid while covering the community's expense and freeing up resources. So ultimately, that ambulance is free quicker, so that it can be available for the next call instead of needing to put on more staff and another $500,000 ambulance later, that they can actually save the community money in that situation.
Great, thank you.
Thank you for that. Representative Ballard.
I will follow up on that because I was a little confused about that too. But what you're really saying, if you stabilize this individual right there, it saved a lot of time, maybe their life, and a whole combination. But if you're just waiting to say, now ambulance, take them back, there's another bill that's tacked onto it, but you're not getting anything for
If
the
we
work.
transport them and then have to transport them back home, is that what you're saying?
Yes.
Yes, because Medicare often, and most insurance companies, do not pay for that trip back. So we work with the patient, if at all possible, to find them another resource, because using the ambulance in that mechanism is not covered under most benefit plans.
And if I'm correct, what you're asking is a lot more economical.
Yes.
It would be a lot more economical. And if the person stays in the setting, you don't leave them until you know they're okay.
Correct. And to go back to the pilot project Medicare started that I referred to briefly, they had an organized set of protocols and policies that were signed off by the medical director of the ambulance services that were participating, and had other safety components in there. So there was a consult with a physician on those more serious patients before they chose to stay at home.
I understand that, because then that would also, if you're not getting paid for it and it went further on and they end up taking them to the hospital, there's a copay.
Correct.
That's going to be bound on behalf of that other person too. So in this case, you're actually, once they're stable, you're preventing that copay that they would have to do, and it could be more efficient.
Correct.
In the process.
Yes, that's our goal.
Thank you very much.
Thank you.
Sure. Okay. Well, I have just a question about this. So we're primarily Medicaid.
Yes.
So in that instance, it seems like, what do you do? Ask them what insurance, are they private pay, or are they Medicare, or are they you see what I'm saying?
Right.
It seems to me like if there was some savings, and I think it's a great idea, but there's other people that probably could get involved in that private insurance. It would save them a lot of money too.
Yes.
So I'm just want you to understand our purview is just around Medicaid.
Correct. We understand, and we're hoping to have further negotiations on private, as well as there's national work on Medicare, trying to adopt that model on a more permanent basis as well. So, but we want you to be aware that we're working to try to help Kansans stay at home so they can stay off of some of those waivers, hopefully, and get the care they need and be economical with the KanCare dollars as well.
Very good. Thank you for that. Any further questions? Seeing none, thank you again.
Thank you.
Interesting. Next, we have Mark. Mark Heath. Thank you for being here.
Hello. My assistant Jason's going to pass around some flyers. I'm also going to talk about community paramedic. My name is Mark Heath, the chief of EMS for the Kansas City, Kansas Fire Department. I'm also the co-chair for the MARC Regional EMS Consortium, which is the metro area. So we've had a community medic program in Kansas City, Kansas since 2019. Right before COVID, I got that thing online, and then COVID happened. As a service in Kansas City, Kansas, we respond to 36,000 calls a year. 26,000 are EMS related. We transport 18,000 patients a year. So Chief Olson would give you a concept of rural. I'm going to give you kind of the urban. So we have a small and mighty community paramedic of one. Jessica does a great job on what she does. But what we've seen is the high utilizers. We go find the high utilizers, and we go back to try to see the why they called 911. So on a daily basis, I practice high-speed EMS is what I always call it. I want to put an ambulance on your scene in 9 minutes and 59 seconds and a fire truck in about 4. ALS care all throughout. There's 2 paramedics. We've got that down. That's our bread and butter. That's our core. You call 911, a bunch of stuff is going to show up. So what this is slowing down with community paramedicine is the why they called 911. Because unfortunately, with the high-speed EMS, you either sign a refusal or you go to the hospital. That's kind of your treatment choices. It's a yes or no. With the community paramedic following in off a referral, like, hey, this lady might need a little help on here. And you have the medic come out and they look at the giant box of pills and they help sort through the box of pills and get a pharmacy consult. You could have 2 doctors from 2 different healthcare systems seeing them for the same thing, or sorry, for different treatments, and crossing the meds. Sometimes it's as simple as just a medication adjustment. Hey, you know, you're taking double the amount of Lasix that you should be? Things like that. And then going through the house, safety assessments, smoke detectors, trip hazards. Do they have enough food in the house? Simple things like that are easy things. One of the success stories is she was out helping somebody. She'd had a right side stroke. The handrail on the stairwell was on the right side. Called the crews over, 2 fire trucks showed up, the captain pulled out a drill and they moved the handrail from the right to the left. We used to go there 3-4 times a month. Now we go there once every 6 months and beyond. So simple things like that have made a huge difference in our community. Getting back to money. So let's talk about money. So if my medic can see 360 of the high utilizers on our system a year, and let's just say they only go one time. I know they're high utilizers. Let's say they go one time. That's an average savings of about $288,000 if they only go one time for those 360 patients. Running a fire truck and ambulance and transporting to the hospital is about $800 an hour is what it breaks down for us. So if she can solve the why and solve 5 or 6 more calls, I can extrapolate that out. $500,000, $750,000 is what it's saving us because it's keeping my ambulances in service for the next 911 that comes in. So we don't have to add trucks at $500,000 a piece or staffing at $700,000 a piece. Those things get pricey. So I won't take up any more time, but on the back of the NAMET thing, the thing I will highlight on here is there was a national study by $24 million emergency room visits across 750 hospitals that 4.3 million visits associated with patients with 6 chronic conditions were preventable. The average savings was $8.3 billion nationwide on that. What we're asking for is a carve out to get our toehold in so we can start getting some data, because if you've seen one community program, you've only seen one. They all kind of have variations. We'd like to start extrapolating some data and get some real world data to show you guys what the savings would be. So, welcome for any questions.
Any questions? Representative Bryce.
Thank you, Mr. Chair. Thank you, sir.
Yep.
Thank you for your service. Obviously, to just kind of set up my question, obviously paramedics can't practice medicine. They don't have a medical license. So you have to work off of a protocol of some sort. That's
correct, by the medical director.
Right. And so the creator of that protocol is the medical director of the EMS locally?
Yes.
Is that correct? And so do you foresee, a couple of questions, do you foresee an increase in liability exposure associated with increasing the community paramedic program, medical liability?
I mean, by the numbers, every patient encounter, you're going to increasing your liability. I don't see that we are increasing our liability in any particular thing. They're not doing anything way outside the scope. I thought when I started my paramedic program or my community paramedic program, I was going to need all these things and on-scene blood treatment, and we'd do all these things. A cell phone, a laptop, and a clipboard does more for me in a $20,000 Chevy Equinox than a $60,000 heart monitor's done. A lot of the times it's her identifying the small item and getting her plugged in to, hey, we need to get a pharmacy consult. It looks like you're doubling up your meds. Looks like we're doing this. And just getting that continuity of care so people don't slip through the cracks. Does that answer your question?
Well, that partially does. Yeah, I definitely see benefit. Previously, back in the good old days, paramedics didn't make judgment calls. It was we either transport you or you refuse, you sign out. Okay, now
you fit in a box and a protocol.
Fit in a box.
Still do.
Now you're having paramedics make medical decisions based on protocols.
Yes.
Someone has indigestion, you give them antacids, they're better, you leave. Well, it was a heart attack and they die, and everybody gets sued. So there's some kind of a judgment call involved now. Is there anything like AI programs or anything like that that helps you decide?
AI, a year ago I went to a conference and they talked about AI, and this year they showed us AI. There's some amazing things coming with AI, both amazing and scary at the same, depending on whether you put a tinfoil hat on or not. I think there's still always, we have medical consult, and nowadays, everybody has a cell phone. We can add telemedicine to this, and I think that's yet another aspect of this that the hospital association, I'll put the words in their mouth, we should be adding that. So when you have any question, you're going to consult a higher level of care.
Okay, I think that answers my question. Yeah. Thank you, sir.
We still always have the availability to call a hospital and phone a friend. So.
Any further questions? Senator Petty.
Mark, thanks for being here. I see that you chair the Mid-American Regional Council Emergency Rescue.
Co-chair, yep.
You're co-chair.
Yep.
Okay. So, and it was mentioned earlier that there are some things that are doing on the Missouri side that we're not. So
yeah, there's.
Since you're with the Mid-America. Good.
Correct. So on the Missouri side, 2 MCOs are chipping in money. They are seeing the value of this, and we've seen that come to fruition. And then over in KCMO has 3 community paramedics. KCMO Fire has 3 community paramedics. Lee Summit has 1. CJC, I'm sorry, the other yellow fire trucks, has community paramedics also. It's been much more successful in Missouri. They have a couple year head start on us, I would say.
And so have they been gathering data then about the impact?
Yes, and they would mostly agree with my assessment of about a 60% reduction. And every person or every patient that the community medic sees, we see about a 60% reduction in the amount of 911s that they're calling.
Thank you.
Any further questions? I think it's intriguing, I'll say that. All right. Next, we have Kathy Keck. Kathy, well, sure. Welcome to committee.
It's a process to get organized here. So good morning, Chairman and committee members. Thank you for the opportunity to speak with you today. My name is Kathy Keck, and this is my son Jacob, and I am the mother of 5 children, 3 who have significant developmental and medical complex disabilities. And I speak to you not only as a parent, but an advocate for more than 800 Kansas children whose lives depend on the TA waiver. Our friend Hudson back here is a good friend of our late daughter, Maria. So I want to talk about the TA waiver a little. I know some people have talked about it, but I want to talk about a couple things. So first, the human impact. So in 2024, my daughter passed away, that girl right there, shortly after her 8th birthday. She lived 2,975 days on this earth. Of those, 96 were spent at an inpatient at Children's Mercy. That was 3.2% of her life. But without the waiver, that number would have been much higher. Her bedroom, just last week, we went to see Jacob's palliative care doctor, and a social worker working there told the doctor, Maria's room was the prettiest ICU room I've ever seen in our home. Being home allowed her to be surrounded by family with dignity and peace for all of those 2,975 days we were blessed by her. But what about children who don't get 8 years? What about the families who are just starting their journey today after a diagnosis or a life-altering accident? If it were your child or grandchild, how much of their brief, precious time would you want them to spend confined to a hospital? Then there's the fiscal reality, and I changed up my testimony a little today because I got some facts and figures. I wanted to just be a little different today. So first, let me speak directly about the economic aspect of the issue because it's not just a human concern, it's fiscally responsible. So a quick search today on Google tells me that the daily impact inpatient cost at Children's Mercy, where my daughter spent those 96 days, is $7,719.98. So as we look at a pending wait list for the TA waiver, because allocated money was not put in the budget last session, for just 10 children forced to remain hospitalized due to the lack of waiver support, that's $154,399.60 per day. For 100 kids, that would be $7,771.998, $771,000 per day, more than $5.4 million per week for 100 kids if we end up having a wait list. Compare that to the entire current TA waiver allocation of $4.5 million. Don't have to be a mathematician to know that's a fraction of what the state would pay for even a few dozen kids hospitalized. So not only is there the human impact, but there's also a pretty significant fiscal impact. And home care, it just isn't compassionate, it is cost effective. So another concern I have, and I've been to this committee since 2016 when we first got our daughter, and we are still here with a care crisis. So I commend the committee. We keep raising these Medicaid reimbursement rates for nurses, which is great. But the T1000 medical rate is what helps pay for nurses to be in our home. But families are still struggling. Why? Because in some cases, up to 45% of the funding is being lost to administrative cost, leaving only about 55% to reach the nurses who provide the hands-on, life-saving care. This is unsustainable. So my requests today are straightforward. Fully fund the TA waiver, eliminate the threat of a wait list for children whose lives depend on it, and cap administrative costs for MCOs and agencies at 20% so that at least 80% of that T1000 rate can go where it's most needed, to the nurses. And as you leave the room today, I just want to ask you to remember, these aren't policy statistics. These are children. These are families. This is my daughter, my son. This is our community. We are doing everything we can, but we can't do it alone. So we need you guys to continue helping finish what we started and bring hope, healing, and dignity to families across Kansas. And hopefully next session, make sure that we get that money needed to make sure we can avoid this wait list for the TA waiver. Thank you, and I'll stand for questions.
Very good, Kathy. Thank you. Committee questions? I just have one really quick one. Where does this 45% go to administrative costs come from? Do you have some instances or some?
Well, nurses used to talk to me quite a bit, and I still know quite a few nurses that tell me how much they get paid to do this work. And I know what the current rate is, $55. And when a nurse is telling me they're making sometimes between $30 and $38, I can do the math.
So you're talking about the MCOs are taking that then?
And
I'm just curious.
I think it's, well, the rate goes directly to provider agencies, but there should be some caps on the administrative rate that MCOs take as well, sir. But this number specifically is the rate that goes directly to providers to provide the care is $55 an hour starting July 1st with our increase. So
they're not passing that on to their staff?
Correct.
Okay. Just wanted to be clear about how that.
My advocate back here says no.
I know this committee and the legislature has been very active in getting the TA numbers up.
Yes, sir, you have been. But that, I think, has not been passed down to where it needs to be going. So thank you.
Any further questions? Thank you very much for being here. Okay, next, Lola? Lola, welcome to committee.
Thank you. Oh, sorry about that. Hello, Representative Carpenter and members of the committee. It is good to see you all again. I am Lola Cornell, the Advocacy Coordinator for the Kansas Council on Developmental Disabilities. We appreciate the opportunity to provide testimony today. As you all know, we are leading the statewide agency advocating for Kansans with intellectual and developmental disabilities and our families.
And I am Whit Downing, the Vice President of Policy and Programming for the Kansas Council on Developmental Disabilities. First, we want to extend a heartfelt thank you to all of you. Because of your leadership this year, we funded 200 new slots on the IDD waiver. Also, for the first time, the waitlist cap was lowered from 4,800 to 4,000. This means that fewer Kansans with disabilities will be stuck waiting for services. That progress is deeply personal to me. As I've shared with this committee before, I was on the IDD waiver waitlist for 8 long years. I was one of the 500 individuals who was offered a waiver slot thanks to you all during the 2024 legislative session. However, since I do work full-time for KCDD now, which is my first full-time job, I decided to let someone else have my waiver, and I'm not on any benefits right now.
Another highlight of this session was the passage of House Bill 2307, the Prenatal Postnatal Conditions Awareness Act, which received unanimous support in both the House and Senate. Under my leadership and with your help, House Bill 2307 became more than a law. It also became a statement of what is possible when people with disabilities are in positions of influence. As a person with Down syndrome, this passage was extremely meaningful. As we move ahead, KCDD continues to encourage this committee to continue to support the modernization of Kansas's IDD system and ensure we become fully compliant with the final rule and help launch the community supports waiver. We need to get off the corrective action plan that CMS put us on last December so we can start the community supports waiver.
We also believe that we need to prioritize funding for the elimination of the IDD waiver waitlist. Next session, we'll be requesting another 500 slots as the next step to ensure Kansas eliminates our waiver once and for all. And it's really cool. You may have seen that Nebraska just eliminated their IDD waitlist. I love that. This session saw the introduction of the Kansas CARES Act. This piece of legislation lays the foundation for long overdue changes to how Kansas supports and retains direct care professionals. We ask for your support as this is reintroduced next session. Thank you all for the opportunity to provide testimony today. Lola and I and Sarah and Allison are happy to stand for questions at the appropriate time.
Very good, girls. Thank you very much for that. Committee questions? You did such a great job, we don't even have any questions for you. Very good. Thank you again. Okay, next we have Colin. Yeah, can you just move the mic down onto the second level there for him? We've done this before, haven't we, Colin?
Yeah. I'll go sideways if that's all right.
There you go.
All right.
Perfect.
Thank you.
Colin, welcome to committee.
Yeah, all right. Thank you, Mr. Chairman. My name is Colin Ornick, and I'm the legislative liaison for SAC. I basically am just going to say what they just said. So thank you. We would, however, like, I'm part of another organization, the Big Tent, which is all these organizations, and we would ask you to ask the legislature if you could get 500 off the IDD waiting list instead of the 300, if that would be possible. So that is what I'd like to say, and we would also like the legislature to look at the Supported Decision-Making Agreement Act and getting that passed as well, if possible, this next session. So thank you, and I will stand for questions.
Very good. Thank you, Colin. Questions?
Yeah.
Representative Ballard.
Thank you, Colin. All right, so what you're saying, okay, we did 200 this year.
I got it down as 3, but you got 2, so, okay.
That's right. I'll take yours, okay?
All right.
That sounds better, doesn't it?
Thank you,
Okay,
yeah.
so you're saying 500.
500 so that we could get 1,000, because the session before that, I think we get the first 500, and then we wanted 500 this next round, but weren't able to get it. So if you could get it this session, that is what we would like to see.
How about that? They have it all worked out, right? All right. Well, thank you so much. And you know what I want to comment on?
Yeah.
You know what we did last session? And not everybody follows what we do from session to session, but I know you do, and I just wanted to comment on that. And it probably just depends on how much money we have that we're asking and other things.
Right.
But I will tell you, I'll consider 500. How about that?
Okay, yeah.
Thank you.
All right. Thank you, guys.
Very good, Colin. Oh, Representative Ruiz has a question for you, Colin.
Yes.
Hi, Colin.
Hi.
Can you let everyone know what the Supported Decision-Making Agreement Act is?
Okay, the Supported Decision-Making Agreement Act is an alternative to guardianship. Now, I know there also has been work on actually redoing the guardianship law. I don't know exactly what happened with that, but it was much improved from our current system. But the Supported Decision-Making Act would make it so that someone like me or anybody with a person they trust can make decisions regarding any aspect of their life as an alternative to even guardianship, which would open up the courts and, you know, make it more streamlined, make it more easy for people. And so that's basically what it would do. Yeah. All right.
Very good. Thank you, Colin, again. Committee, questions? Very good. Thank you again for being here. Okay, next we have Janet Williams. There you are.
Hello, committee. Thank you for having me here today. I'm here to talk about waiting lists and also the brain injury waiver, which I'm guessing some of you may have guessed already. Never heard that from me before, right? As Sean was saying, the brain injury waiver is a rehabilitation waiver. The average amount of time someone's on this waiver is 4 years. They get therapy in the home and become more and more independent over time. It is managed by KADS, and there are a series of committees looking at how to avoid a waiting list. As I was sitting listening to the other parents here today, and the passion and emotion that we're all feeling when they're up talking, I think the fear today is this is the first time that the brain injury, the FE, and the TA waiver are looking at waiting lists. We all hear the noise that's happening federally, so people are automatically calling me saying, are these Medicaid cuts already hitting us because we're about to have a waiting list? So I just wanted to make that connection because I've been fielding those phone calls. And I think that is a disservice to this committee because you guys have been amazing at making sure that you're looking at people and not numbers. And I think the biggest thing, and I want to say today, is let's avoid a waiting list so people don't become numbers. We don't want anyone in this room to become a number. We don't want any of these kids to have to lay in a hospital as a number, saying I'm number 10 on the waiting list, and I have to wait that much longer. You all understand the fiscal impact. Kathy did a great job of laying that out. And I think avoiding a waiting list obviously makes fiscal sense, because if you are a frail elder, I hate that name, a senior, especially as I get older, you're looking at a nursing home. Yesterday, we heard that nursing homes are $8,000 a month. The HCBS equivalent is $6,000 on average, right? Brain injury, it's $45,000 a month to be in the rehab facility. That's where you will sit and wait to come home when it, again, is $6,000 or $7,000 a month. Same for TA waiver. You're sitting in a hospital bed, which is that much more, and coming home and having that same equivalent. So that's my appeal today. A lot more facts and figures in my testimony, and a lot more important people to hear from for the rest of today. So thank you very much. Questions?
Any questions? Seeing none. Thank you. Okay, next we have Bernice. Did I butcher that pretty bad? I did? Oh. Welcome to committee.
Thank you. Good afternoon to everybody. My name is Bernice Cartagena. I'm 52 years old. I suffered multiple brain injuries. My first injury was when I was 5 years old, and a second injury when I was 11, and the third injury happened not too long after. Finally, I had a stroke in my 40s. As a result, I experienced lots of instability and received a lot of abuse. I have lots of challenges with communication. I suffered from aphasia, and I have challenges with my physical health and mental health. making it difficult for me to keep a job. This made it hard for me to have a financial stable life. Without finances in order, I suffered homelessness due to the lack of help and resources. I suffered lots of abuse and loneliness. I lived in states where they didn't provide help or services for people with brain injuries. In 2020, in the midst of a horrible pandemic, I moved to Wichita, Kansas. When I was 48, I received the news that I was diagnosed with an aggressive cancer. A hospital staff member sat with me and listened to me and learned of my medical history. Thanks to her and the way she listened to me, I was referred to brain injury waiver services and was connected with Minds Matter and mental health services. With the help of brain injury services, I was able to receive SSI, Medicaid, and housing through the affordable housing vouchers. Even with services on my own, I still struggle to independently communicate and navigate and understand new systems. But with the help of Minds Matter, I have been able to learn strategies that help me communicate and understand the services I need or have. I am very thankful for the services that I have been provided to me. My brain injury journey started when I was 5, and now I'm 52 years old, and the journey continues. Thank you for listening to my story. I appreciate your time. Thank you. Any questions for me?
Very good questions, committee. Senator Owens.
Yeah, thank you very much. And Bernice, thank you for sharing your story. We're here to listen, but thank you for taking the time and making the effort to come up here and to share your journey and how important that waiver has been to you. So thank you.
Thank you so much for your helps. Yes.
Representative Reeves.
Thank you, Mr. Chair. Thank you, Vernice, for sharing your story. Very powerful. You're obviously very strong, very resilient. When you were at services with Minds Matter, what might be a couple of things that you think helped you the most, other than being able to access like SSI and housing?
Most of it was the support of people being there for me. Whenever I get stuck on doing things on my own, I need that support of somebody that I can reach out to for help. In the past, I didn't have anybody. I didn't know who to reach, who to contact, or who can be there for me to help me be able to fill out some paperwork or to comprehend things that I cannot comprehend due to the injuries. So there was a lot of factors, a lot of things that Minds Matter has been there for me and helped me a lot. And I'm so thankful that the lady that was in that hospital took her time to listen to me and not just threw me off as she just wants attention. You're welcome.
Any further questions? Seeing none, thank you again for being here.
Thank you for
We appreciate
everything.
you. Next, I have Randall Heim. Randall, welcome to committee.
First off, I'd like to start with I've been diagnosed with 19 TBIs, and what brought it all to the head is I had a stroke at work. Okay, I had a stroke at work, and then they started looking at my file and saw the other damage and that I've been diagnosed with 19 TBIs. And when all this started 3 years ago, since then, I've had 2 cancer diagnoses and altogether 20 diagnoses now. It's like the last 3 years, my life has fallen apart. And with Minds Matter, it's been a great help to me because my brain and memory is pretty much turned into Swiss cheese. Some days it's tolerable, some days it's real bad. I've learned through different processes they've taught me, even simple things like using a calendar on your phone and stuff to try to keep things organized. Otherwise, if it wasn't for their help, I would have gave up twice already. Because I take 20 different medications, which is 46 pills and 3 injections a day. And sometimes they've helped me with the fight for the insurance because getting insurance approval for the medications the doctors give me and everything, I would have gave up on. Because I've gotten to the point in the last 3 years where if things are too stressful, I just give up on it. And it seems like more and more has caused stress. But through repetition, and like I said, using a calendar, it's somewhat better. But I'm noticing my doctors have said a little bit possibly of onset dementia or Alzheimer's because of all the head injuries I've received. And now I've got people I can talk to about these things because it's something totally foreign to me. I've always been a very independent and strong-willed person, and now I have to ask people for everything. And I hate it, but I'm learning to deal with it through this. And that frustration, they've really helped me deal with. And I mean, the main diagnosis I have, besides the TBIs, is I have 2 types of cancer right now. One's a stage 3, one's a stage 2. And I also have diabetes, and I'm on the strongest insulin they can give me trying to manage it, and we're still not doing well. And that's frustrating. And really makes my life hard at times. But I mean, without the TBI waiver and the Medicaid, I wouldn't be able to see my doctors or anything. Because I make, what is it, $964 on Social Security, the bare minimum, because I was $1.25 short of my disability. And I mean, I count on these programs to get by day to day. I'll end with that.
Well, thank you for that. Committee questions. Representative Ballard.
Thank you for your testimony. And I think it was very hard for you to go through and share with us all that you're going through.
It is.
I think the TBIs by themselves would be enough, but now you have cancer on top of it. It takes a very strong person to cope with that. And you look like you're coping. You're not totally giving up. And one of the reasons why you're not is because you have a very strong support system, and that's Mind Matters.
Yes.
But you have to be willing to accept that. They can be good, but if you're not willing to embrace it, it is. So, you know, one of the reasons we have testimony and people that come before us is a reminder that life is not the same for everyone. There's all these twists and turns and all of these things that you think, at one point you ask, why me? But then you'd have to say it should be somebody else. So I want to thank you for personally coming before us to share that.
Thank you.
And good luck to you.
Thank you.
Very good. Thank you, Randall. Okay, next we have Jonathan. Jonathan, welcome to committee.
Thank you. My name is Jonathan Pogge, and I was in a head-on collision in 2010 where I had suffered a traumatic brain injury, and a couple days later suffered a stroke at QMed, and then I was transferred up to Madonna Hospital in Lincoln, Nebraska for 4 months, and after 4 months, they pulled me into a meeting room and told me my insurance was gonna stop paying because they said I was well enough to go home, but I was still in a wheelchair and not very intelligible. Like I was speaking cursive, my words would run together. And then I was hooked up with Minds Matter and Medicaid. I got on the brain injury waiver. And with their help with physical, occupational, speech, and cognitive, I was able to graduate with 3 associates from Highland Community College. And right now, I'm working part-time for Minds Matter as a cognitive therapist, just to help the company and community that's helped me out along the way. Thank you.
Very good. Thank you for being here. Committee questions? Seeing none, thank you again for being here. Next, we have Kevin Wadsworth. Kevin, welcome to committee.
Afternoon, everyone. Lights are kind of bright for me. I 28 years ago, I was involved in a vehicle accident, and the motor vehicle accident changed my life. Basically, I was living in a different state, Tennessee, in a successful, career, but it was quite difficult. It was after my brain injury, I tried to get on with my life and continue what I did at a big company in Nashville, Tennessee. I was unable to figure out what was going on. I was undiagnosed TBI, which it was the field I was in. It's something I had been with many years and very successful with life. But these things caused me to come back to my home, which is here in Topeka, Kansas, to get fixed and hopefully to go back to Tennessee and be project manager again and be part of a big deal. But those things were not my chance of being able to go back to do that. Let's see, I spent almost 6 years before I received disability after applying and being not understood that I had a brain injury and all this, but I finally was able to get into Medicaid services through Minds Matter, like the other people, and I've known Janet for many, many years, and I worked with the brain injury program, through their services for 2 years, and I had cognitive therapy, I had behavioral, having a brain injury makes me forget exactly what I had 20 years ago, but a lot of services that we worked on and things, but through the HCBS waiver, I was able to learn new ways of figuring out how to do things, which, of course, some people that don't have a brain injury don't understand, but it's just, you got to figure out a new way to go. You're level, you're on the level, you're there. Once you start building from that level, you can do a whole lot if you have the right backing. The backing I'm talking about is individuals that know what they're doing with helping people through Medicaid services to make sure that these individuals become more successful. Maybe not as much as they want to be, but, you know, people have to understand that, you know, how important these, you know, these therapies and things that is done to help individuals. But what else here? So I've learned a lot of things back. In 2006, I graduated from the TBI waiver and became, again, employed with Minds Matter. I'm a cognitive therapist now. I left Minds Matter and came back with some other consumers that I worked with that left, but I've been the last, well, almost 15 years as a cognitive therapist, and I am on the, I'm on Medicaid services and Working Healthy, and you know, I follow the rules that's set forth, and you know, every day is a struggle, you know, with many different aspects of how I live my life, but I have learned how to become independently okay, yet, you know, it's a challenge, you know. There's different things in my life that just are really difficult, but I have support. Again, Minds Matter, and, you know, the people that I, you know and have known for all these years, you know, they come to my rescue if I need it, but most of the time I don't, but yet they're there and I know that. And I have a very good support system that keeps me, you know, okay, you know, friends and family that, you know, I can turn to get assistance or whatever to figure things out. But let's see, I now work as a cognitive therapist, and I don't know if I said that already, brain injury. But I help the people, you know, with problem solving, helping them to figure out options. Being proactive rather than reactive is so important in life, and people, so many times, they just wait till the last minute and say, oh, I got to do this, and all of a sudden, you know, their options are very limited, and it makes it, you know, impossible to, you know, have a good outcome. But outcomes are really important, and that has a lot to do with, well, with my previous, you know, my life before, you know, being project management, but yet understanding how important it is to, you know, assist people to help them find their way in the Medicaid services. And there's so many different, you know, hoops and hurdles that people have to, you know, obtain to be able to, you know, figure out where to go next. And, you know, I've had, I don't know, maybe 100 people I've worked with in the last 20 years, but in that time, I've never had anybody the same. You know, everybody has different issues that they deal with, and, you know, just trying to, you know, it takes special people to be able to help these people understand how important, you know, the next step is, you know, the next step in their total, you know, achievement of a goal. You know, step, 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 small steps at a time. And some people can do better than others, but, you know, it may be 6 months for one individual and 3 weeks for another. You never know. It's just one of those things. But I'm really happy with being able to be here today. And I'm glad that everyone is here to listen to just a little bit of what I feel that I'm successful in life because of being able to come to realization of how important this work is. Without Medicaid services being so effective in how I became, you know, independently okay, it's just, I don't know where I'd be, you know, without it. But, you know, 27 years ago, I was in a fog and just basically a mess, but today I'm able to, you know, live independently, and you know, I enjoy being part of a positive assistance to individuals that are on Medicaid services. And anyway, by the way, my name's Kevin Wadsworth. I don't think I said that.
Good, very good.
And
Thank you.
really appreciate you all listening to me.
Very
Do you have any
good, thank
questions
you.
for me?
Committee, questions? Thank you for being here.
Yep. All right, thank you.
Okay, we have Rachel Zinn. Rachel, welcome to committee.
Hello, my name is Rachel, and this is my sister Mandy, who unfortunately could not be with us today, but whose story I'd like to share. In 2009, when Mandy was 17 years old, our worlds were turned upside down when she was involved in a car accident after her car hit a patch of ice on the highway that would result in her having a severe traumatic brain injury, changing the trajectory of her young life forever and reshaping life as our family knew it. The next year of our lives consisted of several weeks in the ICU, followed by intensive rehabilitation, all of which were benefits covered under our mother's insurance plan through her employer. When we returned home from the year of rehab, Mandy was technically now an adult and would need health coverage of her own. She had severe challenges and would not be able to access health care coverage through traditional means, so we turned to Kansas Medicaid. Anyone in the brain injury world knows that just because someone returns home from rehab does not mean their recovery is complete. We know there's a lot of work left to do. Because of the wonderful brain injury waiver services that Kansans are fortunate enough to access through the home and community-based services programs, Mandy was able to regain so much of what many of us typically take for granted on a daily basis. Because there was not a waiting list to receive HCBS and TBI waiver services, she was able to quickly continue her recovery journey and receive the services that allowed her to continue healing at home without a long gap where progress could have been lost. She had her own apartment with 24/7 care, which allowed her to receive several years of valuable therapy services and allowed her to take part in her community. She volunteered at a thrift store, joined a special needs activity group, and participated in a special populations choir program. She would have never been granted these opportunities had it not been for the TBI waiver services that allowed her to regain and relearn the skills needed to participate in such meaningful activities. To conclude, I would like to leave the decision makers in this room with a message to consider. Mandy's life was turned completely upside down by something so seemingly simple as tires sliding on ice. Similarly, thousands of others' lives could also be turned upside down by something so seemingly simple as signatures on a piece of paper approving any changes to services that are the lifeline for so many people. My hope is that you'll receive the stories you've heard today with an open heart and an open mind, and that you'll gain a better understanding of how important Medicaid programs and services are to your fellow Kansans and Americans. We appreciate your ongoing efforts in protecting HCBS funding and disabled Kansans, and thank you for taking the time today to learn who we are and how these programs have benefited thousands and why it's so critical to maintain and improve these systems. Thank you.
Very good. Thank you, Rachel. Committee questions? Thank you again for being here.
Thank you.
Yeah. Okay, committee, that concludes our in-person testimony. I'll bring your attention to, on our sheet and in your files here, there are quite a few written-only testimony from KanCare folks. And then I would need a motion to approve I don't need to approve any minutes. Okay. My note, which don't try to confuse me, minute approval in October. Well, that's a couple months away. But I might have figured that one out. But they don't take any chances. So, okay, very good. Committee, anything else? And I want to thank all of you for taking your time to come up here One thing I will tell you, and many of you know, is we do have virtual availability. So you can testify from your home via WebEx or whatever too. So in cases where you don't or aren't able to drive or don't feel like it, we do have that ability too. So don't be afraid to take advantage of that. But thank you very much. We've heard a lot of great stories, and this committee does take these very